Very good morning to all of you. I welcome you all for this 10th ASU Professor H.S. Bhat workshop on bleeding in urology. There's a small change in the program. We'll have the first session, which will be followed by the inaugural program. So now for this session, I'll invite Dr. Dharmarajan sir, Dr. Shivalingaya, Dr. Nishchit to chair the session. Hand mic.
Good morning, everyone. On behalf of ourselves and on behalf of the Trichy Renal Sciences Club, we invite you and welcome you all for this midterm CME of the ASU in the honor of Professor H.S. Bhat. The topic selected today is very interesting and will be of much use to all. The bleeding in urology. Bleeding is a nightmare, not only for us, but also to all the surgeons around the globe. While preparing a patient for surgery, we expect or anticipate bleeding in certain cases, and we proceed. Those are in the scenario are: one, we are preparing a patient who is having already a coagulopathy for surgery, or patients on blood thinners for surgery, or you are operating on a complicated case where you expect bleeding on the table without any reason. You are some complex surgery like a multiple puncture in PCNL or gross adhesions with nephrectomy. There we anticipate. But there is another scenario where we don't anticipate bleeding, but still there is a bleeding on the table as a surprise, which may be due to an underlying coagulopathy which is missed or which is very subclinical, undetected by all the investigations, which become precipitated on the table either due to hypothermia or hypotension or some other reasons. And number two, vascular accidents on the table. These are the two scenarios where we don't anticipate bleeding on the table. The first session is on hemorrhage and hemostasis. This is the most important part of the today's lecture, where we can prepare the patient and do a safe surgery. And we have got 4 papers in this session. Without wasting time, let me call the opening batsman, Dr. Suresh Bhat from Kottayam, to enlighten us about the evaluation of microscopic hematuria. Thank you. Over to the speaker.
Good morning. I thank the ASU for giving me this opportunity to speak on evaluation of microscopic hematuria. Visible hematuria is an alarming symptom, often leading to anxiety, fear, and panic. Whereas microscopic hematuria is incidentally detected and often conveniently ignored and neglected, often leading to serious consequences. Whatever may be, whether it is visible hematuria, microscopic hematuria, whether the patient is on blood thinners or not, evaluation is mandated to find out what is causing this. And we have to remember that to produce gross hematuria, all that is required is 5 ml of blood in 1 liter of urine. That produces gross visible hematuria. And what is the definition of, we all know what is the definition of microscopic hematuria, anything more than 3 RBCs per high power field. And this is based on a study of consisting of 46,000 patients. And in this trial, a threshold of 3 to 10 RBCs per high power field had the highest sensitivity and the lowest negative risk ratio for detection of CA bladder. That's why this more than 3 RBCs per high power field. But what's important is how the urine is collected. It has to be appropriately collected after cleaning, midstream like that. If it is not possible, catheterization has to be done. And nowadays only single sample is required. Earlier it was 3 because it has been shown that with a single sample 95% of the microhematuria could be detected. And the second and third sample had only additional 5%. And one should not should not rely only on dipstick because it has got lots of false positives like contamination with the powdered and iodine and semen. And if we take the urine for examination after exercise, during menstruation or immediately after menstruation or after instrumentation, all this can produce false positive results. And the urine should not be too dilute, that can lead to lysis of the RBC, and should not be too concentrated, especially early morning. First void urine is concentrated, so early morning urine also should not be given. False positive will be there. So collection of urine is also very important. And the prevalence is 2 to 20% higher in elderly patients and those who have got associated risk factors. And what is the significance of microscopic hematuria? Because it could be associated with the severe life-threatening diseases like bladder cancer, RCC, CA prostate, upper tract TCC, and aortic aneurysm. It can also be associated with significant conditions which require surgery like urolithiasis, BPH, VUR, UTI, renovascular hypertension, or maybe due to significant requiring only observation like radiation cystitis, neurogenic bladder, polycystic kidney, or maybe inconsequential like a caruncle polyp or cystocele. So our idea is to find out what is causing based on this differential diagnosis. And the most important significance is because it is associated with the malignancy, genitourinary malignancy. Whereas gross hematuria is associated 20% of the time, microscopic hematuria is associated with malignancy only in 5.2% of the time. Whereas CA bladder is the most common, 4.8%. RCC 0.3% and upper tract urothelial malignancy only 1.1%, whereas urolithiasis is 8%, BPH around 4 to 52% and stricture less than 1%. So these are the common associated conditions with the microscopic hematuria. But the sad part is that only 23% received any imaging, and even less than that, only 13% received cystoscopy for those patients who had microscopic hematuria, often missing very serious problems. So we have to know the risk factors which are associated with malignancy like male gender, age more than 35, past or current smoking, which is the most important, occupation with exposure to chemical or dyes, analgesic abuse. So there are so many risk factors which have to take during our history taking. And evaluation of microscopic hematuria, as I told, mainly to find out what is causing it. The history should whether the patient is on antiplatelets or anticoagulants, any abdominal pain which may be due to stone or malignancy, lower urinary tract due to BPH, stone, BPH, malignancy, stricture, or prior instrumentation, pelvic organ prolapse, prior surgeries, or some conditions which may be associated with the nephrological diseases like CKD, PCKD, deafness with Alport syndrome, or hemoptysis. All these things we'll have to ask during history taking. And examination mainly for CKD is pallor, blood pressure, pudor edema, puffiness of the face, other features of CKD, abdominal mass, genital examination mostly for DR, for any BPH, CA prostate, pelvic organ prolapse, urethral prolapse, caruncle. So all this should be looked for during examination. And the most important thing, whether this hematuria is due to nephrological or urological, which is very easy. Based on the color itself, whether if it is urological one, it is fresh blood, whereas it is nephrological, it will be cola colored. And in urological diseases, it will be isomorphic RBC, whereas it in nephrologic, it will be dysmorphic. Anything more than 17% of dysmorphic RBC is significant. There will not be any cause of proteinuria in urological disease, well, these will be present in nephrological diseases. So these are the various points we'll have to look for. And appropriately, we'll have to refer him to nephrology if there are nephrological indicators. Now, before management, we'll have to risk strat, which is the most important thing. Risk stratify these patients. This is a hematuria risk index based on 4,500 patients. So maybe low risk, intermediate risk, and high risk. Low risk, all these parameters should be there. Women less than 50, male less than 40, non-smoker or smokes less than 10 pack, 3 to 10 RBCs, and no risk factors. So all these factors should be there, then it is a low risk factor. Intermediate, any of these factors enough. Women 50 to 59, male 40 to 59, 10 to 30 pack years, 11 to 25 RBCs, and low risk factors associated, low risk, intermediate risk, that is a low risk with the additional risk factors. So any of these is enough. And for high risk, women more than 60, men more than 60 years, more than 30 pack years, and more than 25 years, 25 RBCs, and gross hematuria. So before evaluating, we'll have to risk stratify like this. So low risk factor, then it is a shared decision. So two options are there for low risk factor. That is either do another urine routine examination within the next 6 months, or we can discuss the patient and either get an ultrasound done or a erythrocystoscopy, because the chance of pickup of malignancy is very, very less than 0.1%. And imaging 25% false positive will be there. American Urogynecology recommends that for asymptomatic low risk patient, it is more than 25 RBCs, not 10. For them, it is more than 25. Then only they will evaluate. Intermediate risk, ultrasound is mandatory. CT is not good, because this whether to do a CECT or ultrasound, it is based on the DETECT study, which showed that can renal ultrasound replace CT urogram? Yes, that is the answer, yes. Because microscopic hematuria is associated only 0.4% of RCCs, but no upper tract urothelial malignancy. So we can safely avoid CECT and we can replace it with the ultrasound. High risk patient, imaging is mandatory, cystoscopy is also mandatory. All that is required, white cystoscopy, white light cystoscopy, that's all what's required. Urine cytology, in the initial evaluation, unless risk factors are there, it's not required. Risk factors which I have already detailed earlier, or patient has got more of a storage symptoms, which is indicative of a carcinoma in situ. So in such patients, we will have to do a cytology. Cytology, sensitivity is 57, specificity is 94 point, and negative predictive value is 97.9. And no bladder cancer or upper tract was diagnosed based on a suspicious cytology. And follow up, if the initial evaluation was negative, get another evaluation after 1 year. Even if that is also negative, no further evaluation is required. If the initial was negative, at the end of first year it is positive, then you have to have a shared decision with the patient whether to proceed or not. Prior negative microscopic evaluation and the patient has the following: gross hematuria, other symptoms like, then we will have to do axial imaging and cystoscopy. So that is the follow-up. And summary, don't depend on dipstick alone. Risk stratify before proceeding. Identify the risk factors. A proper history and examination is mandatory. And the cornerstones are ultrasound, CT and cystoscopy. Thank you.
Thank you very much, Professor Suresh Bhat sir, for your statistical analysis and as well as risk modifications. So without wasting time, thank you very much. I will call upon the next speaker.
Thank you.
Questions afterwards or same time? Yeah, any clarifications and
Yes.
The course of evaluation, we found a small word of evidence. You have to put that to
No, you'll have to risk stratify again. See whether you'll have to identify all the risk factors. Yeah, you know, you have done an ultrasound, that's enough. Ultrasound would have picked up this 4 millimeter stone. Not required, unless he falls into the high risk category. Then probably, yeah, smoker, yeah. Yeah, that is most important cause is UTI nephrological causes. That phase contrast, you tell them they will do. More than 17%, it's significant. Refer them.
Yes, Colonel, sir.
Smoking only, the AU guidelines is only smoking only. They are not mentioning anything about other this tobacco. Only smoking they are mentioning.
Person who is reporting about the type of RBC, whether it is dysmorphic or allometric, do you specifically ask for it? Because all pathologists or all people don't give that information.
Because other symptoms will be there, sir. Other symptom, puffing of the face, hypertension, then RBC cast will be there. That is more important. RBC cast, proteinuria will be there. Unnecessary, you will have to ask for the contrast, face contrast, you will have to ask. That will cost another some 1,000 rupees.
Thank you very much. Yes.
I told you 5 ml. That I don't know. That I don't know how much you will have to find out. We'll have to 5 ml of your means of per ml it is 1,000. So 5 ml means it is 5,000. Yes, 5,000.
Thank you, sir.
5,000 ml.
Thank you for the good discussion. So we'll move on to the next topic, like peri-op management of patients with bleeding diabetes. I am call upon Dr. Uday Kulkarni, hematologist from CMC Vellore. Over to Dr. Uday Kulkarni, sir. Please, your time is allotted 15 minutes. Stick on to this, sir.
Really grateful for the organizers. Yeah, slightly lower. I think I'll stand down. Yeah. Thank you. I think really grateful for this opportunity to meet all of you. So this is the cell-based model of coagulation, which is the current understanding of how the coagulation pathway works. It's too complicated, and we'll stick to the coagulation cascade, which was a previous model. Essentially showing the intrinsic pathway and the extrinsic pathway, both leading to merging onto the common pathway, and that leading to the fibrinogen conversion to a fibrin clot. So this also helps us understand that you can use the activated partial thromboplastin time to gauge any defects in the intrinsic pathway and the common pathway. The prothrombin time essentially will reflect abnormalities in the extrinsic and the common pathway. So this understanding is important, and we'll see subsequently how we use it in the clinic. So another important thing is all coagulation testing is done on plasma and not serum, because serum is plasma minus the clotting factors. So everything is done on a citrated tube. So in preoperative management or perioperative management of bleeding disorder, the first step is confirming the diagnosis of the bleeding disorder. And in that, we generally follow taking a detailed history and a physical examination. In that, there are certain pointers towards a specific bleeding disorder. So for example, if there's a patient who has recurrent mucocutaneous bleeding, then it would suggest that there is a primary hemostatic defect. So either platelet number, platelet function, or von Willebrand factor defects are primary hemostatic disorders. If patient is having recurrent deep hematomas, it would indicate that there is a secondary hemostatic defect, essentially factor deficiencies. So whether there is a defect in the primary hemostasis or the secondary hemostatic defect are generally evident on the history of the patient. We also take a detailed history on what precipitating factors were there for the bleeding, whether there was any treatment that was required, whether patients have undergone a past hemostatic challenge. So if somebody has undergone a normal delivery in the past, very unlikely that they will have a significant hemostatic disorder, inherited disorder. Similarly, we would take a detailed drug history, whether they are on antiplatelets, anticoagulation, any complementary medications, family history of a similar illness, whether they have any consanguinity, comorbidities like liver disease, endocrine disorders, and connective tissue disorders. And in physical examination, we look for if they have obvious joint deformities, it would indicate a secondary hemostatic defect. So either hemophilia or von Willebrand disease would be suspected. If they have recurrent petechiae or purpuric or echinotic patches, it would indicate that they have a either a defect of the platelet numbers or function. So we follow that up with doing a complete blood counts with peripheral smear, and here many patients from the eastern part of the country have giant platelets. So the Coulter sort of underestimates the platelet count. We have to look at the peripheral smear and give importance to history and physical examination. So if history is very unlikely that there are no patient did not have any previous bleeding episodes or has had a hemostatic challenge and has did not have any excessive bleeding during that time, even if the platelet count on the Coulter comes low, we would dig more into it. We would look at the smear to see whether there are any giant platelets, because extremely unlikely that they'll have true thrombocytopenia there. Sometimes we pick up these EDT-induced platelet aggregation also on the smear. So a complete blood count with a peripheral smear is important. Subsequent testing, if the platelet counts are normal, we do a complete coagulation workup in those individuals who have significant bleeding in the past. So if they have had multiple bleeding episodes or excessive bleeding during surgery, or whether they have required a transfusion because of during the bleeding episode, we consider that as significant, and we do a complete coagulation workup, which includes all the factor assays. So if the factor assays, everything comes normal, we also evaluate for platelet function tests. So if the platelet numbers might be normal, but if there is a significant bleeding history, the platelet numbers are normal and the factor assays are also normal, we look at platelet function. So that's how we evaluate these patients. And if there is a factor deficiency identified, we qualify it further by doing an inhibitor assay. So it's important to know whether patient is having severe hemophilia, whether they have additional inhibitors or not, because the entire management perioperatively changes with that information. So we need to know, if first diagnose the condition, whether what kind of bleeding disorder it is, whether it's a primary hemostatic defect or a secondary one. Within these, what exactly is the diagnosis based on these factor assays, and if at all they have hemophilia, whether they have, in addition to that, whether inhibitors are there or not. So that's the step one of this evaluation. So now, assuming that we know what the inherited bleeding disorder is, we move on. So before that, just to have the summary of interpretation of coagulation test. So if there is isolated APTT prolongation, and we generally take a history where if patient is already on heparin contamination itself will lead to prolonged APTT, which will not correct on the when we add pooled normal plasma. Similarly, lupus anticoagulant, we see very commonly patients who don't have any bleeding history. If their APTT is prolonged and it is not correcting, in absence of any clinical history, lupus anticoagulant can explain the prolonged APTT in many patients. The other causes of prolonged APTT would include hemophilia, either A, B, or C, and von Willebrand disease. If there is isolated PT prolongation, if the patient is not on any drug like warfarin, we would consider ruling out factor 7 deficiency. If both PT and APTT are prolonged and if they are not on the novel oral anticoagulants, we would consider sepsis and liver disease, DIC, as common causes. After ruling those out, fibrinogen disorders, inherited disorders of fibrinogen, can cause both both PT and APTT being prolonged. So now, assuming that we have a diagnosis of an inherited bleeding disorder already established, and we have to take up these patients for surgery, what we do is the planning of the support depends on what is the half-life of the factor. So for example, if it's hemophilia A, then the half-life of factor 8 is 12 hours. So we have to give factors twice daily. If it is hemophilia B, we can give once daily. Beyond that also, if there are extended half-life factors which are available. So even in hemophilia A, we can give factors which are short-acting or long-acting, which can be given less frequently. So that, and the patient's weight. So depending upon that, we arrange for factors. So suppose we are planning a surgery for a patient with inherited bleeding disorder, we would arrange the factors. So we would calculate how much factor support would be required for that patient for 14 days if it's a major surgery, and procure those factors. So either the factors we get from the hemophilia society sometimes, or in certain situations the patient buys the factors. So just to give you an example, if there is a major surgery in a patient with hemophilia, who does not have any inhibitors, the approximate use of factors is in the range of 300 to 450 units per kg for the entire surgery. And the cost of these short acting factors are around 10 rupees per unit. So the additional cost towards the factors comes to around 2 to 3 lakhs for a major surgery. And there are common brands which are available, which can be bought. There are certain extended release factors which are also available. They are much more costlier. But the benefit of these extended half-life factors is you can give it less frequently. You can give it, either if for hemophilia A, if you have to give twice daily, you can cut it down to once daily. Now, if you are planning a surgery for a patient with platelet function disorder, we need to arrange for platelets, and we need to know that the platelet storage can be done only for 5 days. So we arrange for donors, ask them to give directed donor platelets and store it so that we can plan surgery and have the support continued post-operatively also. Platelets are stored at 22 degrees and the factors we keep it in the fridge at 2 to 8. So, depending upon what the diagnosis of the inherited disorder is, there is a perioperative hemostatic agent that we use. So we arrange these agents, appropriate agents. So if it's hemophilia A or B without inhibitors, factor 8 or 9 is arranged. If they have inhibitors, then there are bypassing agents, recombinant factor 7A or factor 8 bypassing agent, which is arranged. And similarly for platelet function disorders, platelet-rich concentrates or single donor platelets. And in Glanzmann's, in addition to platelets, we also give recombinant factor 7A. Now, what happens on the day of the surgery is we coordinate with the surgical team, the hematologist and the lab, coordinate with each other, and we give the factor support 2 hours prior to the surgery. After giving the factors, we check a recovery, how much recovery has happened. And if that is appropriate, then we clear the patient for the surgery. And so the sample is sent about 15 to 20 minutes later after giving the factors in the morning. Then we also follow up with the surgeon about the blood loss, the duration of the surgery, and if there is any unexpected bleeding during the surgery, we would give additional factors at that time. So the normal level of factor is 50 to 150%. Anything above 50% is actually within the normal limit. So just to tell you, even the definition of mild hemophilia is when the factor is less than 40%. So between 40 and 50 is a gray zone. So anything beyond 50 is definitely very adequate. So 100% throughout the post-surgical period is generally not required. So for the first few days, we would give 100%. Subsequently, we cut down the trough level. So I'll go through that subsequently. And in post-op bleeding, it's not necessarily the factor deficiency. We also look for local causes and sepsis. So this is the recommendation from the World Hemophilia Federation, and there are guidelines as to what is the appropriate preoperative level of the factors with which we can go ahead with the surgery, and also post-operatively between say day 1 to 3, 4 to 6, and 7 to 14, what are the target trough levels that we need to achieve in a major surgery. So as you can see, there is a high dose practice and there is a low dose practice, and we at our center we've pioneered this low dose protocol, and that results in reduction in the cost for the surgeries, and without any excessive bleeding. Similar to what we saw in the factor support required for patients without inhibitors, if they have inhibitors, there are certain targets that are prescribed for FIBA as well as for recombinant 7A, and we adhere to that when we are planning these surgical interventions. So just to give you an example, so if we want to achieve for a patient with hemophilia, we want to clear the patient if we achieve 80% factor level, we would calculate it by 1 unit per kg, raises the factor level by 2%. So if for 50 kg person, we would give 2000 units in the morning, check a recovery after 15 minutes, and if that's adequate, we would clear the patient. For factor 9, 1 unit per kg raises by 1%. So for a 50 kg person, it will be 50 into 80, 4000. So it's double the dose as compared to factor 8. And so this is the general calculation that we do for managing patients during this period. So coming to supportive care so most of these patients with inherited bleeding disorders, during the surgery itself, we ask the anesthetist to put in a central line, which can be kept post-operatively, because otherwise giving them factors or daily pricking them for sampling becomes very difficult. So get a central line done, we get daily hemoglobin monitoring. If, not for urinary tract bleeding, but in other surgeries, we give tranexamic acid. We strictly write in the chart no intravascular injections for these patients, and we don't give any non-steroidal anti-inflammatory drugs. For pain, just paracetamol and tramadol, if required, a fentanyl patch. So no diclofenac or any other NSAIDs are given for these patients. And monitoring we would do with factor assays, or in patients with inhibitors or platelet disorders, we use thromboelastography, which is global hemostasis assay, which can tell us whether there is any product support required. And this monitoring is done on days 1, 3, 5, and 7, and we gradually, as I showed you, cut down on the factor support. In case of any bleeding or drop in the hemoglobin, we always look for the local cause, and we would also look for sepsis, DIC in situations. If there is a drop in the factor level, sometimes these patients post-operatively can develop inhibitors. So we have to test for those inhibitors and give appropriate bypassing agents. Sometimes with hemophilia surgery, if everything is going on smooth, suddenly there is bleeding, then factor levels have dropped. They might have developed inhibitors to the factors. So that is a possibility. So with that, I would like to end my talk. Thank you for your attention. I'm happy to take questions if any.
Thank you, sir, for a wonderful description of how to go about perioperative management of a patient with bleeding diathesis. Sir,
Yeah.
I just
Dr. Uday, I got a very simple basic question. What is the role of this bleeding time, clotting time, the PT in the pre-operative workup? Because it's going to be a perioperative thing. Every surgeon is doing it. Is there any role, or what you would advise as a hematologist in the pre-operative workup of a patient?
So for surgeries, the bleeding time and clotting time do not have any role as of now. History and physical examination is, if there is no, as I said, that there is a ISTH bad scoring, which is there is a tool which has different components, and depending upon the bleeding history, if patients have undergone a past hemostatic challenge, it essentially rules out any significant disorder. Routine preoperative testing with PTA-PT is generally not required. It's required if there is a bleeding history. In that situation, it would be required.
Yes, sir. Yes. Next question.
regarding one of your slides, sir. You told tranexamic acid to be avoided and urinary tract bleeding.
Yes.
So one is why previously I used to use it, and recently I had a very bad experience. After nearly 7 to 8 years, I had a very bad experience. So why not to use it? And second thing is, any other agent is available in post-operative urinary tract bleeding. Any other agent is available to reduce the bleeding.
Yeah, so basically in tranexamic acid would probably lead to more blood clots in the urinary system. That's why we avoid any agents that would potentially reduce. If there is any excessive bleeding, we would again evaluate with the basic coagulation test. Obviously, the local cause has to be ruled out first. Beyond that, we would do a hemoglobin, platelet count, PT-APT fibrinogen, and would correct that coagulopathy, whatever, if there is any.
Before endourological procedures,
Yeah.
we do a pre-op workup. Pre-op workup is normal. So intraoperatively we develop a bleeding scenario. So any other agent other than tranexamic acid, any other agent is there which can stop the bleeding. Excluding, of course, sepsis usually there, and pre-operatively we manage. Any other agent is there for me.
I mean, if there is no local cause identified, I think we would just give transfusion support. Push to the corner, we sometimes use recombinant factor 7A. Not
no-
really evidence based.
No newer agent as such.
Not
Dr.
that I'm aware of.
Yeah.
Not that I'm aware
Yeah,
of.
yeah, yes, Ganesh, sir.
Yeah, this is just a follow-up on what Dr. Kannan was asking. There is a tendency today for every case a coagulation profile is done, especially from the anesthetist side when a spinal is given.
Mike near your lip.
When a spinal is given. Is it justified?
It's not justified. I think if there are certain situations, like if there's a lady who has undergone a normal delivery in the past, obviously it essentially rules out an inherited bleeding disorder.
That is one. Second thing is, in certain cases of sepsis, sometimes we have a patient with a coagulation disorder, sepsis induced. Patient is sensitive only to cephalosporins, which again can disturb the coagulation pathway. So what do you do in such a situation?
So acquired, I didn't deal with the acquired coagulopathy in the current discussion, but in acquired coagulopathy, essentially we try to target a normal coagulation parameter. So if there is any derangement in the prothrombin time or the APDT, we would give FFP. So if there is a patient with liver disease now, there is role of doing a thromboelastography and giving product support based on the TEG, which is a global hemostasis assay. Beyond that, I think there is nothing, specifically that we would do in acquired coagulation disorders.
No, especially in the septic patient.
Sepsis, generally we see fibrinogen being low or, platelet dysfunction, platelets going down. But in sepsis-induced thrombocytopenia, not too bad. It's generally in the range of 50,000. The platelets would not be very bad to require supports. What we have seen is derangement in fibrinogen. So the fibrinogen levels drop sometimes in sepsis. That you might have to correct giving cryoprecipitate.
Yeah, next
So
question.
we often operate on patients who are on anticoagulants like clopidogrel, ecosprin, or acetron. So what is the best preoperative lab test which is required in these patients?
So basically, it's recommended that if there's a major surgery, take off all these antiplatelets 1 week prior if feasible. That's what is recommended. I guess the subsequent talk is on patients on antiplatelets and
Next
anticoagulation.
talk
I
will be
suppose
there.
that would cover more.
Yes, HK sir.
Sometimes when we do a consult the procedure of the prostate pregnancy, there is a belief that there is going to be a lot of fibrolysis which are released into the system and they develop AIC. So, what do we do at that situation?
If
Anti-fibrinolysis is available except the classic.
EACA is another option, but I think we do the coagulation parameters and correct whatever the abnormality is. That works better than any of these agents. That's what we have seen in the past. So giving if the fibrinogen levels have dropped, we would give cryoprecipitate in that scenario. That seems to probably work the best.
Yeah. Dr. Uday, you said something consanguineous marriages in the history.
Yes.
Yeah, what does it implies? Like, what's the role on this bleeding?
So most of these bleeding disorders are common in consanguineous. If you have Glanzmann's thrombosthenia, platelet function disorders are also very common in patients who have consanguinity in the family. So those are the disorders that we are talking about.
Yeah, in hemophilia patients, if you correct on per-op and post-op also, like what's the chances of secondary hemorrhage in a major surgery with the hemophilia patients? Once it's corrected, like what percentage of...
I don't recollect what's the... I think it's there in our publication. I don't recollect the exact percentages, but we do see it quite sometimes, often when patients are on this factor support, they will have breakthrough bleeding, and that's what I alluded to in the discussion also. Generally, it's the local cause that we would like to rule out first. Beyond that, sepsis and as regards the factor support, some of them develop inhibitors. So we do a factor trough if the factor trough has dropped. So for example, if I expect a factor trough which is say 30%.
When during the
post-op period and suddenly the factor trough comes to say 1%.
Okay.
Then that's a problem. Then we it could be either the potency of the factors, we have not stored the factors appropriately and the potency is low, that is why the factor the factor trough has dropped, or other possibilities whether they have developed inhibitors. So that's the time when we order a inhibitor screen or a Bethesda assay, and if they have developed inhibitors, we would change the product support from factors to giving bypassing agents.
Yeah, but some more clarification about inhibitors, like in what surgery, like duration, like suppose, if you don't correct on table, like what's the percentage of inhibitors developing in that individual? is that, see, because in urology, we
think
do
the-
more endosurgery as well as in,
So I think there are few inhibitors which develop with the glue which is used in surgical practice.
okay.
It's bovine, that is why there is development of, it's a foreign protein which is used and they develop inhibitors.
Okay.
But haven't seen that much in terms of, clinically, I mean, I've read up about it, but I mean, practically what we have seen is not much of, such acquired,
Yeah.
inhibitors. It's there that, it's reported that you use glue, it's bovine derived and you might get inhibitors post that. I haven't actually seen one.
Good. Yes, yes, Sridhar.
Yeah, I think the platelet count, I think generally for anything above 50,000 is good enough for most minor procedures. The major surgery, 80,000 would be good enough, I think, but it's obviously if patient is having fever, one would be very cautious, whether down the line the platelets drop further. So defer if possible, I think, if it's feasible. Correct. Yeah. I would probably clear if it is above 80,000, we would go ahead and any major surgery and then continue to monitor post-operatively, arrange for some donors and keep single donor platelets ready, ensure that the rest of the coagulation parameters are normal. I think that's what would be.
I think Dr. Kulkarni's message is that most of the practitioners are in a non-institutional setup. Sir is in a premier institution, and Sir says there's no evaluation required as such. But one thing, what the message is that please take one history of a previous bleeding episode during any time in his life. It is one additional history before any endoscopic surgery or biopsy, which may help us in a practical practice.
Thank you.
With this, we thank Sir, Dr. Uday Kulkarni for a wonderful talk. And we invite now Dr. Manohar from INU Bangalore to deliver his talk on preparation of patients on anticoagulants and antiplatelets for surgery.
Thank you, ASU, for giving me opportunity to present on this topic. We know that the interruption of the therapy can increase the thrombotic events and during and after surgery. The study conducted by Ivaco has clearly demonstrated stopping of the antiplatelet therapy can result in almost 30% of the thrombosis and 45% of mortality rate. So any patient with a perioperative cardiovascular risk and mortality, the first thing what we have to do is assessing the patient related risk factors and what the type of surgery or the procedure, whether it is an emergency or elective, or the experience of the institution. As the Dr. Nishit said, like experience with an institution with a cardiac backup definitely have a major role. And adequate preoperative evaluation is very important. So why we have to evaluate? Mainly to decrease the morbidity and mortality, including the death. So these are the most common anticoagulants and antiplatelet we routinely use in our practice, like warfarin, and nowadays the most common drugs like direct thrombin inhibitors with dabigatran, rivaroxaban is most commonly used as an anticoagulants, whereas with an antiplatelets like COX inhibitors like aspirin and clopidogrel, ticlopidine and prasugrel is the most common antiplatelet routinely used in our day-to-day practice. So who are these patients? We are going to treat the patient, like the patients who are on atrial fibrillation, mechanical heart valves, and the antiplatelet therapy with a PTCA or any CABG cases. So the preoperative assessment tools mainly includes the complete cardiac evaluation, including an ECG, biomarkers. If required, if the patient is elective, we have to do a coronary angiography also. Other than this, we have got a wonderful risk score. You can assess preoperatively the patient is what stage is in. So we require 4 factors deciding this interruption of antithrombotic drugs prior to surgery. First factor is the estimating the thromboembolic risk. Any patients with a recent thromboembolic event less than 3 months are definitely under higher risk. So these risk classifications we have in a scoring system called CHATS-2 score. If combined with what we call VAS score, this is the score system routinely used for the assessing the patient on this. If the patient got congestive heart failure, hypertension, more than 75 years, especially female gender, all will be score given 1. Anything more than it will be classified into lower, like the risk with 0 to 2, and higher risk with almost 5. And any patients with less than 3 months of vascular embolism, any history is there, the patients will be under higher risk. So the second factor is estimating the procedural bleeding risk before taking the patient. So we have gotten a Has-Bled score where we can evaluate the patient of any patient of more than age 65 years and with an history of any hypertension and stroke, bleeding, if the patient is already on NSAIDs or any aspirin and drug abuse and any alcohol, will have with an altered renal or liver function, who has gotten you can make a assessment with a scoring system of lower score with 0 to 1 and higher score of anything more than 3 will be higher risk of more than 5 to 10% of bleeding rates. So the American Society of Hematology has given a guidelines the managing this by applying as the algorithm. That is, first step we have to do is holding the anticoagulants. Followed by, if any antidote is there, you can given and try to give supportive treatment with an hemostatic measures. So how do we monitor these patients? We are going to monitor these patients mainly if the patients on warfarin, the INR is the most important, dabigatran with APTT and factor 10A inhibitors we can assess the serum factor anti-factor 10A and antiplatelet agents can also be monitored, but it is not available easily in our laboratories. So the fourth aspect is timing of anticoagulant interruption. So whether to bridge or not to bridge, and how to bridge. So as I mentioned, all the patients with lower risk category, the bridging is not required. Whereas the higher risk category, the bridging is required, and the most common what EAU recommends is usage of a low molecular weight heparin of 1 milligram per kg body weight, and EAU recommends an unfractionated heparin. So the bridging may be appropriate, especially what we see in the patients with warfarin. Most commonly, we have to bridge the therapy with the patients on any mitral valves, recent embolic strokes, or any recent coronary stenting. So this is the most important chart. Here you can see the patients can be classified into elective or emergency. So any patients in the elective, if you are in a higher risk, you are going to start, that is, if you want to plan for surgery, you are going to stop the warfarin at the that is last day will be given the 6th day, that is day 5 you are going to stop. On the day 3, we have to bridge with a low molecular heparin by giving 1 milligram per kg body weight, and on the day 1 you are going to test the INR, it should be less than 1.5. And if it is less than 1.5, you are going to stop 20 to 24 hours, that is 1 day before the surgery. The low molecular weight heparin will be stopped 1 day before the surgery. And on the day 0, once you operate, you assess any local hemostasis, whether it's completely or not. And on the day 1 and 3, you're going to resume the heparin bridging with hemostasis, whether it's secured, and you're going to start. And on the day 5 or 6, you're going to stop the low molecular weight heparin once the therapeutic INR is approached. So how to reverse this? Any patients like in the emergency cases, if it is less than 24 hours, we are going to start with a vitamin K based on the INR levels. Anything more than 9, we are going to give 10 mg stat. And if it is not able to cover up, we are going to repeat the dosage again, and followed by prothrombin concentrate complex can be given. If still not able to stop the bleeding, you can follow up with an FFP by giving 2 to 4 units of IV. So these are the drugs. If the other than warfarin, we got a novel oral anticoagulants. What we use routinely, we get a patients with a dabigatran or prasugrel. Like these patients will be again classified into immediate, elective, or all the patients will be first. We are going to assess the coagulation factors, and we can assess even the serum of oral anticoagulants, direct oral anticoagulants. And if you are planning for emergency surgery, try to prefer a general anesthesia to avoid the epidural hematoma. Whereas the patients on emergency basis, if you want to thing, what we have to do is, as a patient on thrombin inhibitor like dabigatran, there is a monoclonal antibody infusion, that is edoximab, it is available. And the patients with an evoxaban, what we use, most of the patients were on evoxaban, these patients can be given with an etaxet alpha, but very difficult, it is not available in India. So any patients on direct anticoagulant therapy, you can stop 1 day before for the low risk cases and 2 days before for higher risk cases. So again, the recommencing will be started almost 2 to 3 days after the surgery. So the most important thing is ensuring hemostasis is very important peroperative before starting this treatment. Coming to this antiplatelet management, we have to stop this antiplatelet management minimum of 5 days preoperatively, and these are the things, like if the aspirin is started, it's ideal to stop, as a COX-1 inhibitor it is ideal, it should be stopped 7 to 10 days, but there are recommendations of 75 mg can be continued. But if you can see the duration of last for clopidogrel and prasugrel, it will be last for almost 3 to 10 days, and 7 to 10 days with prasugrel and ticagrelor for 3 to 5 days. As per the AAC guidelines of 2022, in patients with prior any percutaneous intervention, aspirin can be continued of 75 mg. It is a level 1B evidence. And as I said, ticagrelor should be stopped 3 to 5 days, clopidogrel with 5 days, and prasugrel for 7 days as a level 1B evidence. And if the patient has not undergone any coronary surgeries, the interruption should be, at least of aspirin, should be stopped 3 days before the procedure. So to resume back any antiplatelet, if you have stopped, you can restart within 48 hours after the surgery. So this is the chart which showing the half-life of the aspirin, clopidogrel, prasugrel, and usually you can look at this. The study shows there is no continuous aspirin will be continued, whereas the other drugs can be stopped according to the half-life. So as the question asked for any antiplatelet reversal, absolutely there is no any specific reversible available. But the neurocritical care guidelines have used the desmopressin for intracranial hemorrhages. It was acted very well. So the study is going on, and we got a drug, the patients we see in the day-to-day practice of ticagrelor. The patient can come to us with a lot of bleeding. The study was recently conducted, presented in the American Association of Cardiology in the last year. The bendrasimab is a newer drug. It can reverse almost 90% of direct oral anticoagulants within an hour. So, and the role of transfusion of platelets, what we do routinely, like RDP or SGP, still it is unclear. So I would like to give take-home messages that current guidelines of cardiology recommends dual antiplatelet therapy, especially with AS and clopidogrel for minimum of 1 month and up to a year for treated metal stents. And as I said, aspirin can be continued. And in patients with dual antiplatelet, the procedure should be ideally postponed. However, if surgery, it can be deferred, but aspirin should be continued and clopidogrel should be stopped for 5 days before procedure. And warfarin should be stopped for 5 days, and the bridging with low molecular weight heparin or unfractionated heparin should be considered for high risk category. Thank you.
Yeah, thank you, Dr. Manor. Let's open for questions and yes, Ganesh sir. Mike, please.
Stopping aspirin,
Yes, sir.
especially for prostate surgeries.
Yes, sir.
But it is very difficult to predict the risk of bleeding.
Yes, sir.
Because you can never say when a prostate is going to bleed.
Yes, sir.
So what is the rationale presently
So the
advised?
thing is, first we would have explained to the patient, what they say is aspirin 75 mg should be continued, because the majority of the patients, what we see will be undergone PTCA. So these patients can easily go for stent thrombosis. That's what that assessing of this as blood score and what the chat score I told, the risk stratification, the thrombosis is so much. If you stop, if you're going to stop, almost the increasing of the death can occur almost within 30 days. That's what they say, almost 45%.
No, I'm not talking of the risk, high risk category. I'm
Yes,
talking
sir.
of a normal prostate patient.
Normal category, we
who
are
is
not
on
going to
conservative
stop.
treatment for ischemic heart disease. He is on a small dose of aspirin.
Yes, sir.
Previously, we used to stop aspirin 5 days before
Yes,
a
but
surgery.
actually it is not-
Presently, we don't do that.
Yes, we are not.
But at the same time, it is never, you can never predict how much prostate is going to bleed.
That is always is there. That's what we are going to do is we have discussed before itself now, sir. So we are going to discuss with the patient. Any patient with aspirin, even 75 mg can bleed like anything. That's what we see in our practice. But what I want to say is, like, what we transfuse the antiplatelets, all that, it usually not work, because the action of this aspirin will last for minimum 7 days. So until these 7 days lasts, the newer platelets should come to stop the bleeding, because the instability of this, once you start aspirin, even given a single day of aspirin, it will cause instability of the platelet so much, the reversal can occur only at 7 days.
Okay. Yeah. Yes, sir.
Yes, sir.
Yes.
Dr. Musalik from Madurai.
Yes,
just the first statement you said that the categorically, maybe my question looked a little bit paradoxical with related to the pharmacoprophylaxis of the thrombosis. So he said 3 months is a period, huh? First.
No, 3. What I am telling is that any emergency surgery, we should not stop actually dual platelet. If you're stopping and any platelet of one platelet, we should bridge within a one single anticoagulant, short-term anticoagulant, we have to give it. But why 3 months is minimum is, if there is any stent is there, the endothelialization of stent will require minimum 3 months.
I
That is the
believe
reason,
that is more of evidence based.
yeah, that is the reason we don't stop any antiplatelet or anticoagulants for first 3 months.
So say along that barring major urological procedures.
Yes, sir.
Normally, say for early post-operative period or late post-operative period, when you consider your starting of thromboprophylaxis, what's the maximum
yes,
period
yeah.
beyond which
See,
you may
that-
develop some early symptoms?
Yeah. So that depends on
What is your opinion?
Yeah. See, we usually in day-to-day practice we start minimum of after 5 days. But what they say is the guidelines says is, if the patient is on newer oral anticoagulant drugs, you can recommend after 2 to 3 days. But that again depends on what surgery the patient is on. Actually, I had one slide of showing there was a clinical survey conducted by Davis et al. He has clearly mentioned, he has clearly done the study on 1,100 patients where he had demonstrated all the minor surgery, all the anticoagulants was stopped for 4 to 5 days before procedure, and it was restarted again after 2 to 3 days, except major surgeries, and including TURP and DRPT was started after 5 days.
Okay, thank you.
Major surgery was started very early, but TURP and TURPT was started very late because of the risk phenomenon.
Yeah. Basically, I think we are balancing thrombotic risk versus hemorrhagic risk. Right?
Hemorrhagic, yes.
Hemorrhagic risk, most of us know when we operate a given procedure, how much of bleed can be there. And most of the bleeds from the urinary tract are not as bad as an intracranial bleed.
Yes.
Perhaps you would not like somebody developing a clot around the spinal cord when a spinal is given. But hematuria is very easy to manage.
Easy to manage.
But are there any clues, at least from urological point, from us, for we as urology clinician, how to predict this thrombotic risk? Which patient runs a higher risk of a thrombotic risk?
So that's
is
what-
it just that one of the things which you mentioned is dual platelet, antiplatelet therapy,
Yeah.
where you stop one and continue the other one?
Yes.
Are there any other clues which we have to take?
No, that the clues means we can assess whether the patient can go for thrombosis and can result in like stroke. I have mentioned
No,
that's
this is something which is very difficult to predict now.
Yes,
Who will
very
develop?
difficult to predict, yeah.
Very difficult.
Score will help us only to the whether the patient can go for bleeding, one score. The other score will help us, we can recommend the patient that he can result in higher thrombotic rate, and the stroke rates also can be assessed.
No, this is a separate group of patients who are not on any anticoagulants or antiplatelets,
Yes, sir.
but you are taking up a patient with a high thrombotic risk. For example, elderlies, obese, and with oncological surgery.
Yes.
Now, when you do those patients, you're going to start them on heparin, low molecular weight.
Yeah.
So you normally do it about 12 hours before the surgery
Yes,
or
sir.
previous night.
Yes, sir.
That is where we have a problem when we do endoscopic surgery.
Yeah. Yes.
See, if it's an open surgery, things are under control. But when to stop and when to restart is the question.
That's what that once our studies conducted by urology has clearly showed in that paper. All the major surgery was restarted within 3 to 5 days. But if you look at the TURPT was so delayed to start the ecosprin or that is almost 7 days, more than 7 days.
Yeah. I have two questions. Number one,
Yes, sir.
is there any drug to reverse low molecular weight heparin induced bleeding?
Low mark heparin induced bleeding, you can't reverse it because we have to wait because it's in a short. Its half life itself is 4 to 5 hours. So that's the reason we are going to stop before almost 20 to 24 hours before the procedure.
No, and post-operative
Yeah.
period, 12 hours after surgery, we are restarting.
Yes,
it.
yes.
Okay. If the patient bleeds and the quantum of bleeding is very high, how to manage that? We cannot reverse it.
We cannot reverse it.
Then
Initially.
anything other?
Nothing else. I don't know if Dr. Uday can tell any agents are there.
Protamine partially reverses.
Protamine.
I agree with you. Unfractionated, it will reverse
Yeah.
completely. But protamine, to some extent, at least, we give it practically. If there's
Yeah.
excessive bleeding after MWH, also no harm in giving it.
So in that
Doses
scenario,
we use 1 mg for
And even
equivalent
even the prothrombin complex concentrate, if available, I don't think it's easily available. That has got a partial of reversal, a little bit marginal.
Very excessive, then that recombinant 7A
Severe.
costs somewhere around 48,000 for 1 mg vial. So that is what we use in excessive bleeding without any other agent available.
Even what I said that Idruximab, it's almost cost around 2.5 lakhs to give that.
Per dose.
One dose. But the drug, there is the patient on this ticagrelor, we see routinely in our practice. If the patient is on Prasuda, that is a standard company, he gives free. If the patient is on dabigatran with bleeding of that drug, due to that, he'll give free supply of the monoclonal antibody of Idruximab freely. But not other routine, what we got Indian companies, they will not provide.
Okay. Number 2 is there any guidelines for endourological procedures? Just the patient is obese and morbidly obese patient.
No,
is there
what-
any guidelines for starting this?
See what, there is no exact guidelines, but what EAU recommends, if the patient is obese with I told about the scoring factor. If you look at the scoring factor,
Without any
majority
comorbidities.
will be under 0 to 2, it will come.
You know,
Okay.
most of nowadays all are obese.
Yeah, that's
more
what
than
I'm telling
100
you.
Without comorbidities.
Without comorbidities, you have to assess the patient, because if the family, that's what I told, age factor also comes a role very much. So 0 to score, if it is under lower risk, usually we are going to try to avoid.
Okay.
Only the intermediate and higher risk, we are going to start the treatment.
Thank you.
Stockings, yes. So that is for the venous. So we were, all these factors are mainly on even the arterial aspects.
Thank you.
Yes, thank you.
Thank you. Thank you, Dr.
Thank you,
Manohar. Friends, we recognize the presence of the Dean, Tiruchi Medical College, Dr. Nehru, who has come here for the inaugural function. Now I call upon Dr. Santosh from CMC Vellore to discuss about the hemostatic agents and their use during perioperative bleeding.
Good morning. Thank you, organizers, for calling me. It's a very long presentation for about 1 hour with more than 100 slides, and Surya has told me to cut down. So all the indications, all the contraindications, and all the side effects have been cut down. The more than 80 products in 8 minutes, I don't know how much we can see, how much we can do. Very interesting videos are there on YouTube for each and every product. So each product, if you are interested in seeing, please go to YouTube. What you will get is how effective the products are. What you will not get is what exactly is there in the product. So that's the problem, because all these things, and also when some product is very popular, it changes hands. So somebody buys it off, like Covidin buys it off, or some Baxter buys it off, and then the companies change. You will never know what is exactly in each of these products. So with that basis, I will come. There is no substitute to good surgical technique. All the talking we are doing today, somewhere in the back of the mind that we think that any of these things are the cause. But there is absolutely no substitute to a good surgical technique. So when you're doing your surgery, tie off all the vessels, hemostat them, make sure the hemostasis is good. Do not rely on anything else. But unfortunately, when there's too much of blood loss, there's hemodilution. With that comes acquired platelet dysfunction, factor consumption, hypothermia when the surgery has gone on long, the abdomen has been opened for a long time, and fibrinolytic pathways get activated. Because of this, what normally a body could heal or recover, at times is not able to do, and we are forced to use these agents. So it is not a substitute, but it's an adjuvant to good surgical technique. Thanks to Uday, he has explained all this. I'm sure you have all understood. All I want to say is we only use these terminal products, thrombin, prothrombin, thrombin, and fibrin. All these are the terminal products that we use in our practice when we use them as adjuncts, or we use some of these matrices which help the normal coagulation pathways to come through. So this is the summary of my talk. So there are so many verticals under which there are the active agents. So what we look at is actually the last products, the fibrin and thrombin, and they can be in the liquid or in the patch form. Then we have these matrices mechanical hemostats on which a normal coagulation catheter will go and seal. Then we had this third group of agents which are called sealants. I would say just like araldrite, just get two things, mix them together, they become really strong bonding thing and put them over the surface and probably they'll take care. Then there are hemostatic dressings. These have a varied amount of hemostats which are more like chemicals or biological based things over gauze pieces. They are not supposed to be left inside the body. They are mostly used for active bleeding at trauma sites. Then there are systemic agents like desmopressin, epinephrine, antifibrinolytic path things. And there's one which is topical and systemic. Some of them may be using is botropase. So each of them I'll be touching just for about a minute each. So active agents, this is one of the most common ones we use. So the liquid formulations are AV seal and flow seal and T-seal if you have been using. Flow seal, two of them come, you mix it before and you put it in, and T-seal, both of them get through the syringe which is injected. And then there is one group in which you have these mechanical devices over these coagulation factors are there. The Everest and TacoSeal, they are very effective, especially in areas where active bleeding and oozing is there and you use these agents and they get lifted up the surface, then you use them. So they are the liquid formations. You can see that the application, the way to apply these also, there's a lot of technology in it, because once you mix both of them, they become very hard and then they clog even the applying devices. So there's a lot of technology which has gone. So the two main things are thrombin and fibrin. So if there is higher fibrin, the clot is strong, but it forms late. By the time it forms, it gets washed off. Other thing is thrombin. So it is a weaker clot, but forms very rapidly. So a very good balance between the two is to be made so that the hemostasis happens at the right time and the clot is strong enough. And the application, as I said, there are various methods which companies have used so that they can be mixed at the terminal point and can be used. So there is some evidence as to whether you want to use the mechanical or the fibrin agents. The fibrin agents are actually a little better, marginally better than the mechanical devices. But there is a basic problem is the mechanical devices are supposed to work with your own body's hemostatic mechanism. So your own platelets, your own fibrin, thrombin is going there, whereas this AV seal and flow seal and all give them artificially. So they are from outside. So if you're depleted of the factors, use them. If you have your own factors, you're good to use the mechanical devices. So as I said, fibrin patch, there are many. TacoSeal is one of the most common ones, and they have these collagen surface over which the coagulation factors are there. Advantage is it doesn't get washed off. So if you apply it with a little pressure, in a few minutes, you attain good hemostasis. These are the various brands which are available. As I said, there is one layer of collagen and then there is prothrombotic things. So mechanical hemostats are the ones where you apply a mechanical device over which your own clotting factors come in. They are little inferior to the previously described ones, but they were available long before the fibrin and other things came in. The one we use most often is oxidized cellulose, which comes in the name of Surgicel most commonly. They have gone on, this is the evolution, went from Surgicel, Surgicel neonate, Fibrillar, surgical snow, which is just the fibers, and now the latest, I don't know if everybody of you have used this powder form. It is this device which you pump in and powder comes in, and the cellulose is nothing but the same thing that is used in the sanitary pads made from plant origin, cellulose. If you've seen the movie from Coimbatore guy, he has explained how to get this cellulose out of it. So it's the same cellulose, it's just that it is refined and made smaller, smaller, smaller. The smaller you make it, the more it can absorb and more rapidly it works. Oxidized cellulose. Adverse effects, there are some experiments to suggest even in partial nephrectomy that there is increased risk of fistula formation and infection, suppuration, and neural foramina, if you use them to pack, they could also cause paralysis. So it's a word of caution for these things because they can induce a reaction. Gelatin, I think when we started surgery and doing lab colis, we were placing them on the liver surface. So they also similar, they just applied there and they get absorbed completely in 4 to 6 weeks. The other is collagen. Again, the mechanism is the same. And this is something new. I have never used it or seen it. The next group I'm going into is the sealants, the albumin base or fibrin base, or synthetic ones are polyethylene glycol and cyanoacrylate base. Cyanoacrylate base is nothing but the derma bond, the one we use on the skin. Normally not supposed to use inside the body, but their property of coagulating is used by when you do angioembolization. So intervention radiologists use it. Otherwise, the albumin and the fibrin base, there are products. And they are just like I said, araldite. So you just mix two things. They are so fast to act that actually, if you'll see here, there is this bioglue where it is, I think, a plant starch albumin base. So it has these multiple applicators. So you have 3-4 applicators because it coagulates so fast that inside the tube itself it will this thing. So once you have applied it and you wait for 1 minute also, the tube gets clot. So they give 4 actually with it, so that you want to put in another area, you take off the tube and put. So the application technology also has come depending on how fast the thing forms a bond. Hemostatic dressings, I haven't gone into the details. There are many of them, but they are mostly used by trauma in the field. And when you use them, they are not absorbable, so you have to leave their wrapper so that the person who's in the emergency knows that one of these gauzes have been stuffed inside and they need to be removed. Otherwise, they will cause suppuration and infection. These are all the various types there. Again, very interesting videos are there on YouTube. If you are interested in any of them, you can go and see them. This whole presentation would have been very colorful and very interesting had I put any of those videos, but unfortunately, due to lack of time, I can use none. So, systemic hemostatic agents, again in urology practice, I don't know if anybody ever uses any of them, but cardiothoracic surgery and long liver surgeries, people regularly use apotrinin and EACA, tranexamic acid. They are used by others. In urology, we hardly use, but they have been known, some of them, to even decrease mortality and decrease blood loss definitely. So these are the indications and advantage, disadvantage of these agents. Because of lack of time, I'm not going to touch on them. Botropase is very interesting. Again, a plant, snake venom, which was procoagulant, has been used, can be used systemically and locally both. So some of them use, I have no experience, only in my MS, when I didn't understand anything, very happily I was using them. I don't use it any longer. So how to make a decision? So if you're having an injury from a parenchymal organ or an osmotic line, you can use a sealant. That was a third group that I talked about. But if there is coagulopathy, it is better to use liquid fibrin based adhesives. Unfortunately, nowadays everybody is only using the liquid fibrin based adhesives. They are a little costlier, but very effective. And if you have external bleeding, then you use the compressive dressing. So in conclusion, active hemostats are preferred in patients with coagulopathy. Mechanical hemostats are preferred in patients without coagulopathy. Fibrin patch or sealants are preferred in osmotic line bleeds. Systemic hemostats are effective in as topical hemostats and decrease the mortality. Especially few of the systemic agents can decrease mortality. The only level 1 evidence is in aprotinine. With that, I end. Thank you.
Thank you very much, Dr. Santosh, for your precise bird's view of hemostatic agents who are available and usage. Due to lack of time, we can allow only 1 or 2 questions. Yes, 1 or 2 questions. Yes, sir. Mike, please.
Surgical technique, instead of a good surgical technique, after a TURP or after a PCN, you are taking all the precautions.
No, not for these agents. They'll just get washed off because there is urine flow. There's not. Yes, PCNL. I know that few of my colleagues actually in the West, we were doing tubeless PCNLs here for ages. We never used anything. But there were people in the West who use this fibrin glue and other things. As they withdraw the implants, they inject. So they were very scared that, hey, how come you people do nothing? I said, parenchyma will fall back in itself and the hemostasis will occur. Why are you worried? But they were very worried and they use. So these things, but most of the time, I think they will get washed off. So there is no role on these agents. So when you're doing liver parenchyma or the renal parenchyma, which is raw, there you can have this thing. Any of these can be used. Bioglue has been used by liver people. There's a lot of people on CSF leaks after the Dura closure, they have used the Dura seal. So there are a lot of these sealants and things have been used on dry surfaces, they work. But where water is flowing, no. See, the problem is if any of these things, no, outside. See, liver, as I said, some of these sealants have been used by cardiothoracic people after they do the aortic valve and all that, the smaller leaks. So there the blood loss and hemostasis is much better, but they are bigger things. We use smaller things. There's a very high risk of thrombosis if any of this goes in. So it's not advisable for our type of surgery that we do, AV fistula and renal transplants. It's not advisable.
Santosh sir, we all give tranexamic acid intra-op during TURP. What is your opinion? Couple of papers on intravesical
the literature that I have seen is very major surgeries, cardiothoracic and vascular, where they have used. For TURP, if you have evidence, please present it, publish it somewhere, I will see.
Thank you very much, Santosh sir.
Thank you.
So at the outset, I will thank all the speakers who are well in time, and thanks for the opportunity on behalf of my co-chairpersons to the organizers to give this opportunity. We will move on to the organizers. Thank you.
Thank you very much, sir. We welcome you all to this prestigious midterm program conducted by the Association of Southern Urologists in honor of Professor H.S. Bhat. We'll start the inaugural function. We had to modify the program a little different because we had to wait for the dean who was preoccupied. I request Dr. Rajesh, the organizing secretary, to accompany Professor Avadayappan sir, the ASU president, to the stage. I request Dr. Dr. Devanand sir to accompany the dean to the stage. Dean will pick the slides. I request Dr. Avadayappan to accompany the USA Secretary, Dr. Keshav Murthy, to the stage. Will be to the left of I request Dr. Rajesh to accompany Dr. Surya Prakash to the stage. Surya Prakash. I request Dr. Devanathan, the organizing chairman, to give the welcome address. It will be a very brief function, so everyone will be given only 2 or 3 minutes for that.
Good morning, everybody. On behalf of Trichy Chapter of Urological Society of India, I welcome Dr. Nehru, Dean of KAPV, Government Medical College, for giving us an opportunity to make use of this auditorium for the purpose of a scientific meeting. Thank you very much, sir. The venue is an excellent venue, and we have all the comforts to perform a conference of this kind. This is a 10th ASU Professor H.S. Bhat Midterm Workshop, and I welcome the Secretary of Urological Society of India, Dr. Keshav Murthy, and I also thank Dr. Avadayappan, President, Association of Southern Urologists. I welcome Dr. Surya Prakash, the Secretary, Association of Southern Urologists. I welcome all delegates, participants, and speakers for this excellent topic, expected, interesting topic, bleeding in urology. We have with us the invited speakers, non-urologists, hematologists from CMC Vellore, Dr. Uday Kulkarni, and interventional urologist, Dr. Bavaharan. I welcome the invited faculty on this occasion. We are looking forward for excellent deliberation to come from now onwards. We have in the past hosted 4 conferences in Trichy. 2 conferences were at Tapasu in 2005 and subsequently in 2013. We had also hosted midterm conferences in Trichy, and all the conferences went on well with a lot of appreciation from the delegates. We would very much like to maintain the same today also. I am sure with the participation of everyone around here, we can make this event a memorable one. I once again welcome all of you on this occasion of 10th ASU Professor H.S. Bhat Midterm Workshop organized by the Association of Southern Urologists. Thank you very much.
Sir, can you please stay back? We'll honor the dignitaries on the stage. I request the organizing chairman to honor the ASU president, Dr. Avadaipan, sir. I request the senior urologist from Trichy, Dr. R.R. Surendran, to honor the Dean, Trichy Medical College, Dr. Nehru. I request Dr. Rajesh, the organizing secretary, to honor the USA secretary, Dr. Keshav Murthy. In fact, he is the brainchild behind this program. I request the organizing joint secretary, Dr. Azhapan, to honor Dr. Surya Prakash, the ASU secretary. There will be a small video presentation as a tribute to Professor H.S. Bhat.
Professor Hattangadi Shashidhar Bhat, popularly known as Professor HSB, was born in Udupi on 21st January 1921. After his school education in Mangalore, he went on to graduate medicine from Stanley Medical College, Chennai in 1945. He was the best student in his batch and showed keen interest in surgery from his early days. Professor HSB joined Christian Medical College, Vellore in 1946 and worked in various departments before completing Masters in Surgery from CMC Vellore in 1953. Professor HSB believed that to become a successful consultant, one needs God's grace and accurate understanding of fundamentals and basic principles of surgical techniques. An academician of outstanding repute, HSB won 9 gold medals. He was awarded the Rockefeller Fellowship and worked with the giants in urology of those days. He was the recipient of the prestigious B.C. Roy Award. Professor HSB organized the first Urological Society of India conference in 1961. He served as the president of Urological Society of India from 1970 to 71. He was on the editorial board of IJU, was a council member of National Academy of Medical Sciences, and chairman of the special committee of ICMR. He was fondly remembered by all as the father of Indian urology, as he trained early urologists and teachers from all over the country. After an early retirement from CMC Vellore in 1975, Professor HSB worked as honorary professor at Bangalore Medical College and also at St. Philomena Hospital, Bangalore for a brief period before joining Sri Satyasai Institute of Higher Medical Sciences, Puttaparthi in 1991, where he was the chairman of departments of urology and nephrology. The department under his leadership was recognized for the DNB course in urology and trained many urologists. Professor HSB, the teacher of teachers, worked selflessly in Sri Satya Sai Institute till his last breath. These are some of the glimpses of Professor H.S. Bhat during his days. He even performed surgery on celebrities without knowing them they are celebrities. The late Dr. Prema Bhatt, wife of Professor H.S.B., was a renowned microbiologist and has done phenomenal work on tuberculosis for ICMR. The couple is blessed with 4 children: Dr. Usha, a clinical pathologist; Dr. Tara, a microbiologist; Mr. Gurudat, an engineer; and Dr. Sanjay Bhatt, a urologist. Dr. HSB left for his heavenly abode on 19th November 2010. Thank you.
Now I request the dignitaries on the dais to inaugurate this function solemnly by lighting the Kuttuvilakku. They can join for lighting the Kuttuvilakku, please. So. Thank you very much. This lighting of Kuttuvilakku symbolizes the removal of darkness from the atmosphere, from our minds and all that. Thank you very much, ladies, for helping us. We'll go to the address by the President ASU. We'll have a brief talk by the ASU President for 3 minutes.
Dear friends, Dean, Medical College Trichy, Secretary, USI, and other friends and seniors and my colleagues, it's a great pleasure to welcome you all to this ASU midterm workshop in Trichy. Trichy is becoming a hub for urological education. So much of activities are going on in Trichy. And really, we are honored to host it in Trichy. And as a president, sitting president of ASU, I welcome you all for this program on bleeding in urology. And it's my pleasure to be with you on this day. And a few requests, as a president. Our strength is our membership. So we are trying to convert all our associate members into life members, and the drive is going on, and we were successful in converting around 25 members in the past 1 or 2 months. And request all the professors who are all with us here, either retired or still on service, we request you to convert all your associate members and advise them to become a life member once they leave your institution, and really help us to strengthen the association by making the membership more. When the membership increases, what happens is our representation is increasing in the national body. We will have more say there. And our number of representations in the central council depends on the number of membership we have. So we can increase the number of membership in the central council also. So the base is the membership. So my kind request is that in our tenure, we would like to convert at least 80 to 90% of the associate members into life members. I think we will be achieving it, and we have started doing it. And one more request is the Central USA conference that's going to come in Delhi in 2023. And the president has taken a drive of making it a self-registration. And we were really becoming successful, and we have crossed the landmark of 15 to 1600 so far. And we would like to make it to 30,000, I mean 30 hundreds, that means 3,000 minimum. And I request all those who have not registered for the USICON 2023 to do a self-registration for USICON 2023. Thank you. Thank you all.
Thank you, President Sir. We'll have a brief introduction about the theme by the Secretary ASU, Dr. Surya Prakash.
Respected President ASU, Dr. Avidiyappan sir, Organizing Chairman, Dr. K.S. Devanathan sir, USI Secretary, Dr. Keshav Murthy sir, Chief Guest of today, Dr. Nehru sir, Dean of Medical College, Organizing Secretary, Dr. Rajesh, Joint Organizing Secretary, Dr. Allagappan, and the man who has put a lot of efforts for this program and who wants to sit in front of the dais, Dr. Kannan sir, and all my dear delegates. I welcome you all for this 10th ASU HSP midterm workshop. The theme of this workshop is bleeding in urology. It's a very hot topic. This complication, or I call it a scenario, is seen by all of us in our day-to-day practice. The topic was chosen by Kannan sir 2 years back, and he wanted to do it as a physical program. That's why we are here. And the council thought that it's very apt to discuss this topic in depth. So the program is divided basically into 3 sessions. The first one we finished, the hemorrhage and hemostasis. And this will be followed by 2 sessions of upper tract and lower tract bleeding. And we have interesting case scenarios of both upper tract and lower tract, which will be discussed by our panelists. We have highly learned faculty, a mix of both junior and senior consultants to enlighten us on this topic. So I request all of you to interact with the faculty and make the sessions useful and carry home knowledge for the benefit of our patients. Thank you very much.
Thank you, sir. Now I welcome the guest of honor, the person who has given this place in our disposal, our respected the Dean of KP Medical College, Dr. Nehru. Sir, we owe it to you for all the ambience we have today, and people have come in the maximum number in all these 10 editions where we have recorded the maximum of 175 registration for this program, which is very unique in that the entire amount for that program is given by the old students of Professor H.S. Bhat, led by Dr. Keshav Murthy, and we don't get any sponsors from outside. And we gratefully thank you for giving the campus for our program, and we request you to give address us and tell us about your views, because it so happened you sat through one of the lectures which is of very vital importance to our practice. Please, sir, your words of wisdom for us, briefly.
Thank you, sir, for your good words. Good morning to everybody. I am the Dean of this college. Really, I must thank each and everybody of you. You preferred this college for conducting this South Zonal midterm CME on urology. Really, it's a pride to us. Your presence is our pride, really. Because you are all are super specialists, not the simple persons. You have spared your Sundays, valuable Sundays. Everybody's respect on Sundays, because that day is the only rest day. That day also you were sitting and conducting a conference and making it useful to each and everybody practicing persons. You are sharing your knowledge among you, and that too a very good topic, common topic, complicated topic, but brought many very good persons from various places to become a success. I have to say some of the persons. Dr. Rajesh, who is behind this semi. I congratulate him because because of his efforts only you have all the ways all you are came here and you made this program as a success. And also Kannan sir, I have to say some of the names of the urologists came in my life. Professor Dharmarajan sir, he sat here, and Surendran sir, the best going outstanding students of Tanjore Medical College. I am one of the student in the Tanjore Medical College student, old students. You symbolically represented that the topic in your dress. I wondered why you are wearing the red colored dress. Usually this kind of dress will be worn by somebody's in hotels. I could not realize what was the topic. I was invited, that's all. What was the topic? I do not know because I have held up in some other problems. I have got facing some problem in the hospital. In between what I have to talk, I do not know, remember. I catch this point, that's red color and also bleeding. So this is why they preferred red color. So everybody is having, the police station also painted red color to make alert everybody. So any patients will ignore all the symptoms, any other symptoms, headache, simple complaints, abdominal pain, vomiting, they go for medical shop and they get medicines. But what about this, even head injury, even bleeding comes from the head, they will not take much care of about that. They will put their hand and will go to the doctor. It will take some time. But whenever there is a bleeding in down, what happens? Immediately he will shout. Definitely he will shout, please help me, help me, help me. He will definitely will call doctors by the side of him because of this kind of a bleeding. Nobody will accept. So such kind of a very good topic has been chosen. And I have to thank and everybody. Don't please tell thanks for me. It is an opportunity to spread the education in my place. That is not in my place. This is belongs to government institution. I welcome all the educational aspects in our college. It is not my college. It is our college and your college also. All the times you come here, you conduct similar conferences, similar meetings. I will be very happy. That's the thing. Because of your presence, definitely will make our college name will be flourished. Thank you very much.
Thank you, sir. Thank you for your kind words. I'm just reminded of Professor Ravi Shankar's famous slide. Red is a sign of danger. So if you see red, don't say not to worry. There is something behind. That's a very famous slide of, that's a message you have brought in your address. Thank you very much, sir, for all the nice things you have done for us. And now I request Dr. Keshav Murthy, the USA Secretary, to felicitate. He is the person who initiated this, and this program is very unique. All the speakers come from various places. They spend money on their own. We don't spend any money for any of them. The entire amount is sponsored by the Association of Urologists, Southern Urologists, which has been donated by the Bangalore Urology Society under Dr. Keshav Murthy. I thank you also, and please felicitate on this August occasion, sir.
Thank you, Dr. Kannan, dignitaries from the dais, and respected seniors and my dear friends. I bring greetings from the Urological Society of India. I'm happy to be here attending the 10th ASU Midterm workshop, and this was the program which we started 11 years back. The first meeting I had in Bangalore, exactly 1 year after the demise of Professor H.S. Bhat. It is at that time when the seniors, including Dr. Ganesh Gopalkrishnan, Dr. Ganesh Kamath, Professor C.C., Mahendra Bhandari, most of them had attended that meeting. And in that discussion, we conceived the idea that we should start a program which would be self-sustaining and we should not get any pharma sponsor, because H.S. Bhat was a person who never went behind this. He was never after money. In fact, he told his son also, Dr. Sanjay Bhat, that you should go to institutions, not go behind money, money will come behind you. But Sanjay Bhatt was not that. Sanjay Bhatt was a very practical person. So to follow the principles of our teacher, I was fortunate to be working with him at Puttaparthi as the first student in Puttaparthi for 3 years. And I've imbibed most of what he was teaching us. And that's the reason we thought of this idea. And thanks to the UCCon 2012, which Dr. Ramesh was also the organizing secretary, when we got the proceeds of that from the Bangalore Urology Society, we decided that we'll make a corpus of 25 lakhs, which will be kept as a corpus for this midterm CUV, and then we start adding on to it. And this program is entirely run on the interest of that corpus. Nobody is sponsored by any company, and the interest of that will run this conference like that. I'm happy to see the 10th edition of that running, and I hope it becomes much bigger. And this is the largest attended conference I've seen of the 10 editions. That's primarily because not only the awareness, it's also probably because the topic which Dr. Kannan has chosen. Kannan and Raja were famous for these in my student days, when they would bring in topics which would teach what the textbooks would not teach us. That was their theme. And similarly, he has brought in this theme. So it would be a theme which would be practical, and this CME is dedicated to that we have more interaction and we learn from that. And I hope the ASU brings this conference to a much higher magnitude, which needs to be attended by more members of our association. Thank you, Kannan, and thank you, ASU, for the opportunity.
Thank you very much, Secretary Sir. Now I request the playing of, we have a felicitation message from the President of the Urology Society of India. The video message will be played now.
Good morning, everyone. I feel happy to know that this year's Dr. H.S. Bhatt Symposium is being organized on 20th of November at Trichy. I'm sorry that I am not able to attend the meeting personally, as I am engaged with Video Urology Conference happening in Ahmedabad around same time. H.S. Bhatt Symposium for last 10 years has established its identity, and that is because it is different in the way it is organized, such as low budget, self-paid, without pharma support, but having highest quality academic content. It is very heartening to know that day by day, the popularity of this program is increasing, as evidenced by the delegates' attendance. We have shown the whole India that this format not only is sustainable, but can be popular also. I must congratulate the organizers to have selected the theme of bleeding in urology. This can be a very hot topic with a lot of practical utility, which can generate a lot of discussion. I have no doubt that delegates attending this meeting will be benefited immensely. All my best wishes to you for a great success of this H.S. Bhatt Symposium. Thank you very much.
Thank you. Now I request the ASU Secretary, Dr. Surya Prakash, to read the message of felicitation from the President-elect of Urology Society of India, Dr. Sanjay Kulkarni.
This is a message from Dr. Sanjay Kulkarni. Dr. H.S. Bhatt was a teacher par excellence. He set up the first department in India to start the MCH course in urology. He was a very compassionate man. His empathy towards patients, dedication to educating students, and passion for urology led him to be called as the teacher of teachers. He received the coveted B.C. Roy Award. He was the designated surgeon to the President of India and the Chief Minister of Tamil Nadu. He established the urology department at Satyasai Institute of Higher Medical Sciences, Puttaparthi, and under his guidance, 18 batches of DNB urology students graduated. He practiced medicine for nearly 7 decades. He was a true visionary and a leader in Indian urology. The Urology Society of India and President-elect Dr. Sanjay Kulkarni wishes to congratulate ASU for conducting the Professor H.S. Bhatt Annual Midterm Workshop at Trichy 2022.
Thank you. It is customary that someone from the family of Professor H.S. Bhatt attends the program of this midterm workshop every year. But this year, due to unavoidable situation. Dr. Sanjay, but who usually attends, could not attend. But we were able to get a message, video message from the eldest daughter of Dr. H.S. Bhat, Dr. Chitra Sitaram, Dr. Usha Sitaram, probably will get the message.
Good morning, everyone. I am Usha Sitaram, Sanjay Bhatt's eldest sister. On behalf of the Bhatt family, I thank the organizers of this meeting for recognizing our late father's contribution towards the development of urology as a specialty in India. Over the years, as a family, we saw how much his students meant to him. Our home and later the hospital ward where he spent the last few years of his life were always an open house for his students. Age was never a barrier. Today, the efforts of his students belonging to various generations are a testament to the fact that the bond and mutual respect goes beyond the workspace. He would have been moved by this gesture. His life's purpose was provide quality health care to people from all walks of life without distinction in class, creed, race, caste or status. And he worked diligently to fulfill this purpose. Thank you once again for honoring our father's work and memory in this manner. We will always remain grateful for this gesture. Sai Ram.
This the simplest effect we could take to complete the program where always someone from the H.S. Bhatt's family were there. Now I request Dr. Rajesh Rajendran to propose a word of thanks for this inaugural function.
It's a happy moment to be here as the organizing secretary of this Professor H.S. Bhatt's 10th midterm program, and as the first president of the first Tiruchirappalli city chapter of USI. This is the first city chapter of USI. And for this, first I thank Dr. Krishnaswamy Kannan sir, who is responsible for the creating our chapter and mainly for this program. And I thank our dynamic secretary Surya Prakash sir and our Audipan sir for their support. And I thank President USI, Secretary USI and President-elect USI for their good words and support. I thank our Dean, an ever-smiling, pleasant personality, a physician cum radiologist who is well-versed in both clinical and radiological aspects. With his full support only, we are able to conduct this program. Thank you, sir. I thank all the faculty members who have come all from various places with their own expenses. And I thank all the delegates who participated in huge number. And I thank all my Tiruchirappalli city chapter members for their extreme help and support. With my prayers for smooth running for this program, once again I thank you all. Thank you.
Thank you very much. The inaugural function comes to a close. We'll have a short break of 10 minutes when we can go out for a tea break, and we have to join again because the program is going to be very tight with a lot of interesting topics.
Thank you, sir. Exactly in 10 minutes we are back. I request all the speakers to stick to the time because time is a factor. We have many talks and we want to close the program by 4:30 today evening. Thank you.
கரையில் அழகாய் சின்னம் நகரும் பாக்ஸ் சிட்டி சின்ன பெயர்தான் வேலை கொண்ட
Tiruchirappalli, the city chapter of USI.
Now Dean is coming on a hat. Hello, please make it faster. Have a quick tea break and come back. We should. Sorry? There is no tea break at 11:25. It is now. Oh. There is one more tea break. Sir, coffee. Sir, coffee. Shall I get some coffee? Okay. Sir.
Hello, check. Hello, audio check. Just hello, check.
So, when I was doing MCH in MMC, all the people from Andhra and North India, they will stay behind me. And DC sir will be shouting at me, Kana, you're delaying and all. Have a quick break and come. இது ஆக்சுவலா இல்ல என் கையில இது ஆக்சுவலா வந்து ரொம்ப வச்சு சூட வச்சிருந்தோம்னா வந்து அதான் 90 சொன்னேன் சூட வச்சிருந்தோம் டக்குன்னு இருக்கா காலையில கூட என்ன அது இல்லைன்னா பிடிச்சிக்கிட்டே இல்லைன்னா அனுப்பிச்சிருக்கு ஏன்னா வந்து அங்க வச்சு அது அதுலதான் பண்றது.
చెక్ చెక్ హలో హలో చెక్ చెక్ టెస్టింగ్ కొంచెం அதை வேணா கெயின் வேணா லைட்டாக வச்சுக்கோ చెక్ హలో హలో చెక్ కొంచెం చెక్ టెస్ట్ హలో ఓకే
இது மட்டும்தான் அவர் பல நாள் படி
அங்க கேக்குமா? கேட்காது, வெளியே கேட்காது, சுத்தமா கேட்காது.
చెక్ చెక్ హలో చెక్
So welcome back after the tea break. Now we'll move on to the second session, that is on upper tract bleeding. For this session, I invite Dr. Gurunath, Secretary Tapasu, Dr. Rajesh Rajendran and Dr. Surendran sir to chair the session and take the proceedings forward.
So this session contains 4 papers. Let me invite Dr. Kiran. Energy sources for hemostasis.
It's not audible.
It's mine.
So, thank you, USI, for inviting me for this talk. Sorry, ASU, sorry. That was a mistake, pardon me, sir. Deeply honored to be a part of Professor H.S. Bhat Symposium, who is considered the father of urology. So, I'll be talking on energy devices for hemostasis. I'll start with a quote which says, "There is nothing more important for the successful outcome of an operation than maintenance of hemostasis." And I have no conflicts of interest to declare. Coming to the history, in 1928, Bowie devised the first electrosurgical equipment which laid the foundation of modern electrosurgery. In 1970, bipolar was introduced, and in 1993, ultrasonic. And now, almost every surgical procedure, cutting across geographical location, you take any surgery, starting from the basic circumcision in urology to the most advanced laparoscopic or robotic procedures, there will be an energy device which will be used during surgery. The most basic is the monopolar, as we all know, which is the most commonly used. The coagulation happens through the interrupted waveform, which causes high energy flow, causing hemostasis. But there are disadvantages like stray current injuries, inability to seal vessels more than 2 millimeter, interference with pacemaker, and tissue charring. The bipolar, as we all know, since the current passes in between the tips of the instruments only, so it is relatively safe, and there's minimum collateral spread. Coming to the tissue effects, monopolar has vaporization, fulguration, desiccation, and coaptation, whereas the conventional bipolar, advanced bipolar, and ultrasonic devices, there is a combination of desiccation and coaptation, and probably because of that, there is less smoke production. The most commonly used advanced bipolar devices, as we all know, is NSEAL and Ligashore, and Cayman is the newly introduced device from Aesculap. So, NSEAL is a bipolar product from Ethicon, which has nanopolar thermostats inside the jaw, and it causes tissue-dependent energy dose deliverance, causing hemostasis. It can cut and seal vessels up to 7 millimeters, and the seal vessel can withstand more than 7 times the systolic blood pressure. This is the new one, the NSEAL G2 articulating. It has an articulating arm so that there is a perpendicular, we can cast the vessel perpendicularly, leading to better hemostasis. This is a new kid in the block, Cayman from Aesculap company. The advantages is this device has the tip first closure. So it is claimed to have better compression and better hemostasis. And it has among all the energy devices till now, it has the longest jaws. And it also has got 80-degree articulation. The ultrasonic devices, it was introduced in 1993 and it became popular from 2010 onwards. It converts electrical energy into vibrations. More than 55,000 cycles per second is the vibration of the blades, which is above the audible range. Here we have to be aware that the harmonics lower jaw is the active one, which is vibrating and causes hemostasis, and it should not be brought very close to the vital structures. So how to maximize hemostasis when we are using a harmonic? You have to decrease the power to the maximum, minimum level. The power, the coagulation is 3. When you decrease to 2 or 1, further hemostasis improves. We have to always catch the tissues towards the proximal part of the blade, not at the tip, so that hemostasis occurs. And there should not be any tissue traction or tension. Because if you put tissue traction and activate minimum, the action will be maximum, like cutting action. So there should not be any tissue traction. Maximum you have to hold inside the jaw and should be perpendicular. So this is a new one from harmonic Ethicon, ACE +7. Whereas the routine harmonic ACE can seal up to 5 millimeter, this harmonic can seal up to 7 millimeters. It has got a green button here, which is the advanced hemostasis button. This is the Covidion's answer for Ethicon's harmonic. This is the Sony Session, which is an ultrasonic device. The advantage here is it is cordless. And it has got a reusable battery and a reusable generator, which can last 150 to 200 cases. The hybrid device, Thunderbeat from Olympus, is the first device to integrate both ultrasonic and bipolar in a single instrument. It has got faster tissue dissection, can seal up vessels up to 7 millimeters. The ultrasonic part cuts and dissects, whereas the bipolar part causes coagulation, vessel sealing. It has also got the intelligent tissue monitoring, which stops the energy after the tissue is transected. What are the newer technologies in energy device? There is a device called AcroSurge from a company in Japan, Nikiso, which is the first device to use microwaves as the energy source. This microwave causes vibration of water molecules causing coagulation. It is not available yet in India. From 2017 onwards, it is available in Japan. The second one is a ferromagnetic based device in which the ferromagnetic alloy within the jaw reacts with the magnetic field causing coagulation. Now, how do we compare these energy devices? There are so many energy devices in the market. So we'll be comparing these three parameters. So first is the vessel size. Ultrasonic harmonic ACE, as already told, it can seal vessels only up to 5 millimeter. But the newer harmonic ACE plus up to 7 millimeter. And advanced bipolar N-seal, Ligasure and Thunderbeat up to 7 millimeter size vessels. Burst pressure is the maximum pressure before leakage at the sealing site when done in experimental studies. And in those studies, Thunderbeat has scored the maximum burst pressure, which is even comparable to the surgical clips. So here we can see 5 to 7 millimeter bigger vessels, Thunderbeat scores more than Ligasure and harmonic. So what about seal width, which is an indirect parameter of seal reliability? Here we can see the Ligasure seal width is very good compared to harmonic and Thunderbeat, wherein air pockets are seen, which is classical of ultrasonic device. Lateral thermal spread is lowest with harmonic ACE and smoke production also. And 5 millimeter is considered to be a safe margin for all newer energy devices. So there was an article in BMC Surgery, which was the only article I found which compared energy devices in our field, like urology. They compared harmonic scalpel, Ligasure and Thunderbeat in laparoscopic adrenal surgery. And it was found that Thunderbeat was the fastest device, and the intraoperative blood loss, there was not much statistical difference between Thunderbeat and Harmonic. So in a nutshell, Thunderbeat has got the highest burst pressures and fastest sealing time. Harmonic scalpel lowest thermal spread smoke production, whereas Ligashore has the highest seal width and seal reliability. So what is the take home message? No single energy device has been shown superior to another. It all depends on the type of surgical procedure, the type of vessel you want to seal, the operating surgeon's familiarity, and the instrument preference availability also. Last but not the least, it is not the one, it's the wizard which is important. So analogy here is, it is not the energy device, but the surgeon who is important for the hemostasis. So probably if we want our organizers t-shirt to be painted white, I think it should be the primary responsibility of the surgeon, not the energy device. So as the professor, Dean sir also told. Thank you.
Thanks to Dr. Kiran for this excellent speech. Now from the floor, questions from the floor.
Yes, sir. Okay. That's probably because of that pressure. The more you apply the pressure, there is less of hemostasis and more of cutting. So even if you press the minimum button, that is what I discussed with the Ethicon guy regarding what actually happens during surgery. So even if you press the minimum, if you put tissue traction and if you hold the tissue towards the tip, there will be more of cutting action rather than coagulation. That might be the reason. Okay, okay. Harmonic only. Okay. So that is my, maybe they have introduced the more advanced harmonic ACE 7 plus. So it is claimed to cause better hemostasis. And it is the routine, sir. Yeah, routine harmonic. When compared to Thunderbeat scores better.
I request all to use the mic because it is being recorded. Please use the mic because
recurrent hemorrhage, bipolar devices more in comparison to ultrasonic devices. But I don't think there is literature comparing the secondary hemorrhage for these energy devices. The seal reliability is the maximum with Ligashore, but Thunderbeat actually scores more in practical applications. These all studies were done in pigs, experimental studies, but real life application, most studies are with Thunderbeat. So I think Thunderbeat would be the best choice.
And the maximum burst pressure.
Yes.
And what does that signify as far as the coagulation cutting of tissue is concerned?
It is the reliability of that hemostasis. That is, they compare, they infuse saline into the sealed vessels of pigs after coagulation with each instrument, and they check how much is the burst pressure. The pressure at which the leakage first happens is the maximum burst pressure. So in that also, Thunderbeat scores better. It is almost comparable to the Hemalock clip, 750 millimeters of mercury, more than 7 times the systolic blood pressure.
Now, does it
But
depend on
clinical
the length of the, sort of coagulation?
Yes.
Or the depth of coagulation? What does it depend on?
Basically, among the energy devices, it has been shown that Ligashore has the maximum seal width. If you compare the seal width, Ligashore scores better. So maybe dependent upon the bipolar energy which is delivered. I searched the literature why it is happening, but I didn't get the answer yet. No, sir, I have never used the Indian one. Makes sense. Okay. I don't think there is a literature which compares the standard devices with our Indian instruments. I've personally never used Indian instruments.
Many
so
people
I'm
are buying, so we
probably
have
not
to
a candidate to speak about.
guide them. Youngsters are, because it is cheaper,
Yes.
we need to guide them.
Yes.
Yeah, I have used one device which is marketed in Bangalore,
Okay.
Allen. So the harmony scalpel, it's very good. And the coagulation, the bleeding is very, very minimal. The cauterization is very good. He says
what is the cost, sir?
Yeah, he says it is between 5 to 6 lakhs. He quoted 8 lakhs. I said, can you come down? Probably in that range he is going to come back. So 5 to 6 lakhs. And no. The generator.
Generator
And
and the handpiece?
he says it comes to about 50 cases.
Oh,
So it was
that's
very
good
interesting.
then.
So,
Because harmonic hardly lasts for
Yeah.
8 to 10 cases.
So I think our institution is going to buy that.
So
in
which
Bangalore.
company, sir? Then?
Allen.
Allen.
Company. Yes, we can do it. We'll do it. Sure.
Comment. I just want to add a comment on that. Same observation. Even the biorad has come with harmonic type of thing. What sir says is coagulation is good, but if you use close to the ureter for partial nephrectomy like this, the lateral spread will be more.
Yes.
It is highly coagulative, as sir said. For general purpose like nephrectomy, it will be very useful. For reconstruction, any pyeloplasty if you use, there may be problem. I am able to see the hardness of that also. If you touch the liver more than harmonic, it is causing burn.
Yes. Lateral
Lateral
spread is
spread
more.
definitely more, sir. Definitely more.
Oh. Okay, sir.
I think I can move on for next topic, sir.
Thank you, sir.
I invite Dr. Bobby Vishru from Coimbatore to speak on PCNL bleeding risk factors and interop management.
Thanks ASU for giving this opportunity. It is an honor and blessing to be part of this annual event. My topic has two aspects. The first part is the risk factors in PCNL. It can be remembered as past, patient factors, access and accessories, related factors, stone factors, and surgeon's factors. Among the patient factors, the most important is the body build of the patient, diabetes, hypertension, lack of pre-op hydronephrosis, history of prior open renal surgeries or prior endoscopic stone surgeries, renal anomalies or skeletal anomalies, and patients being on anticoagulants. Of the stone related factor, it is mainly the complexity of the stone, the volume of the stone, the stagon stone or multiple stones. And among the axis related, it could be a single step sequential, whether it's a balloon or metal or the type of the ampler sheets which we are using, the size of the ampler sheets, and the energy sources for breaking the stones. The surgeon's factors could be starting from the beginning, from the puncture, whether it's done by the interventional radiologist or by the urologist, type of position employed for the puncture, the imaging guidance used, whether it is supracostal, subcostal, the type of technique which is employed, papillary versus non-papillary punctures, number of access tracts which are created, and the operative time. So there are various retrospective and prospective studies have been done, and none of them they agree with all of them. You can find every aspect being countered by some other study. So even though one of the most quoted cited paper is Kukreja's paper from Mujlibai Patel, the factors which they thought were the diabetes, multiple tracts, prolonged operative time, and occurrence of type of method of tract dilatation. Just the summary from the textbook, which has given as 6 aspects. That is, one is the diabetes associated atherosclerosis, hypertension, stone burden, number of access, and operative time more than 58 minutes in this edition of the textbook. There are various scoring systems, but none of them predict whether patient can have a bleeding risk during PCNL. And this is a recent paper published, presented in AUA 22 meeting, and the authors have looked at creating a nomogram. One of the factors which, some of the factors which they have added are BMI, preoperative hemoglobin, and whether or presence or absence of severe hydronephrosis. We know that PCNL is like a controlled grade 4 renal injury, and the bleeding complications are less than 10% in the current literature. The reason for the so less bleeding reports is being that everyone adheres to the standard principles of making a track and stone removal. So these are some of the things which everyone is well versed with. The second part is the intro of control of bleeding, and which starts from the time when we start making a puncture. And when the initial needle puncture is showing a blood efflux, it is, or when you are placing a Alkan needle to place a safety wire, at that point of time, if you notice any pulsatile blood, withdraw and reposition. Use a appropriate size ampula sheath and manipulate use it appropriately. If there is any vision problem because of the bleeding, we can raise the irrigant fluid column and then proceed with the procedure. It depends upon what time of the operation that happens. And in case that bleeding is troublesome, easy way is to put in a large bore nephrostomy tube and come out and stage the procedure. Some people use inflating constrictive balloon catheters for the same purpose. And one of the most common theoretical question in EVing is use of KS balloon tamponade. The advantage of this balloon is that it provides access to the PCS and provides track across the entire PCN tract. There are other methods to control bleeding people have employed. This is a large retrospective study of 341 units, 249 cases. They used electrocautery. 1/3 of them were tubeless, but in the comparison, they concluded that there was a decrease in blood transfusion rates. If we have to ask about intra-op management, it is basically, I thought it is part of the tubeless PCNL, and people use either electrocautery, laser or cryotherapy to fulgurate the bleeding points which they see at the cortical or PCS margins. And other concept of tubeless PCNL, they use certain hemostatic agent sealants like fibrin sealant, gelatin matrix within the tract and take a stitch on the surface to achieve the tubeless concept. So these are some of the retrospective and prospective studies which have compared using various sealants, and if you see, there is no difference in post-op bleeding complications. And this is another agent which is employed from morning. People are talking about, I think there is a talk on this topic in the subsequent sessions. Friends, the match is not over till the last ball is bowled. Similarly, in a PCNL, till you place the nephrostomy tube in a proper place and come out, the procedure is not over. There can be mishaps can taken place. There are some case reports of misplacements of nephrostomy catheter into renal vein and IVC. So please be aware. Thank you very much. Just to summarize, there are two parts. One is risk factors for bleeding following for PCNL. My question is there is no predictive factors. There are all factors are important, and then it depends upon the surgeon's experience and the operative time. These are the most important factors. as part of the intra-op management, I think people have or use different techniques to counter some of them. That is again from experience, and in case there is a problem, best thing is to stage the procedure and then do it.
Have you used
any questions?
Have you used any balloon tamponade?
Yeah, balloon tamponade is you can use the Foley balloon, regular Foley balloon, which has a 3 ml, 5 ml capacity balloons for the tract. Otherwise, you can use a regular PCNL tract balloon, balloon, Nephromax. Nephromax you can use for the tract tamponade.
What is your experience, sir?
I don't have much experience in intra-op management, except for one case. I think I have heard that we have used some Bugbee electrode when we saw some bleeding sputter which is there. Nowadays, people are using laser for mini perk left and right, and in case if they see some sputter is there, they can use the same laser to fulgurate that bleeding point. So actually, I thought that it is basically anecdotal. Most of the intra-op management bleeding control is anecdotal, but then when the literature search was made, then I came across this retrospective paper. This is most of the time when as a person who has done the procedure, he knows what has happened. I feel that any surgical complication, the surgeon knows the best. So when in a patient with PCNL, when he has finished the procedure and he has come out, one of the first thing is to look at is the urine bag. And then we know at the time of procedure, when you look at the bucket which contains the blood, we know how much has happened, and then it is good to interact with the anesthetist and get his feeling, because sometimes you may be biased with your procedures. Best thing is to get interact with your anesthetist, and then if parameters are same, and then most of the time these patients are shifted, and with the tamponade it settles down. And if you look at it, the majority of the time we only take the help of our interventional radiologist in the post-operative setup. Very rarely we bring them back for a control of bleeding. Yes, sir. Because I said that this is not part, I thought that somebody else is having a part, I thought left it. The issue is that if you are looking at the bleeding complications, though it is less than 10%, but if you are looking at the transfusion rates, whether it is mini perk or with the standard perks, it goes up to 53%. So there is a variation in literature report, but aborting the procedure for a bleeding is 0.2% in the literature. And so that's the thing. And because it is a major artery bleeding, again it is very low.
Just a interesting thing like to add, my experience, it may be useful for the others also, where a pelvic kidney with a staghorn stone, I punctured under ultrasound laparoscopy guidance.
Yes.
Punctured, dilated the tract under laparoscopy guidance, removed the stone. So there was little bleeding, so we sutured it laparoscopically. So there was no bleeding at all. So that is also one of the way we can control the bleeding.
Thank you, sir.
Yeah.
We'll pass on next.
Curiosity, I would like to know the August House, how many of you have had the misfortune of doing a nephrectomy post PCNL? Because some of you have practiced without the help of angiographic facilities available. There was a period where angiography was not available in every place, but PCNL was being done. I'm sure PCNL. So how many of you had to go through this painful exercise of doing a nephrectomy post PCNL? Because I have had one occasion, and I just wanted to know, because it's an awful thing when a good kidney comes out. See, this particular case I am referring to is a very obese woman, about 115 kgs, and she had cryptogenic cirrhosis which was missed preoperatively. And she kept on, she had that, and she developed ischemic hepatopathy and kept on bleeding. So we had to do that. So this was, and then subsequently, of course, on a number of occasions, we got away with the angiography. I agree with, because anything which is hemodynamic stability, instability, hematocrit, and persistent bleeding, one has to, and the threshold should be really low. One has to go, and because if angiography is available, I think it can work wonders if you have help in your issue.
Thank you, sir. We'll go to
I
next,
just add on to this because I thought it will be a part. Okay, then we can.
We'll go to next paper, sir. Bleeding during RARS prevention and management, Dr. Karthikeyan.
Good afternoon, everybody. Thanks for having me on board. After an excellent talk on post-PCNL bleed, I'm going to talk about bleeding in RARS. RARS is any retrograde manipulation above the PEJ, whether we do it with semi-rigid or flexible ureteroscopy, it's called RARS. It's a very safe procedure, but it does hide some potentially dramatic and fatal complications beneath its beauty. I'm just going to unwrap its rare complications here. I'm going to present few case reports to underline the significance of post-RARS bleed. This case report about arteriocalyxal fistula was published in Journal of Endourology in the year 2020. Here, a 50-year-old gentleman underwent RARS for a 1.5 centimeter lower calyxal stone. He had history of PCNL and multiple RARS and ESW in the past. Patient presented with bleeding in the day 1, continued to bleed for 2 weeks, and when they did a digital subtraction angiography, they found a arteriocalyxial fistula, which was then selectively embolized. Not only there are reports about early bleeding, in this case there is a delayed bleed. Here the delayed bleeding happened after 37 days. This patient underwent RARS for a 12 millimeter middle calyxal stone, and there was difficulty in the manipulation of the scope, and patient had bled after 37 days, who was also managed by selective arterial embolization. In this case, there was intraparenchymal hematoma after RARS due to high pressure irrigation. Patient had this bleed. On day 1, patient presented with loin pain again post-procedure. CT was done. A small subcapsular hematoma was found. Patient was discharged with conservative management, and he came back after 2 weeks with loin pain, fever. A repeat CT showed a 10x8 centimeter subcapsular hematoma, which was then percutaneously drained, following which the patient improved. So, the literature has enough case reports and case series about post-RARS bleed. So, this is not something uncommon, only we are not aware of this. Hemorrhage in RARS is typically minor and self-remitting and rarely warrants any monitoring or intervention. Any profuse or pulsatile bleeding during RARS indicates a vessel injury, and we have to be a little more careful in these situations. Bleeding during RARS follows a vicious cycle. Initially, because of need of better vision, there will be increase in irrigation fluid pressure, and it leads to high intrapelvic pressure. There will be more fluid will be absorbed, and high BP will be there, which will initiate the bleeding. And to counteract this bleed, there will be more irrigation, and this vicious cycle will continue. So here, we are seeing few small mucosal bleeds. Mucosal bleeds can be mostly minor. It occurs because of the mucosal aberration or manipulation by the scope or the stone. In this case, despite having a minor mucosal bleed, we were able to continue our procedure and complete it. Sometimes, because of the continuous bleed, we may have to increase the intrarenal pressure by better irrigation, and there will be clearance of this bleed and the vision improves like this as it happened in this case. The moment you stop this high pressure, you can see the bleeding completely has settled and we have a better vision at the end. But the moment you release the irrigation pressure, it will re-bleed. So what goes on inside comes outside also. This is a post-RARS bleed seen as a continuous bleeding from the access sheath. Sometimes these patients may bleed to a significant amount. They may have clot retention when we have to do a clot evacuation also. So the etiological factors for post-RARS bleeding can be because of an access sheath induced bleed. Whenever we force the introduction of access sheath, there may be bleeding from the VUJ. Because of high intrarenal pressure, as I said before, there can be intraoperative bleeding or even post-procedure bleed. Laser induced bleed because of misfiring. This usually happens when there is a high frequency is used, and instead of the stone, we may touch the submucosal blood vessels or the papillary tips. When there is a difficult manipulation or excessive manipulation of the scope, this may lead to bleed. Accessories like a basket can produce small mucosal beads which are usually non-clinically significant. Any large volume stone can produce a significant bead because of any of the above set mechanism. Any history of previous procedure like PCNL can increase the chance of bleeding, and any distorted calyxal anatomy can produce a significant bleeding. In the first case, the patient had a PCNL and 4 RARS and ESW procedure, which might have precluded a subclinical aneurysm which might have been opened by the RARS. So we have to be very careful when we do RARS following a post-PCNL or a post-ESW indication. So we have to be little brush our anatomical knowledge. We know that after the segmental artery, which divides as a lobar artery, the interlobar artery runs parallel to the infundibulum. This interlobar artery not only responsible for the bleeding during PCNL, this can be a significant source of bleeding during RARS also when there is inadvertent injury to the interlobar arteries. This usually runs parallel to at 3 o'clock and 9 o'clock. So we have to be very careful at these locations. So there are some special situations which can increase the chance of bleeding due to RARS, like calyxal diverticulum, stones, any ectopic kidney, any cross-diffused ectopia. Here the vascular anatomy is the rule. It's not an exception. So we should be aware the vessels can be present at abnormal locations, and the laser usage should be very cautious. We know patients with medullary sponge kidney or patients who have stones embedded in the parenchyma, during RARS, they can have a significant bleeding because we may injure the submucosal any vessel like interlobar arteries or an arcuate artery. During endopellotomy, care should be taken to make sure that there is no crossing vessel. Otherwise, this can be a cause for significant bleed during RARS. So far we have seen how bleeding can be significant. Let us see how it can be prevented. Always try to maintain a low pressure irrigation. The irrigation should be only for having a better vision, and make sure that the BP is not raised throughout the procedure. If you are doing it under regional anesthesia, try to synchronize with the patient's respiration, your laser firing. If there is a need for infundibulotomy, never do an infundibular incision other than 5 and 7 o'clock position, although these positions themselves are not always safe. Avoid high frequency setting near the mucosa. Consider GA if there is significant respiratory intervention because of the patient's respiratory artifact. So as a novice urologist, what are the care we should take? Always select your cases properly. Avoid doing RARS or be more cautious when you are doing RARS following PCNL or ESWL. Make sure that you have good accessories and equipments. Always do RARS with a proper roadmap. Safety guide wire is a must when you have the difficulty entry is there. Never use force during endourology. If there is any bleed, just stent and come out. We can always have a day for repeat procedure and not a complication. So the management options are simple. So if there is a mild hematuria, little bit more of irrigation may be helped. Sometimes it may be counterproductive. Your role of tranexamic acid is questionable, but mostly it is useful. If there is a small bleed from one of the calyxes, try to navigate away from the calyx, go to other calyx, finish those stones, come back. Mostly these bleeds would have settled. We can try fulguration with the small bleeders. Mostly it will be successful. Significant subcapsular hematoma can be dealt by percutaneous drainage. Large subcapsular hematoma may need nephrectomy. Selective renal arterial embolization can be done when the bleeding is profound and recurrent. So the take-home message here is RARS is definitely a safe procedure. These are all rare complications, but don't get disheartened. Most bleeding following RARS are self-limiting. Conventional angio is the best. Even if it's rare, it can be life-threatening at times. Thank you one and all for your patient listening.
Thank you very much, Dr. Karthikeyan, for your excellent talk. And let me invite questions from the floor.
I want to share 2 cases where torrential bleeding has happened, significant bleeding from the access sheath and loss of vision. What I wanted to add, apart from it has happened retrospectively when surgery is seen, the laser fiber has touched the upper pole infundibulum. The point I wanted to stress is that if you put your flexible scope and keep on washing, blood loss will be significant. Take it out, put the stent, and usually clot formation happens in short period. So 3-way irrigation insert. So remove the access sheath without putting the flexible spoke for a long time if the vision is not there. Let the clot form. Put a stent if possible because sepsis may occur. And start three-way irrigation electively to wash out the blood. These are the 3 points I want to add. 2 cases I have seen in 15 years.
Point well taken, sir. Thank you.
Suppose the bleeding starts. Once you put the access sheath, bleeding starts. Even before you start the procedure, will you abandon and come out?
Yes, sir. We will abandon if the vision is compromised.
Okay.
Definitely.
Number 2, infundibulotomy between 5 and 7 o'clock positions, but various infundibula at various directions. So, which infundibulum you mean by infundibulotomy at 5 and 7 o'clock?
So mostly the middle calixial infundibulum, this 5 o'clock and 7 o'clock is usually safer because the variation of the infundibular arteries is the variable. That's what I said. No position is safe for infundibulotomy.
No, sir. That concept of infundibulum incision clockwise is gone, sir. Now, no deeper incision. If you really want to enlarge the lumen, 5-6 areas you burn a little bit, 1 mm, so that enough lumen to go into the calyx and do it. No single incision anywhere in the infundibulum.
Exactly.
Highly unpredictable because 3-dimensional calycial orientation nobody can predict. So nowhere it is written 5 and 7 for any infundibulum.
So we can
Only
say
few mm submucosal to increase the diameter of the calyx. You want to otherwise go for PC.
what we can say is we avoid 3 o'clock and 9 o'clock and no single position is safe.
In calyx.
No.
Pilotomy is defined. Endopilotomy.
Not be equated with the endopilotomy.
Yes,
No,
sir.
no, no.
Yes, sir.
No,
Calyx, no clock position.
Another risk factor, Karthikeyan, is infected stones. Your culture may be sterile. When you start glazing, you will see that. Then friable mucosa. In such case, I think you should come out.
Exactly, sir. Inflamed mucosa is always a riskier for bleeding.
Karthik, the clot is the biggest enemy in our ARS. If there is no active bleeding and you have clots, what will you do?
Clots within the pelvic-calixial
Within the
system.
pelvic calixial system, you have a lot of clots, but there is no active bleeding. What will you do next?
No, if it is not interfering with my vision, I will proceed with the RARS. Nowadays, the option of suction through the access sheets are available, which will be a valuable tool for better vision during RARS. But otherwise, if we don't have a significant bleed, which doesn't impair our vision, we can definitely proceed even if you have clots within the PCS. Yeah. Yeah, definitely because of the high density, putting insulation of contrast within the calyx may help in reducing the bleeding. Sometimes it will stop also. Thank you, sir.
Now I invite Dr. Bhavagaran to talk on angioembolization in post-PCNW bleed.
A very warm good afternoon to everyone. I thank the Urology Society of India Trichy chapter for inviting me here.
இது புதுசு அது
Yeah. Okay. A warm good afternoon. Post-PCNL bleed embolization is what I'm going to talk on. So today with the advanced and much sophisticated interventional products, we are able to access any particular vessel, whether it is a main or the distal vessels, to actually embolize the bleeding part very, very super selectively. So these are the common materials we have. We generally divide the embolization materials into temporary and permanent. So permanent is the one which we use either polyvinyl alcohol particles, or we use glue with lipiodol as a contrast agent, or we use coils. So these are the common thing. Major access we take is through the femoral artery route, and then we get into the renal artery and go super selectively using a catheter called as a microcatheter if it is required. So let's go to the case here. So you could see here, this is the post-PCNL case where there is a large pseudoaneurysm sitting in the lower polar branch. So that is the bleeding source. This patient was bleeding very profusely and his BP was dropping. We had to shift him to the cath lab. Could see here again, that's the aneurysm that is actually being shown here. Again, you could see. So this is the microcatheter which could access into the, see how distal we have gone into the vessel, so that we get the maximum amount of nephron possible to be saved. So that's the main point of doing the procedure here. So you could see here the catheter is being advanced into the system. So this is again another case of aneurysm where you could see it is much closer to the hilum, but it's still, you can actually access this particular branch and you can embolize this particular vessel. So what we did was we went into it and we put the microcatheter inside and coiled the entire aneurysm as a whole. So this is again a very simple, straightforward procedure. Hardly takes about 20 minutes for the entire procedure. That's it. So this is again a case where you could see the nephrostomy tube is there, but it has multiple aneurysms. You could see here because it had two calculus and there were two punctures taken in this case. So there were two different aneurysms at two different places. So what we had to do, we had to go through the microcatheter into this particular aneurysm and we actually embolized this particular vessel because this was not supplying anywhere else. You could see here again, this particular vessel was not branching and it's not supplying anywhere else. So we had to embolize the entire vessel. So that is important because when you actually go and embolize here, there is always a possibility that there can be a collateral which can fill from here and enter into the aneurysm. So again, there can be a recurrent bleed. So we had to block the aneurysm in front as well as back as well as the aneurysm. So that was the approach taken in this case, and we went through the microcatheter and blocked this particular aneurysm. So again, you could see another aneurysm, the same case, which was filling in the upper polar branch. Again, this was a two puncture case. So we had to go and embolize that particular vessel also. Now this is not an actual coil. This is what we take from the catheter, the tip of the soft part of the catheter, because it's about 1 millimeter. 1 millimeter coil is not available. So what we do is we actually cut the distal end of the soft wires that we use, and then we put it across and coil it inside so that it doesn't cause any more bleed. So this is the post-coil structure angiogram you could see. You could see the coils here, and this is the digital subtraction angiogram. The coil is masked, and the rest of the kidney is absolutely beautifully seen. So this is a case where this was a case of pseudoaneurysm which was there after a biopsy actually, but you could see here the bleeding was very active, which was going in the extra renal or the perinephric space. So in this case, actually putting a coil will be very, very difficult because again, there's a very small vessel tweak coming in and it was flowing, but there was a good control. The patient had a good control of the blood pressure, everything. So what we did, we injected glue. So glue is what you use in endocril, which we actually mix it with a agent called as lipiodol. Generally, this glue, when it comes in contact with any ionic material, whether it is blood, whether it is your normal saline, whether it is a ringer lactate, it just solidifies immediately. So we had to either use 5% dextrose or we have to use a lipiodol, which is made up of poppy seed oil. So we had to mix that in a particular concentration, take the microcatheter so deep into the interpolar branch, and then slowly inject the glue into the system. So that is how a glue stands. So the glue stands here and it will be appearing radiopaque. So this was the aneurysm, which was the extrarenal bleed that was embolized with glue, and post-embolization angiogram showed perfectly normal kidneys. Right. So this is a case where again a post-PCNL case, and you could see here, sorry for the slowness, okay, you could see here the vein is filling much quickly and you could see the vein filling it up in the arterial phase. So this is a arteriovenous aneurysm, sorry, arteriovenous malformation. Now this arteriovenous malformation, you cannot inject glue. Glue will, if it is migrate, it can glow into the lung and it can cause severe cough to the patient. Poppy seed oil, when it crosses into the system, goes into systemic circulation, is very, very toxic. So we cannot use that. So what we did was putting a coil there. You could see that is the post-embolization where we did, you could see the coil there, and there the aneurysm, the AVM is totally blocked, and this particular vessel, so that's the coil there, and that is completely blocked. Now in this case, we had to actually give off the entire lower pole. Almost 20 to 30% of the kidney was lost in this patient after embolization. That's because we had to embolize this entire particular vessel. So this is a case where it was a very delayed aneurysm, so very delayed bleed after about 6 weeks of PCNL. This patient presented and there was a bleed, so we did an ultrasound, and ultrasound revealed aneurysm straight away, so we did not do any CT, took the patient directly into cath lab, and then we embolized this particular large aneurysm just by putting a coil into the feeder branch. That's it. The entire thing was particularly gone. This is a very crazy kind of a case. We had for the I would say 4 cases in the past 7 years. The first case was a 35-year-old guy who had a post PCNL. The patient presented to the emergency department with bleed. So it was in a hospital, and that hospital had 2 theaters. Both the theaters were full because they were doing cases there. We could not shift the patient to the cath lab from the hospital because the patient BP was drastically dropping and he was pouring blood into the urobag. So this was the video, actually what we had. This is another case again. You could see here, that is the pulsatile pseudoaneurysm which was sitting, and you could see the perinephric hematoma, and you could see the pulsatile aneurysm sitting there. The patient was profusely bleeding. He was oozing and his BP was dropping. The anesthetist was getting ready to intubate the patient, but we were not able to shift the patient back. See here again, that's the aneurysm. So what we could do, we had to save the patient. We directly, what I did through the ultrasound guidance, you could see that's the aneurysm. So what I did was we had glue. So I directly punctured the aneurysm, ultrasound guidance, directly punctured because we had a good renal parenchyma there, and put in a glue there. It was like magic for us because when there was bleeding profusely, after about 2 minutes, there was a fresh white urine that was coming up. So that actually stopped the bleeding. It was a risk, I know that, but nothing could be done to save the patient. So that was the case, and fortunately or unfortunately, we had 4 cases over the past 7 years. And this year, I think in Trichy, we did only 2 cases, post-PCNL bleed and nothing more. So these are the methods which we use to embolize this particular post-PCNL bleeding structures. Thank you so much for your patient listening.
Sir, I have a question. Sir.
What is the cost for the procedures? Actual, I mean,
okay.
approximate cost.
Approximate cost will be around 60,000, sir. And if you use lipidol, it costs, see, 1 vial of lipidol is 10 ml. That lipidol alone costs 20,000.
Okay.
So that will be the extra cost if you are going to use glue. Otherwise, coil will cost about 60 to 65 at the max, including all, the entire procedure cost.
Entire package?
Entire package will be 60 to 65, sir.
Thank you.
Sir, do you have any experience of coil dislodgement?
Sir, no, sir. When you put a coil, the important thing is to select the size of the coil. When it is a smaller coil when you use, then the problem of dislodgement, everything comes into play.
It gets proximal to the vessel, or it gets proximal renal artery gets.
That happens, sir. See, sometimes when you do, that's what I'm saying. When you don't select the size of the coil properly, then we have a problem of coil migrating proximally. That is the problem sometimes we have. So when you select the size of the coil right, see, for example, we used, I told you the edge of the wire was cut and we put it. That's because the vessel size was less than 1 millimeter. So we cannot put a coil there. So we'll have to put a straight structure which actually goes and stops. So that's why we use that particular structure.
If you use gel foam or the liquid,
No, so
there's a
gel
chance
foam.
of
No, sir. Gel
reflex.
foam is never used in case of post-PCN bleed, sir. Never. Never. Don't use any gel foam. Gel foam stands only for about 48 hours. After that, it gets dissolved and it gets absorbed. See, it's like putting a gel foam in after surgery when you pack your post-operative bed with gel foam. It gets absorbed eventually in about 48 to 72 hours. Similarly, here also it gets absorbed and the patient will start to bleed again. So gel foam is not advisable in any of these post-PCNL bleed where you see an aneurysm or an AVM. No.
I think the coil migration is more in cases of central AV communications rather than the peripheral ones. Especially the one you showed where there is vena cable seeing immediately. Those are the situations where it can go up. So that possibility is there if it is central rather than peripheral.
Yes, sir. See,
Second is, what is the incidence of post-infarction syndrome in your cases?
See, most of the patients, like about 20 to 30% of the patient do have a bit of pain and they have fever, which settles in about 24 hours. I just use paracetamol to those patients.
So this post-PCNL bleeding is one of the most dreaded, not only because of the complication as such, because of the cost involved. Because, invariably the onus comes on the surgeon. So we have made a small modification. We use the central line guide wires, the inside part of it, the core of it. The cost of our embolization comes to 15,000 rupees because of using.
No, sir. It's here. The problem is, I get attached to a hospital, so we'll have to pay to the cath lab, number one. Number two, the sheets and what we use. See, when we use a straight catheter, just a regular catheter costs for somewhere around 2,500 rupees. But when you want to go very specific into the distal vessels where you want to be super selective in occlusion, you have to use a microcatheter. Now, the microcatheter comes at a cost. It's about 18,000 rupees plus tax. So that has to be again included. And the one coil costs around 5,000 rupees. So that's an average. So if you use glue, then the glue cost is only about 900 rupees. But when you use glue, you cannot use it with any other agent. So you need a mixer where you could see that we have put the glue in the right place and dilute it. So that in that case, we need to have lipidol. That costs around another 20,000 rupees. So this is where the cost is involved most of the time, sir.
How do you keep the catheter in situ after embolization procedure?
I mean, you mean the PCN catheter. So it depends, sir. I mean,
Not the PCN, the femoral catheter. Do you remove it immediately or do you wait?
No, sir. We wait for some time, sir.
How long?
Because till the urine is clear and completely out. See, sometimes, there can be a huge clots that is sitting in the ureter that can slowly migrate down into the bladder. That can cause obstruction in the future. So in those cases, they'll have to do a bladder wash and all those things. Many of the times, bladder irrigation I continue after the procedure when there is a good amount of bleed, and when I see clot before the procedure, generally I ask my colleagues to continue the bladder irrigation at least for next 24 to 48 hours.
Not the bladder irrigation, femoral catheter.
No, femoral catheter I remove it immediately, sir.
Immediately.
I
You
remove.
don't wait
Yeah.
for
If I am confident that I have done it completely and this is absolutely fine, I remove the catheter. I don't just keep it, because when you put the catheter in, now the problem is you will have to have heparin in round the clock for the next till the catheter is there. Now you cannot leave it without heparin. So that I have to use. So that's quite honestly. I remove it immediately. Yes, sir. If I am confident about the procedure that I have embolized it completely, I remove it.
So I understand that from most of your presentation, I presume that on most of the occasions, you can be very sure that, pretty sure that when to use glue and when to use microcatheter, isn't it?
Yeah.
Can you devise some novel method to just, in terms of cost effectiveness, where you can optimize glue and catheter like that? It's just a very
okay. See, too much
maybe unconventional
optimization.
question. I don't know.
Yes, sir. See, sometimes we can use a used catheters, which is actually ETO. When you do a proper sterilization and use, sometimes the patient is absolutely poor. In those cases, actually, we can actually cut down the costs of the catheter by using a previously used catheters after sterilization. So already it would have been paid to the hospital. In those cases, the hospital which I am working in, generally they don't charge for the patient. So in those cases, we can cut down considerably at about 20,000 rupees, 25,000 rupees. Actually, it can be reduced for the patient side. No, it's about the flexibility of the catheter that goes. See, after a sterilization, the catheter is not as smooth as what you want.
Now, thanks to Dr. Bhavagaran for this informative talk.
Thank you. Thank you.
And special thanks to the organizers for giving us the opportunity to be the chairpersons for this session. Thank you.
Thank you, sir. I thank the chairpersons for doing an excellent job for this session. Now, we move on to the next session. Now, I invite the chairpersons for this session, Dr. Jagadishwar, Dr. Avadiyappan sir, and Dr. Ravi Kumar sir. So, I have the duty of honoring the speakers of the previous session. So, I request our President ASU, Dr. Avadiyappan sir, to give a certificate of appreciation for the previous speakers of the previous sessions. Dr. Suresh Bhat sir. Dr. Uday Kulkarni. Then Dr. Santosh. Dr. Manohar. Okay. Dr. Manohar. Next session. Yeah. Now I invite the second session speakers. Dr. Kiran Nair. Dr. Babi Vishwarup. Dr. Karthikeyan. Dr. Bavaharan, radiologist. Yeah. Good talk. I request the chairperson of this session to carry on with the proceedings. We have small change. We'll have the second talk first.
We'll start the next session. The first lecture is by Dr. Lakshman Prabhu on management of bleeding following renal trauma.
Thank you, chairpersons, and apologies to my co-speakers that just have to leave a little earlier, so I have requested for this small little change. My apologies. Can we have the slides, please? I was also wanting to wear a red shirt, but then after seeing so many red shirts, I realized that I had to make a small change. The reason why I wanted to wear a red shirt was my topic is such that it is bleeding from a traumatized kidney, and it will bleed whether you like it or not, because there is no surgeon there. It is an accident or an assault. Whereas when the surgeon is there, the urine at the end of the procedure should look like urine. So therefore, with that message, I thought I changed over to a white coat. And the next two speakers probably will tell us how to achieve that. Now, you cannot say that a traumatized kidney should not bleed. With that, we will move on. And this would be the plan of my presentation. Understand bleeding from a traumatized kidney, and then how we triage. I would restrict my whole presentation only to bleeding and no other injuries. And then finally, treatment. Now, post-traumatic renal bleeding can be early as well as delayed, and the causes for delayed bleeding usually are the well-known AV fistulations or the pseudoaneurysms, and I don't intend to visit it, so in this particular presentation. Now, this illustration is very well known to all of us, that we have gradation of renal injuries. But the most important thing is a traumatized kidney will no doubt bleed, but this bleed can be concealed or revealed. This is most important, and it is perhaps not correct to say that hematuria is the cardinal sign of renal injury, which we learnt as undergraduate and MS students. a sub-stratification which is also available in the literature. Grade 4 is subdivided into 4A and B, and only we find that the risk of intervention goes up to almost 60% upwards when it is grade 4B, and there are criteria. I will not go through the criteria. Suffices to say that in the recent guidelines on urotrauma of American Urology Association, hemodynamically unstable patient with hematoma more than 4 centimeters, vascular contrast extravasation and deep complex lacerations invariably go for an interventional form of treatment, that is operative management. Now, this particular sketch will tell us that no matter how the kidney is injured, whether it is blunt injury or penetrating injury, whether it is acceleration injury or a deceleration injury, whatever is the type of penetrating injury, the vessels cannot escape. In isolated pedicle injuries, perhaps the parenchyma might escape, but in any type of renal injury, there will be bleeding, and that is why it is very important to understand bleeding from a traumatized kidney. Trauma can also unmask pre-existing abnormalities, and this is the mechanism is there is amplification of force in a liquid-filled incompressible compartment. Many of the practitioners would have come across bleed when they have handled a large hydronephrotic kidney, either during PCNLs or in situations where the patient has come to us after trauma. Now, the following points have to be borne in mind. Majority of renal injuries coexist with concomitant injuries, and the latter can be the cause of shock, and therefore there should not be in a hurry to do something for the kidney. We don't get traumatized kidneys, we get traumatized patients. Pre-existing conditions put the renal unit at a high risk, which easily bleed, and visible hematuria or revealed hematuria is seen only in about 35 to 77% of cases, and therefore somebody could be having a serious bleed when it is internal and it is concealed. Serious pedicle injuries in penetrating trauma may not have visible hematuria. Anterior penetrating injuries tend to injure the pedicle, and most important thing is resuscitation precedes imaging in hemodynamically unstable patients. Now, these are the points which all of us, most of us were, I would say that some of us were raised before the guideline era, I would say, that we were all told that an active bleeding from penetrating injury, I would here pause for a while and say that I think during our time, there was no conservative management for penetrating injury. Today things have changed. I think most of the seniors, Deva sir will agree, I think all of you will agree that that was the standard teaching. An expanding pulsatile hematoma, extensive ecchymosis, hemodynamic instability, that is systolic blood pressure of less than 90 millimeters of mercury with microscopic hematuria, and persistent gross hematuria, all will by and large end up with the interventional form of treatment. Penetrating injuries have a higher rate of significant bleeding. Here, I would like to say that the 4 P's, the pre-existing renal disease, penetrating trauma, pediatric trauma, a palpability, significant palpability, a large mass, and persistence of hematuria are all red flags. You know, I think you are wearing red shirts or red t-shirts, I think justifies this. I think, you know, it is most appropriate for this presentation rather than any other segment of this workshop. Now, the triaging is by imaging, and initial imaging is done in stable patients or stabilized patients, and this is how you go about it. A re-imaging is usually done in 2 to 4 days when we adopt what is called as a norm or a non-operative management. And if there is clinical deterioration, then this re-imaging can be done a little earlier, and it is also one of the indications for a re-imaging. Now the treatment is, you know, like in classical music you have Tarana or Tillana, you know, the tom noms, you see, this is, we also have this nom and om. So nom is non-operative management, and majority of the cases are managed non-operatively. Here, the surgeon does well to remember that it is Mother Nature who achieves hemostasis and not the surgeon. and expect us to not to meddle with her efforts, and the surgeon intervenes. Surgeon should not interfere. The surgeon intervenes so that Mother Nature can take an upper hand. Operative management should not be equated to nephrectomy today because we have excellent methods of, because of our partial nephrectomy experience, we can do a rhinorrhaphy, a partial nephrectomy. And the most important thing is one can manage majority of these bleeds conservatively with angioembolization and the blood transfusions. Now, a word about angioembolization. It is always done after stabilizing the patient. It should be done as selectively as possible. Blind angioembolization is not indicated when angio is negative for active bleeding. Renal artery interventions, example stenting, should be done. I mean, if there is a thrombosis, it should be done by those proficient in it. And an endovascular balloon is at times used as a bridge to definitive hemostasis. Now, coming to the summary, every traumatized kidney will bleed. Bleeding can be concealed or revealed. There is no absolute relationship between the type or the degree of immaturity and the type of severity of the injured kidney. Each of the traumatized kidney should be accorded a systematic triaging. Not every kidney that has blood needs invasive intervention. Just see these three pictures quickly. This was a polytrauma. Kidney is not visualized, but the renal artery is visualized. There is no extravasation. We thought this could be a thrombosis. We thought this was an acceleration injury. There is no extravasation. But then we pressed for angiography, and this is what it was. We could still see the renal artery, and most of the segmental vessels were not seen. So there was a bleed which was coiled and glued, and whatever it was told to us in the previous. After that, the patient was taken up for an exploration because he had a diaphragmatic laceration. The stomach was in the thorax, and there was a lot of blood in the left thorax. And when we explored, in fact, we were called in as an intraoperative consultation because they thought that they had done the job, the interventional radiologist. This was how the kidney was. The kidney was simply picked up. No effort, it was picked up from the operative site. So it is decapsulated and it is damaged. So this was actually not, and what probably had happened was the renal artery was perhaps in a state of spasm, and that is why there was no extravasation. Thank you very much for overstepping into the time of my co-speakers. And once again, I have to say something. See, we brought out the special covers to honor Professors HSB during the decennial celebration of our department. These special covers are available at the counter. I want all of you to pick up one and make a generous donation to the Professor HSB fund. Whatever it is, whatever you feel like, please make it, because mine is, this was passed in the annual general body meeting of the Association of Southern Urologists recently in Bangalore. Mine is a donation in kind. You pick up, it's a collectible, and make a donation, which will be, the secretary will take care of that, and he will maybe even cut a receipt for your whatever amount you are going to donate. It should go to HSB fund. That is one thing. And also as the Secretary-elect of Urological Society of India, and I'll be speaking on behalf of Dr. Keshavamurthy, that the benevolence fund forms are also available. Such of those who can join, please enroll yourself for that. And with that, thank you once again for the time.
Thank you, Dr. Lakshman Prabhu.
Yeah.
Patient was going remodeling something, and I need to go in there. And after going in there, I never seen, I couldn't make any landmarks. I called the infograph and my chief. And it was very difficult, and the patient landed up in a picture. Even doing an effective in the case was so difficult. Before going in there, I thought I like to pass and between all those things. But intraoperatively, nothing was able to be, I'm not able to be any much structure. So what do you think?
No, see, in fact, that is the experience which we come across every now and then throughout our life, because there are no tips actually. What you did very well, most of your patients were conserved. This was an unusual case where you needed to go in, and remember, when you go in, you invariably end up with a nephrectomy. It is not that easy where you have a shattered kidney, where you can do a partial nephrectomy. It is all nice. We can discuss it. Maybe all that becomes very easy on a blackboard. But in real life situation, if there is a huge hematoma, kidney shattered or traumatized badly, grade 4, 5 injuries, I think best don't waste your time. Only thing is I forgot to mention that if you don't have imaging information and if the blood pressure permits, kindly do an intraoperative urogram. At least 1 urogram with the table has a bucky, you can take one. Most of the times we have today, we are in the era of modern imaging. Invariably, you will know the information on the contralateral kidney. Nothing now. There are no tips. You have to be fast. This is one situation where your even general surgical skills comes to your rescue. We may have advanced surgeons who do all these endoscopic work, but they can be a mess in a situation like this. I have seen this. I am not casting aspersions on anybody. You did well. You have to act. Thank you.
So deceleration injuries, thrombosis, non-excreting kidney, will you do nephrectomy or will you wait?
No, again, what happens is these things are missed invariably. See, you have up to CT angio you will go. So if a diagnosis of thrombosis is made, the ideal thing, if the diagnosis is made, the ideal thing is to recanalize. That's why I said it's stenting. No, by the time you do it, the kidney would have lost its function and you will be looking at a page kidney or hypertension management. So how often we can have this balloon or even a stenting unless you have expertise?
Thank you, Dr. Prabhu.
Thank you very much.
Thank you very much. We shall go to the next paper now, sir. It is by Raghavan, hemostasis in partial nephrectomy. Dr. Raghavan.
We thank Raghavan for accepting the invitation in the last moment. Thank you, Raghavan.
The most respected chairpersons and my most respected seniors and colleagues here. I thank ASU for this opportunity. I had the joy of attending this ASU midterm workshop almost 6 times, first invited by Dr. Ganesh Kamath, and subsequently I've done my best to attend it every time. Thank you so much for the invitation. So today my talk is on hemostasis and partial nephrectomy. I'm not sure whether I'm going to tell anything new, but I'll see whether I can structure it down to simple points. If there are any PGs here, this picture is very useful. Otherwise, we'll skip this picture and move forward. We know the renal arterial anatomy is segmental in nature. And that also gives the advantage that you can perform zero ischemia because of the segmental nature of the artery. The first step of hemostasis is to make sure that we have source control. The source control for kidney is the artery. So you have to have a precise understanding of how many arteries are there and the way to control it. And whilst people do zero ischemia or even peripheral occlusion, the mass occlusion of the artery is the one which is followed by almost 99% of the population in the 99% of the urologists in the world. One thing I should say is impairment of the renal artery intermittently is a bad idea. Continuous occlusion and quick job and finish the work and go is a much better idea than blocking it, opening it and blocking it again, because it releases a lot of factors which in turn causes more damage, and therefore intermittent blocking is not a good idea. And also the other thing is if you are going to keep the renal vein open, it causes some bit of black flow and therefore some bit of perfusion. The precise amount of which is not quantified, but it is a good medical practice to do that way. The rest of all the techniques like intraoperative mannitol injection, including I give it as well, even though the literature says that it has no benefit whatsoever, I still do it because I feel that there's nothing to lose and everything to gain. The other thing which really benefits the renal preservation is the cold. So if you're going to do a mass clamping like what we do for open surgeries, cool the kidney down, which will definitely help you in reducing the trauma to the kidney. So the types of partial nephrectomy, all of you know about this. It can be enucleation, segmental nephrectomy, wedge, and whatever. All methods is practiced by all of you. So come to the real point. is how to get hemostasis. So the first step of hemostasis is to understand what are we going to deal, how many arteries are there, how many veins are there. Nowadays I'm doing a 3D recon for all my partials because it makes my life tons better. I now know how many arteries are there, because most of the time the quality of scan that is done, because I get scans from every part of the country, it is not always, especially if it comes from northeast, the scan quality is very poor. So 3D recon really makes a difference to my life. It reduces the operative time by about 25-30 minutes. So such a complex case, recon, we know that there is one artery which is arching there that could be preserved, and you could see that well preserved artery as well. I hope it can be shown here. Yeah. That artery can be shown as well and preserved, which the patient had a grade 1 clear cell RCC with clear margin. Intraoperative technique, this is what people commonly ask the question on. So the point I'm going to say is, an individual vascular structures need to be clipped and sutured. Now, this is more applicable for open surgery. Whether it is possible to do whilst you are doing minimally invasive surgery is difficult. Because in minimally invasive surgery, most of the time we use warm ischemia, not cold ischemia, and therefore we are racing against time. Whilst individual arteries and vessels are clamped and sutured is very good, it's very difficult to implement in a warm ischemia setting. So that brings us to the next point, which is inner layer rhinography and outer layer rhinography. Now, whether to do one mask closure, a lot of laparoscopic surgeons do a mask closure as well. Whilst I am not against it, I'm very, very anxious about it, and I've seen quite a few pseudoaneurysms after mask closure. So all I would say is have a word of caution, think well before you do it. You can always combine many things. There is a concept. So this is just to show that that is individual vessel ligation. One of the best surgeries I've ever seen was done by Ganesh Gopalakrishnan sir in one of the meetings conducted by Ginnell, where sir performed an open partial nephrectomy in a very complex endophytic tumor, zero ischemia, minuscule by minuscule approach, clipped every vessel without blood loss and did it. That was just a gift to see. So that not everybody is gifted. Most of us are people like me. So we do this, we clamp and close and do it further. The most popular thing that is practiced in the world, almost across the world, is sliding clip rhinography. Nukit also was mentioned by Santosh, and bolsters, the surgical mentioned by Santosh as well. We'll cover all the three. When I started doing open partial nephrectomies in 2005, this was very popular, taught to me by Keith Parson, where you have to place bolsters on either side and shrink the kidney down. For some time during the time, once we started using Hem-o-lok clips, we stopped using it somewhere 2007. I stopped using this. We just use the Hem-o-lok clip applicator and Hem-o-lok clip to occlude it down. We don't use it at all nowadays. This is the sliding clip rhinography. Everybody in the world uses it. It's excellent technique, foolproof. Many million partial nephrectomies are done this way, and it is so far so good as a technique. So what you do, the point of reference which I wanted you to understand is that you divide the suture into two segments. You do the inner layer rhinography and then come to the outer layer rhinography. This is the outer layer, that is the inner layer. And for the inner layer, I use fish hook suture, which is a Stratafix or a quill or a V-lock, whatever your choice is. But it really tightens it down, especially if you are using a minimally invasive technique. If you are going to use an open surgical technique, which I do as well, I use PDS because the curve of the needle, a 3-0 PDS curve of the needle runs nicely without causing much damage. Surgical bolsters. I remember one case where Brian Chapin did partial nephrectomy. It used to be a very common practice for us to put a Surgicel and occlude it and come. And we realized that at the second day it bled because, as Dr. Bhavagaran was saying, it dissolves. It dissolves and everything bled. So we realized that time onwards we don't put bolsters inside, but we do there is no replacement for good surgical technique, quote unquote Santosh. So do a good operation and put an added bolster as more manshanti rather than a real work of the bolster itself. This is very popular now, cortical rhinography without outer layer rhinography. I've started doing it a lot often now as well. Almost 30-40% of my cases, I do just this one. Do the inner layer, don't do outer layer and walk away. So far, no complications. But I'll take a few extra minutes. One point of reference, before you do the final set of closures, it will be wise to just ask the anesthetist to blow up the lung so that you know that this is just very applicable after you finish the inner layer. So it helps you in that way. It will play, I assume. Okay, right. Okay. Inner ear rhinography, this is what almost most of you use. One thing I wanted to say, especially youngsters, do not hesitate to take a deep bite. Many times we hesitate to take the deep bite, and when we take the superficial bite, the renal parenchyma tears. You may feel that I am taking very deep bite there. Keep in mind the depth of the needle will go to about 3 to 4 mm only. The bite that goes in will go to only 3 to 4 mm depth. So it is very easy to get a good inner layer rhinography. It covers everything that you need to do in terms of vascular control. If you have a large calyx open, make sure you close it separately. I do close it separately as well. And this is the outer layer rhinography. Once again, the suture that we use is a 10 vicryl. Why I use it is because it slides nicely with the hemlock clip and the hemlock clip stays. And after the procedure, you can always singe it a bit more as well. Yeah. Now you see the singeing. You singe the outer layer rhinography, go back and singe the inner layer rhinography one more time. It really gives you a beautiful hemostatic effect. In the process, I want to say that there is another beautiful hemostatic tool called gauze piece. The only thing is you can't leave it inside and come out, but it really, if you put the gauze piece and wait for about 2 minutes, it really stops all the minor oozing, which leaves you only with the major oozing that you need to deal with. And after I have done it, I leave a Surgicel on top of it and then close the whole layer across. It's like a renal trauma. We have created a trauma, we put it back again, put the Gerota back again, so that it becomes a contained small hematoma which heals on its own. Okay, just a word about the hemostatic agents. Gauze piece, extremely useful but temporary. Lot of things. I used to use it when I was in 2010 and all. Since 2010, I stopped using any of these agents. I don't use any of them at all. Once again, a range of things is available, including organ beam coagulator, electrocautery, harmonic scalpel, blah, blah, blah. I don't use any. So, conclusion, please plan. You should know how many arteries, how many veins, what challenges you're going to face, what segmental artery you're going to sacrifice. Planning, theatre staff, good assistance. You can have all the hemostatic agents that you want in the world, but have a backup plan, including a plan for radical nephrectomy if necessary. Thank you so much for the opportunity.
Any questions from the floor for this?
We have to, because I find that liver surgeons, they are unclamping and every 15 minutes to perfuse the liver. And why should we think of this reperfusion injury? That is a factor about which we have to, because I don't find any strong evidence to say that such a thing exists. So how can we prove that reperfusion? So what I am doing is now, is after my first layer, I unclamp and see if there is any bleeding. I just put the clamp again, suture it, and then unclamp again. That is what I am following now. Second is about mannitol. Again, the same confusion. You highlighted that mannitol. So I stopped using mannitol because there is no perfusion. Third thing is the how long we can clamp. That is again because I feel that perfusion, the bleeding and whatever renal issues that can happen post-operatively, that has to be taken care more importantly. And if you are overshooting by few minutes, we should not compromise the bleeding and repair.
There is one more point I wanted to highlight.
Thank you, Ginil. All the 3 points are extremely valid. So the first point about reperfusion injury in liver is a beautiful organ, unlike kidney. It can process anything that you throw at it, liver will process. Whereas the kidney is not capable of that. So that is the reason for the reperfusion injury being very commonly discussed. But is there an evidence, a body of evidence to support it? There is no body of evidence. In terms of early unclamping, all of us are doing it. I just skipped the video and showed. Nowadays, after the inner layer rhinography, I always unclamp. And sometimes I leave the inner layer rhinography and come out, don't even do the outer layer, especially if the crater is too big. That is the second point. I agree with that as well. And lastly, mannitol. I still use mannitol, even though I know very well there is no evidence for it.
Raghavan sir, some people coagulate the surface and close outer rhinography like Dr. George P. sir. Some people individually suture the vessels also, especially hilar tumor. Or clip if you are intelligent enough to know the before cutting it. I want to know your comment. And some people close very closely inner rhinography to very, very close bites with, and as you said, now outer rhinography is not indicated. These three things. When will you suture the vessel? When will you coagulate and directly close? For example, peripheral tumors, so to reduce the warm ischemia time.
So the first point about just doing outer rhinography and not doing inner rhinography. I come from the other philosophy where I believe strongly inner rhinography is more important than the outer one. And that is my thought. I'm not George P. sir. I'm not going to, he's a doyen and therefore I'm sure he would know what he is doing. Second point about the suturing of the vessels or inner vessels. Now, if you are doing open surgery and you are able to see the individual vessels, as I said about the GGK sir's operation, it was beautiful to do. And as you rightly said, we can individually clip and ligate. When you are under cold ischemia, you have a lot of time in your hand to handle these things. But when you are in a warm ischemia time, it's very difficult. And since the advent of the fishhook sutures, the inner raphy has become so good that if you are able to exactly take the bite, covering those vessels as well, and then cinch everything down, it really works. Now, all of our series, we in fact collated the series between 4 of us. We had only about 3 pseudoaneurysms which needed, attention to. So our pseudoaneurysm rates are not very high as well. Compared, even the world literature is about 3%, whereas ours is about 1.2%. So that's the second question. Anything else I missed?
Coagulation of the surface outer rhinography before releasing the clamp. Not much useful.
Not useful.
So
in fact, that causes more damage to the parenchyma as well.
So
I think it all depends upon the time you are taken to do the resection. If you are finished in 10 minutes, a complete resection of the tumor, if you still have 15 minutes, and I would like to do a ligation of the or transfixation of the vessels individually. But if you have taken already time nearly 15 minutes or nearly 20 minutes, then you have to really be quick at inner layer suturing. So I prefer to take
the individual
suturing.
So one single question, sir. What about the outer rhinography? So here, outer rhinography. Some people have observed taking continuous sutures as opposed to the interrupted sutures and cinching with the hemlock. The same.
You need a superb assistance to do the continuous V-lock suture, because what you need to do is take one bite, cinch it. You have to take the other bite. You should know when to cinch that, when to cinch this, when to cinch that. It takes an effort. I work in a center where I have a registrar who assists me on different days with different registrars coming in. So I need to break it down to simple structure so that even an ordinary person like me can follow that. Simple instructions: cinch, stop. That's it. That's all. It is perfectly all right to do that as well, as long as you have a good assistant who can apply the hemolock and you're doing it, or you're doing it yourself. That's okay.
Thank you.
Other hemostatic method, in the slide of other hemostatic method, the last one, hydrogen peroxide, was put, sir. So have you
That
any
is very.
experience with that, sir? Just
I learnt it from my registrar, who learnt it from Ganesh Bakshi. Ganesh Bakshi uses it in Tata. So what he does is, after he does the inner layer closure, he puts hydrogen peroxide gel, soaked gauze piece into the crater and leaves it for about 2 or 3 minutes. It almost makes the whole thing pale, leaves only the structure which are to be bleed will be bleeding. And then, as sir said, you can individually take a suture and close it.
Thank you.
Thank you, sir. That really, we are overshooting the time.
Thank you, sir.
So thank you very much
Thank
for
you
the
very much.
elaborate discussion on that. So after listening to partial nephrectomy and trauma bleeding, we are here having Dr. Nagaraj of Bangalore to talk about bleeding during radical nephrectomy.
I get a pointer? Pointer. Mouse, huh? Okay. Okay, the chairpersons, friends, at the outset, I like to thank the council, ASU council, and Surya Prakash for giving the opportunity to talk today. The bleeding during radical nephrectomy is not a common problem. It is only very rarely it can happen. You can assess which cases is going to bleed, like a tumor which is more than 10 centimeters. If the tumor is sitting at a hilum, or if you CT shows that there are a lot of lymph nodes which are very close to the hilum, so you can expect some bleeding. And you all know that 90% of the tumors, the renal masses, are highly vascular. So these are the situations where you anticipate and be ready. And most of the times we are not ready with all the things what I am going to show today. You have to keep a blood. If you don't have the blood reserved, ask the patient to donate beforehand. That is not the practice in India. So now coming, next slide please. I can change here. Now here is the scenario. Most of the times when you do radical nephrectomy, the bleeding is less than 100 ml. And severe bleeding occurs only in 2 to 5% of the patients. And the blood transfusion rate is very, very low. So that doesn't mean that when you are doing a radical nephrectomy, that don't reserve blood. Most of the times we do only the blood grouping is done, but it's not reserved. So I'm going to show, you may be little shaken with the pictures which you are going to see. Probably you like to reserve some blood and go inside. Now, what are the causes of bleeding? One is the port insertion per se. Now, why I am telling here is, majority of the times, majority of the people use varus needle and then put the port. A blind insertion can produce problems. I had an experience where a company guy gave a Visi port, so where we can put a telescope and go inside. And unfortunately, this fellow was an obese guy and a lot of fat. I did not see the bowel. I was going inside, I did not see the bowel at all. Till we see the bowel, we had to go inside and then take out that. Then finally, I went and hit the common iliac vein at the sacral promontory. There was, when I removed the telescope, there was bleeding. Then I realized that there is injury. So unfortunately, we could open out and suture that iliac vein and patient became all right. So this is common problem, can happen. So I always do a open technique, Hassan's technique, where make an incision and then you see the layers and then take a artery forceps which is blunt, dissect out and then put the primary port. Vascular injuries is the commonest cause for bleeding in radical nephrectomies. Vessels like renal artery can get injured, renal vein can get injured, IVC can get injured, common iliac vein can get injured, external iliac vein also can get injured. I am going to show how the external iliac vein we can injure, external iliac artery can be injured in these procedures. Now, a few words about how to prevent this bleeding. Now, the lap anatomy is very, very important. Most of the people are used to the open anatomy. Lap anatomy is little different. There is a magnification, and if you are not aware of these things, an injury can occur to the major vessels and bleeding can occur. I am going to show in my next slides, use blunt dissections near the pedicle. Either a suction tip you use, or there are people who are manufacturing the Teflon tubings which are stiff enough to do the dissections. If you use scissors, what is going to happen? There are some experts who always go with the scissors. It thinks how it can happen because the complication percentage already mentioned is not that high, but that can be prevented if you use these blunt instruments close to the hilum. And when in doubt, when you anything that okay, whether there is a vessel or no vessel, when there is a doubt, just clip it and cut rather than of blindly cutting it or using a monopolar cautery and then cutting it. Then do not tease tissues. There is a tendency, I have seen some laparoscopic surgeons hold it in both hands and keep on teasing it. So there will be a small vessels in the renal, the gyrota fascia surrounding areas which will bleed, makes things messy inside. So don't do that. And then as far as possible, you have to use electrocautery. I'm going to come to that. What is the type of electrocauteries? Use ultrasound scalpel if you are if you have that. Otherwise, it is not a very essential instrument. The harmonic scalpel. You can use a monopolar and bipolar and finish majority of the surgeries laparoscopically. And then avoid touching the major vessels with the harmonic scalpel. As soon as we dissect it, we try to go close to the artery and touch it. It's okay if renal artery touched. Anyway, we are going to do a nephrectomy. If you go and touch the aorta or the IVC, it is going to be a messy thing and we have to take a suture. So be careful about that. When you are using harmonic scalpel, when you're dissecting it, activated it, you go and touch the fat somewhere and then come back and touch close to the vessel. And then I've seen this. The best way of preventing bleeding is go to the artery first, clip it, and then go around wherever you want it. So I'm also going to show, if you're not able to go to the renal artery at the earliest, so which is the other way where we can go in between especially on the right side, go between the IVC and the aorta and then clip it there. Then you have a lot of time go around that and dissect out easily. Now the techniques of hemostasis, one is permanent, where we use sutures, clips, staplers, energy sources can be used. The temporary is Satinsky clamp. Oh, already the bell is buzzing. So please give me time, secretary. I am going to take little time. Temporary are Satinsky clamps, bulldog clamps, graspers, and then when there is bleeding, increase the abdominal pressure to 20 centimeters or 20 millimeters of mercury. It will help us to a little extent. When you are clipping a vessel, these are the precautions you should take it. And then the clip, it should be safe, locking should be there. You should hear the sound of the clipping. Use the appropriate clips. Don't use a smaller clip or a bigger clip. When you use a smaller clip or a medium-sized clip, sometimes we cannot clip the renal vein. So what is the technique, how you can do it? You can, I'm going to tell, pinch the vein and clip it. And then leave 1 millimeter of the cuff. This is the classical teaching. And then avoid titanium clips, I'm going to show there. We should not use titanium clips on the renal artery or a renal vein, which are very dangerous. So I've seen that some people are using it. The most reliable way is by suturing. Now, what is the suture material we have to take? Laparoscopically, don't use the proline suture because they are not that easily, the memory is so much, it is very difficult. Only a seasoned, experienced surgeon can manage the proline. You can use a vicryl, and 2-0 vicryl is the best laparoscopically. Robot, if you are using 3-0 vicryl is well fair enough, but because the 2-0 vicryl, the needle is bigger and it is very easy to take through and through and then take it. I am going to show how you can use it. So these are the few equipments you should have when you are doing a radical nephrectomy, especially when you are in the beginning stages of laparoscopy or robotic surgeries. Better have these things. One is the Satinsky clamp. Ideal if you have it 10 mm or a 5 mm. If you have both, it is very good. And then you should have a suture material which is of not more than 10 centimeters length. If you take too long also, it is very difficult to handle it inside, and one side it is clipped, put a hemlock clip so that you can immediately take it and lift it up. So it helps you a lot. So this is called a rescue table, some people call it, a rescue stitch, this is called. So better you keep it ready, you put it inside the abdominal wall. So this is the other important thing what Dr. Raghavan is insisting. If you are not confident it's going to bleed inside, take 1 or 2 gauze pieces inside, put them, either spark it properly so that you remember and pull it out and plug it inside. It's very important. This is what the rescue stitch which I was telling. You take it, but don't leave it free. You fix it to the abdominal wall. Whenever you want it, pull it out. You pull it out through the hemlock clip side, not to the needle side. It will come out. So this is how it is beautifully parked in the abdominal wall, so you can identify and take it. So this is what I was telling. If there is any bleeding, you take a suture, you can blindly take it, or you put extra ports at that time. Instead of 4 ports, you can put 2 more ports. Ask your assistants to help you. Somebody sucking it, and then somebody pressing it. Take a suture and lift it up. Then everything will become very easy later on. So this is how. There was a bleeding, we sutured it and lifted up, it has stopped it. Now this is what I wanted to show, that how to identify on the right side renal artery in between the IVC which is lifted up, and then the renal artery is seen, aorta. You have to identify the left renal vein just behind and below the left renal vein. You see the renal artery pulsating. There will be some lymphatics which is covering it. Slowly you tease them off, and then you make a little space. You need not go and dissect it too much also. Then put one hemlock clip. Leave it there, go around. It is very handy. Now I put this slide to insist, to impress that you always use a bipolar forceps in the left hand, because it is like I am using it for the past several years, almost 15 years. I am using a bipolar forceps in the left hand and then a monopolar cautery in the right hand. The bipolar forceps Indian makes has got a very good, nice jaws. It can grip the tissues very well. Serrations are very good. So any bleeding, immediately burn it, or any doubt, you burn it at 2 places and cut it with a monopolar on the right hand. So this is what the slide I showed, that bipolar forceps which is costing about 5,000 rupees, and we can use it for any number of 100 cases, and then you can throw and buy one more one. Now this is what I was showing, that never use a sharp instruments close to the hilum. You see that the hook is damaging the renal vein, and since the bipolar forceps is there, you see, it's at this juncture you can ask assistant to put one more port and then somebody to suck and show it. See, that suction will give us some view of that. Now you burn it and by some time lift the tissues up. That will also help you a lot.
Nagaraj sir, very sorry that I have to interfere in you.
Yeah, I'm
Take
finishing.
A little longer. Okay, make it a little short, please.
Okay. See, this is one more case where the sharp instrument damaging it. Now, this is a picture I am showing to avoid putting titanium clips, which is dangerous, which can slip when you are operating it. Now, this is one more where the accessory renal artery, when you are clipping it, see it is bleeding, and it is very easy to put a pressure and compress it. So this is how you can manage, but you should be ready with some of the very simple things, gauze piece and Satinsky forceps, and then additional ports which will help you to minimize the bleeding during radical nephrectomy. Thank you.
Thank you, Dr. Nagaraj. As we are running short of time, I think there will be no place for question and answer. Thank you.
thank the speakers and chairpersons for this session. I request our President, Sir, Dr. Ayodhya sir, to felicitate the speakers by giving a certificate. Dr. Raghavan. Dr. Raghavan. Dr. Lakshman Prabhu.
I need a word with you.
Nagaraj sir.
Thank you, sir.
They want to go for lunch. We are running at least 40 minutes late. There is a small change in the program. As per the organizing committee, we'll break for lunch for half an hour. Then we'll assemble again. Exactly half an hour. Now we'll assemble in the hall by 1:30 for the case discussion. For lunch. Next is case discussion.
This is one term.
Yeah.
More program.
One more. So we are going running late. Yes. So 1:30 will come back.
You can leave the feedback forms if you have filled in the registration counter or with me. The feedback forms, if you have filled, you can leave in the registration counter or with me.
This is my first time, sir. Please pardon me if it.
Start it.
Yeah.
They are already
Very good afternoon, teachers, seniors, and my friends. I profusely thank ASU and the organizing team for giving me this opportunity in this forum. So I thank our panelists today for joining us for discussion. So since morning, we have been listening a lot of lectures regarding this upper tract bleeding. We have gained a lot of knowledge, and it is time for us to put those knowledge that we gained into practice. So I will be presenting you real case scenarios where we have faced bleeding I'll be discussing with our panelists, and they will be sharing their inputs and insight and knowledge and literature support, and also how their experience, how they will come out of those situations. After that, I'll be showing you how we have come out of those unfortunate situations. Whether it is right or wrong is open for discussion, and we'll start with all important PCNL first. This first case is a 25 mm stone in the middle calyx and lower calyx. This case was done by our fellow. This is his first PCNL. He is very excited about it, and he has done this puncture and parked this guide wire. So I want a quick comment from our panelist. Sir, your comments on this puncture, and what is the ideal PCNL tract that you define?
Thank you, Hemnath. As far as the ideal PCNL track is the one which is straight and closest to the stone with the least complication, and one would prefer an inferior calyx, posterior calyx.
Okay, sir. This puncture,
So
in your view, is good.
This seems to be good from
Yeah.
what I see in a uniplanar view.
Yeah. So this fellow, he is very excited about his first successful puncture just when the sister told that there is fresh bleeding in the Foley's. So now what you will do, sir? Whether
It's very unusual to have just blood in the Foley's and no blood in your initial puncture needle. So I don't know whether you have noticed blood in the puncture needle
that was
as well.
almost clear, sir, not that frank. It was it was little reddish, but not to the alarming extent.
First thing what we do is we normally stop the process, wait for a while, see whether it clears up. If it doesn't clear up, then you remove the guide wire which you have kept, give sustained manual pressure with both hands as if you're doing a bimanual examination of the kidney. Hold that, and then if it clears up, you are allowed to proceed. If it doesn't clear up or if it increases, then it's better to abandon the process.
This guy panicked and he called the senior for help, and what our senior consultant did is he has done, as you told, he has removed that puncture guide wire and took a separate puncture, dilated and finished the case. Is this the right way, sir?
The previous slide, that is not alarming bleeding.
Yes, sir.
You can see the light is reflected. It is not a fresh bleed.
Yes.
And the puncture is perfect. I would not have gone to the other calyx. I would have, that if you would have used the same thing, the fellow would have more confidence
Okay, sir.
continuing the procedure. Now he is panic.
Yeah.
So puncture is perfect, not much bleeding. I would not have gone for other calyx.
Yes, sir.
I would think that whenever there is a bleeding that is seen in the Foley's catheter like this, with just a puncture, there would have been a significant bleed there. I would not continue dilating this particular puncture at all because it is in the Foley's. So there must be some, and the bleeding would be pretty significant because within few minutes it has come to the Foley's, that to dark red.
Yes, sir.
So I think it is bleeding from that puncture side definitely and quite severely. So I'll definitely do some other puncture, not that.
So yes, sir.
I want to expand on his point. He said it's his first case, so he has to get the confidence that he proceeds. He's right. Because every time if he sees blood, if he's going to abandon the procedure, then he's not going to move forward in his training. But the caveat here is that he waits, because blood in a puncture, slight blood is fine. If it clears up, he proceeds. If it doesn't clear up or increases, then he has to have the prudence to postpone or choose another calyx.
The other way around, it is, we don't know, that's what, the ureteric catheter caused bleeding, or when you do a cystoscopy, that is caused, that we don't know. But the puncture alone will not cause this.
Yes, sir. We'll move on to the next case. So the second patient is a 27-year-old, perfectly healthy female, walked into a clinic with a complete stag on the left side. So we have planned a prone PCNL for her. We took a puncture, it's almost like a RGP, the stone is filling all the calyces. We took a puncture in the lower calyx, dilated up to 30 French, and also took a puncture on the upper calyx for if at all needed afterwards in the surgery. So the surgery was going on, the vision is not perfect, the FLX is also not that clear. Up to 90 minutes we were doing the surgery and this happened. The anesthetist told us that the patient is almost collapsing, BP is down and she developed tachyarrhythmias. So I want to ask you, so in these case of complete stag-on, sir, when do you decide to stage the procedure and what are the parameters you see to stage the procedure? Whether it is time or you wait for the anesthetist to tell you or some crude criteria like blood full of blood in the bucket. What is your criteria, sir?
I would have staged it when I had a consultation in the OP itself.
Okay. Pre-operatively itself?
Pre-operatively, I would have told that this type of stone, I am not going to clear in a single stage. You may need a multiple stages. So that the consultation begins with a staging procedure in this type of stone.
Okay, sir.
And 60 to 80 minutes, there is no hemodynamic instability, can continue that. If there is a hemodynamic instability, put a nephrostomy, come out.
Okay. Any other difference of opinion, sir?
I think you have put down that last thing, blood loss. Surgeon fatigue should not be the, how can
some other crude criteria.
How can the surgeon?
One of our senior consultants used to joke that I'm getting raw smell of blood, please stop the procedure.
Then it is okay.
Somehow 90 minutes is too short a time to, I don't think you can define 90 minutes.
Progressively
Because you can do
slow
a
amount of-
PCNL up to 4 hours.
Yes.
As long as you've taken the precautions.
See, a normal head health male, usually persons we operate, fortunately for us, are not like the medical ward patient. They're all good, healthy adults who come to us. Most of them, if they don't have renal failure, their hemoglobin reserve also will be high. So their reserves also high. So easily 30% of blood volume they can tolerate. And this patient has lost more than that, so he has reached that critical stage. Most likely it is because, one, the surgeon is not very clear. Your effluent coming around the nephrostomy will be very red. So you have to differentiate between red and very red. So you operate a patient in cardiothoracic surgery and come, he'll say that patient has hematuria, come and see. There you see it is just light pink and you're not worried. The opposite is for a urologist to feel that. So you should be aware of what is happening. Second is the anesthetist also, I don't think had been anticipating and keeping up with that blood loss. So now when you reach that critical level where 30% of the blood volume has been lost and he is now decompensated. That's why you have such severe tachycardia with such severe hypotension. So that stage shouldn't have been reached. Before that, surgeon and the anesthetist should have been aware that the blood loss is going out of hand, and then they could have replaced and they could have asked you to stop, and you could have stopped and put a tube and come out. So you won't reach that situation. You know it's a big stone. You know all the factors Bobby has told. Very clear that these type of stones can require stay. They will have increased incidence of sepsis. They'll have increased incidence of blood loss. They will have lesser clearance.
Yes. What would be your exit strategy in this case?
Ready for these type of cases?
Definitely we will reserve 2 units, sir, in these stag-on patients. Even for all PCNLs, we keep a reservation. But we don't procure it, but we reserve it.
Blood ready means for PCNL. Only stag-on or all the PCNL?
Any patient
Every PCNL, I think you should cross-match. Because you never know which one is going to bleed. Even the simplest stone can cause a bleed. I don't think any surgeon for that matter can say, okay, this case won't bleed.
Okay. What would be your exit strategy, sir? Whether what you like to keep, whether a Foley's or use any of these things, what we have seen in textbooks, this case nephrostomy tube or a counsel catheter or regular Foley's?
Not Foley's. There are nephrostomy tubes are available in different sizes.
Yes.
So we'll use a nephrostomy tube. These tubes are, I have not seen.
Yeah. Yes, sir. Thank you.
These kind of scenarios not only in bleeding but also in sepsis. Sometimes
Yes.
we have been to endotoxemia.
Sepsis is also one possibility in these patients. Yes.
See, we constantly hear about these tamponade balloon catheters. Can somebody put up a hand in the audience? How many of you have used this? Okay, Dr. Ramalingam. Anybody else? So two. So it's very, very rare. I don't think any of you stock these tamponade catheters also.
Okay. So if you want to stage the procedure, what is the gap you give for this patient?
Usually this patient had a hemodynamic instability. I don't want to go
Not
back.
this patient, sir.
Normally, if there is no hematuria and the hemoglobin drop is not much, after 48 hours, I will go back and do this.
Okay, sir. So this patient had a very turbulent post-operative course. She went into hypotension. She was on inotropic support, ventricular tachyarrhythmias to the extent of stress-induced cardiomyopathy. We had to shift her to a cardiac center. They have done something called intra-aortic balloon counterpulsation to stabilize her. And even after all these things, after 3 months, she came back to us for the residual stones. She literally begged us, she doesn't want PCNL this time. So we have to clear those stones in a staged manner with RIRS. This is how this patient.
Yeah, I think one glaring issue with this patient is somebody has not been monitoring this case intraoperatively.
Yes.
27-year-old, young female, no comorbids, has suddenly precipitated a hypotension. So which means nobody has monitored the blood loss. So that is an important aspect.
Yes, sir. I agree with that, sir. I was doing the case. So I also got carried away more because young female. It was a very bad experience for us. In PCNL, patient going to stress cardiomyopathy and on ventilator in the post-operative period. And they are from Deputy Collector of Chennai, came to Hyderabad and got operated. We were really worried. That's why I told to present this case. I carried away for more than 1.5 hours. If you are progressing continuously, 1.5 hour PCNL surgery is too long, I feel, even whatever the expertise is, unless it is clear without any. And one more thing in between, if you see the bucket, you will get at least idea. Anesthetist might have been much more alert in this case, as you said, sir.
Okay.
He might have stopped me when tachycardia was around 100. I feel tachycardia more than 100, we should stop crude criteria, I mean to say.
When we have problems in Chennai, we usually go to Tirupati Balaji or your place.
Okay.
This is the last point that Chandramohan has come. When do you say that, the 100, what is the tachycardia or blood pressures won't fall so early?
Yes, sir.
So what is the criteria when you think of staging that intraoperative?
One very wise house surgeon told me, okay, very wise house surgeon. You take the message from bottom, it is very good. If the pulse is higher than the systolic blood pressure, systolic blood pressure falls lower than the pulse, time to get worried.
Okay, sir. We'll move on to the next case. The third case is a middle calyceal and lower calyceal stone. The surgery was done by a junior consultant. So as Bobby sir told in the morning, until the last ball is bowled, the match is not over. This is a perfect example, I think, this case. Almost a good puncture and a guide wire parked in. This is a supine PCNL and the tract dilated up to 22 French. There is no blood in the needle or during the dilatation. Vision is perfect. The pneumatic is used. This case is over within 20 to 25 minutes. Everything was going well. The consultant kept the nephrostomy and after that this happened. So my question would be, sir, would you keep a nephrostomy in this uncomplicated PCNL where from puncture to the stone removal everything was going perfect? Would you keep a nephrostomy in these cases? So no requirement of a percutaneous tube in this case. This is a Foley catheter. Foley catheter.
Come out of the track.
Okay, sir. So the mechanism of hemostasis after a PCNL is collapse of the parenchyma. there are two schools of thought that nephrostomy doesn't allow it to collapse, or some people tell that the nephrostomy acts as a tamponade also to close those bleedings. It would be helpful in cases where you find a intraoperative bleeding, the system gets clotted off and will clamp the nephrostomy. In this case, whether the nephrostomy would have been a cause for bleeding. It is not allowing the parenchyma to collapse.
No, no, that usually doesn't happen unless the nephrostomy has slipped out.
Okay, sir.
It's not allowing the, yeah.
It is in the system, sir. We have done a contrast, it is in the system. So what would you do next for this patient, sir? How would you
What
tackle?
size nephrostomy did you put?
16 Foley's was being kept. There's a 22 dilatation and a 16 Foley's.
Just close it clamp it for a couple of hours and watch.
So, okay. Okay. Okay, sir.
No, but Karthikeyan, see, when you're doing a procedure which is relatively uncomplicated, straight and simple, you have gone to the extent of not even keeping a tube. You're talking of a completely tubeless PCN. On the other hand, you're also saying that the tube which you keep is small in size. You have to keep a larger tube. So where is the bridge between these two theories?
Now, studies are showing that
what I'm
smaller
trying to
size
tell
is
you
enough
is,
for bleeding control.
yeah. Yeah.
That fact is well known. The size of the crack can cause pain is the factor that will be disturbing. The size of the tube. The larger the tube, the larger the post-op pain. That's why the tube sizes have come down. If they cannot see the break, so it's all reduced. That's because of pain. 15 minutes. It's not to reduce the bleeding. Okay. The indication would be again large for infection or blah blah blah. So if it is a straightforward PCN, not no intraoperative bleed, this patient probably wouldn't have needed a PCN.
Point taken, sir. Yes, sir. Okay. So, smooth extubation also is a factor. Yeah, okay. Okay, sir. Thank you. So, what we did for the patient is again we called for the senior consultant's help, and he came and removed the nephrostomy and put a pressure, and then magically the urine got cleared. So, with irrigation in 24 hours, everything was fine in this patient. She got discharged. Nothing, sir. Post-op ultrasound is clear, and so this nephrostomy might have been the culprit here.
Did you put a stent for this patient?
Yes, sir. Stent was there. Everything was complete, sir.
So
Stent.
what was the efflux from below?
Efflux, we had to actually do a clot evacuation in this patient. Yeah.
Okay, okay.
Completely red. We did a clot evacuation and put a 3-way catheter and irrigated. So after the nephrostomy removed and manual pressure, the bleeding got stopped. This is, so literature, yes, sir. Yeah, yes, sir. Thank you, sir. So literature shows, as already discussed, in nephrostomy versus no nephrostomy, and size also doesn't matter, and supine versus prone, no difference. Standard versus mini, definitely mini is better. And the next case.
No. So wait. It's,
definitely intraoperative vision will be little compromised, sir. But as such, there is no difference in the post-op hemoglobin drop and the blood transfusion rates.
No. You said standard versus mini, there is no difference.
There is difference, sir. Definitely mini, there is less blood loss, but it has not...
Stone-free rates?
Stone-free rates.
The duration of surgery goes up in mini.
Yes, sir. Definitely. Yes, sir. Oh, that's what we were discussing. Probably the nephrostomy tube size disparity, as somebody has told, and probably parenchyma to collapse. probably it might have slipped out also. That is one reason.
Most common theory after discussion like Keshavamurthy sir telling that if it is half in the tract,
Yes.
it will never allow to stop.
Yes, sir.
Usually removal is the best way. Tamponade can happen. So
It's
it's
a
in the
parenchymal
parenchyma.
bleed.
Most probably it is in the it's a parenchymal bleed.
Yes, sir. Thank you. We keep a Foley. No. We tried inflating in this case, but it was creating more trouble. Pardon? No, it's individual choice. Whether you can use an Ellerton catheter or Malikots, it's individual choice. Yes. Yes, sir. Thank you. So this next patient, he had relatively smaller stones. He was he underwent PCNL 20 days back, and they did a clot evacuation on the 10th day. He had intermittent bleeding since that time. He was referred to us on the 20th day with again a clot retention. In these 10 days, there is significant drop of hemoglobin, 2 grams percentage. And this is the organized clot we found when we received the patient. And after doing a clot evacuation, we found bloody efflux from the right ureteric orifice. So, what would you do now, sir?
No, usually the bleeding after 2 weeks, it's mainly maybe because of the pseudoaneurysm or AV fistula.
Okay, sir. When do you plan for angioembolization in this patient? Whether
I would
right now?
I would do a Doppler, ultrasound Doppler study.
Okay, sir.
If it shows there is a turbulence in the flow pattern, if I consider there is an aneurysm and there is a hemoglobin drop, I would go for an angiography.
If the Doppler is normal, sir?
Doppler is normal, I will observe for a day or two, then we'll take a call.
Okay. Any other?
I would slightly differ from him because this person has already had a
2
documented.
times clot evacuation.
Yeah, he had a transfusion drop in hemoglobin, has come after 10 days. So your diagnosis is more or less clear that he's got a AV malformation or a pseudoaneurysm. So I will proceed straight away with that.
Okay, sir. We have done we have sent to a senior intervention radiologist, and they have told that angio is normal. So, how often you see this, sir? Normal angio in a bleeding patient, macroscopic hematuria is there, clots are forming. How often do you see these kind of findings in angio? He is bleeding, sir. He is bleeding on a continuous irrigation. Even on the morning of this angio, we have done a clot evacuation and put a 3-way irrigation and sent to the. Okay, sir.
Yeah,
That's
but
what.
see,
That is a lesson learned. This patient, even with admission and irrigation, he had continuous hematuria, and still the efflux is bloody in this patient. So 2 times clot evacuation repeated. We had no other option to again go for a repeat angio, and this time they could find a small pseudoaneurysm in the middle calyx. So
it didn't exist during the first angio?
first time they couldn't find, sir.
So it's
a
case of-
technical,
yeah.
probably technical error or I don't know, sir. Probably. Yes. I don't know whether they have done. Okay.
But that's
Okay,
a
sir.
standard practice among angio, right? Whoever is
Probably
doing the
they might
intervention.
have. He is a senior interventional radiologist. Probably we should take that he has given the papaver. Okay, sir. If he is,
It's only a diagnosis. On the other hand, the whole idea is you want a diagnosis and you want a management. So in one shot you can cover both.
Whether
But if
CT
you just
angio
do a
would be
CT
better.
angio, you're not going to get the chance to embolize.
Okay. Yes, sir.
There is no role for any other investigation other than that.
Yeah.
But a Doppler, it is not going to tell anything. If a Doppler is negative or positive, you still have to do an angio. CT angiogram is not going to tell you anything. think you're wasting time by doing all of the investigation. This guy needs only an angio.
So repeat angio is worthwhile, sir, in these case scenarios. Okay. So.
Where they had actually done angio, it was negative. So the nephrostomy was still there, so surgeon went in and they found a spurter, arterial spurter on the pelvis, and they used the laser and perforated and did it.
Okay.
So the reason is that sometimes it can happen, but extremely rare.
Rare.
So angio is the way.
Okay, even multiple times repeating is worthwhile. So pseudoaneurysm is the most common cause and success report for first time is 90%, failure rates around 17%, second re-embolization would be successful in 94% of the patients. So coming to the RIRS, as Karthikeyan sir told, we should not take RIRS lightly. So already Chandramohan sir has already discussed this case, so I will directly go to the sir, this patient had a 2 centimeter stone in the upper calyx, wanted badly RIRS. So we have done with the homium laser. So as is a big stone, we went for fragmentation earlier and then popcorning. So during popcorn, suddenly the vision got lost. So the surgeon is going for fragmentation here. Can I get the cursor? Move. No, I cannot fast forward this video. Okay. So after starting popcorn, the laser accidentally touched the mucosa, and this is the scenario now. Fresh blood in the access sheath. So what would you do now, sir? As I already discussed this case, so
Laser stent.
yeah, as fast as possible, we should come out of the system and place a stent, and we should.
Give something like tranexamic acid and all.
Yes.
Which helps.
So we removed the access sheath and passed a guide wire through that. Lasix we usually give around 30 minutes into the surgery, sir. Yeah, if we stay inside the system.
And
so
the room temperature should be, too much of cold temperature also destroys the coagulation effect of the. So I think it should be brought to the room temperature.
Okay, sir. So we should remember that the huge clots can form in the bladder. We should do a clot evacuation before we keep a three-way Foley and irrigation. So this patient had no bleeding after 24 hours of irrigation. So
warm saline would increase the bleeding because it would do some amount of vasodilatation. So warm saline is not to be used in PCNL. It should be a room temperature saline.
No,
because there is some amount of vasodilatation with the warm saline.
Yeah, but that is only regional. It is not going through the blood. You have a certain degree of drop once you go beyond 60 minutes of using the PCNL irrigation fluid, which is at the AC temperature of your theater. So that once it causes hypothermia, it affects the platelet function also. So once the bleeding starts, you also have absence of coagulation. So it becomes a vicious cascade.
Sir, as far as my knowledge, in RIRS, no warm and no cold saline is advised. Not at all advised.
Not RIRS.
No, sir. In
stag on long process.
No, sir. Even then, as of now, no, sir. You are already saying that RIRS with TFL is causing increased temperature. It is not at all proven, sir. For that, cold saline usage is not at all proven, sir. I am 100% sure. 100% sure. This discussion multiple times happened. 100% sure.
So in extension to that case, this is again a TFL laser in the middle calyx. While we are dusting and chipping on the edges, the laser fiber accidentally touched the calyx, and this is the scenario now. But in this scenario, the bleeding was not alarming as the previous case, sir. So what would you, where do you?
You'll do the same steps again.
Yes.
Give Lasix, wait for a while. If it clears up, finish the process. Otherwise, put a stent, come another day.
So we have not stayed in that calyx for a long time. We came out into the ureter and waited with irrigation. And after 5 minutes, everything settled and finished with the popcorn. So next is a interesting case. This is a impacted upper ureteric calculus planned for RARS with almost a gross hydronephrosis and a thinned out parenchyma. We have done a primary RARS in this patient. So the stones were broken in the upper ureter and pushed into the system, and then laser done. Everything went well, but the post-operative patient had severe loin pain, and this is the post-operative CT. Subcapsular hematoma. So what would be the reasons for this formation?
That's what was the pre-op function, split renal function?
Split renal function we have not done. That should have been done.
If you look at the picture of that kidney, the parenchyma is already thin.
Yes, sir.
So this is a chronic obstruction.
Yes, sir.
Yeah.
So
impacted stone, very high chance of perforation.
yes, sir. Either a PCNL or a staged RARS, like a stenting followed by RARS would have been a good option in this patient to avoid this complication. Urine culture is negative, sir. So this patient required open drainage of the hematoma because of persistent pain, and he was fine after that.
Why
So
open drainage?
this was an organized clot, sir, that was not liquefied. It was around a 10 centimeter size, sir.
No, see, you notice the subcapsular hematoma when you're operating. Am I right?
No, post-operative.
How many
Around
days? How
10
many
to
days
14
post-op?
days,
14
10
days.
Yeah.
Post-op.
Post-op. It's an organized clot. We have to do an open drainage. Yes, sir. Last. So laparoscopy. I'll show one case. This is a partial nephrectomy. Renal score of 7x. Almost exophytic tumor in the middle and the lower pole. So we were creating a lower window. Some vein tributaries were there, and in the upper window, while creating the upper window here, we have used a blunt dissection here with the suction cannula. While doing this, a tributary got snipped off from the renal vein, and it was bleeding. So when we are doing this blunt dissection, near the renal vein, one tributary got snipped off, and flush with the renal vein, now there is a rent in the renal vein and it is bleeding. This is a partial nephrectomy. We have posted for partial nephrectomy. What would you advise, sir?
No, there is a pressure, put a gauze and wait for some time and get a clear picture. And always when you do a laparoscopy, try to have a rescue stitch. Morning, Dr. Nagaraj has shown that.
Yes, sir.
And if it is not settling down, it's a venous bleeding. You can take a rescue stitch.
So we can proceed with partial nephrectomy as planned laparoscopically. Otherwise, if we are not experienced, we can do
can
a
go for
open.
open and-
Yes.
What about the use of increasing the pressures during an intra-abdominal
bleed.
pressure?
Yes,
You can differentiate between a venous bleed. Sometimes you do that, no? Increase the pneumoperitoneum.
To raise the pressure up to 21
Yeah.
or 22, so that, yes, sir. Yes.
Increase the pressure.
Okay.
So when the renal vein is open like that,
No,
then,
this is
then
a-
you'll have to completely take off pneumoperitoneum.
Kamath,
It's a negative system, right?
Kamath,
Yeah.
this is a very, very common scenario. You have many times a small vein going to the, coming from the adrenal, getting into the upper border of the renal vein. So on the right side, look for a small tributary always. Quite often we find it, the moment you try to do some blunt dissection thinking that it is very safe, and then you do with a suction, it snips up from the upper border of the vein. So you keep a gauze piece, and if you have a bulldog, apply on the artery. That's why all the time you have to dissect the artery and keep it ready.
So
You can apply a bulldog on the artery or keep a certain ski. But certain ski will obscure the bleeding. But if you apply a bulldog clamp on the artery, then you still will have a
We have not still
little bit of-
dissected the renal artery. So we have just done a mass sampling temporarily, and as sir told, we have taken a rescue stitch was ready. So we have taken a 50 Prolin and repaired it and proceeded with formal laparoscopic partial nephrectomy. So this is that patient.
In this case, as Dr. Ginil and Raghavan was discussing, I had a doubt when I was doing this. I have to take control because direct taking bite may lead to nephrectomy. So I thought I will clamp, I will take the bite and then control. It took 2.5 minutes. After that, I have to release because I have not dissected the partial nephrectomy part. So after that, I proceeded, everything went well. That 2.5 minutes, does it cause any damage or not, was the discussion. But I did not have any choice because if I do direct suturing, it may end up with nephrectomy.
2.5 minutes on the renal artery.
Ah, yes. Yes, it will take a long time.
Okay. So we will conclude then. So the lessons learnt are hemostasis precedes anything else in minimal invasive surgery. Poor vision makes us to do more mistakes. We should learn when to stop, we should learn when to convert, or we should learn when to call for help. Thank you. Thank you for the opportunity.
Thank you, Dr. Hemnath. It was an excellent session, nice case session. Thank the panelists, Dr. Ganesh Kamath, Dr. Gopichan, Dr. Muthu, for a good informative discussion. We move on to the next session. For this session, I invite Dr. Mayappan sir to chair the session. Dr. Sridhar, Dr. Prabhakaran is here. I invite Dr. Musadik to chair the session.
Shall we start? TURP bleeding, Dr. D. Ramesh from Bangalore.
Yeah, good afternoon. From the upper track, we move down to the lower track, but still the theme is red. So at the outset, I would like to thank the Council of ASU and the Honorary Secretary, Dr. Surya Prakash, specifically for inviting me over to come to Trichy and talk on this issue on bleeding in TUR. TUR, of course, is the most common surgery that we as urologists perform both during our training period and during our careers as a urologist. And the bleeding is quite common in TUR in our practice in the initial days. And that is probably attributed to the vascularity that the gland attains as the gland enlarges in size. It's got a rich vascularity, both from the inferior vesical artery and the middle rectal artery. And you can see the plethora of vessels that are there within the prostate gland. TURP is still the gold standard in spite of all the minimally invasive therapies that have been attributed for prostatic surgery. And a lot of us in the Asian subcontinent and specifically in India believe that the minimally invasive therapies are occurring because people fear bleeding and people fear incontinence. These are the two most dreaded complications that all of us would fear about. In spite of all this, the updated guidelines, both by EAU and the AUA, still remind us that TURP, either using monopolar or bipolar, is still the gold standard and the preferred method of servicing the prostate. The largest data emanates in 2019 from the Canadian registry, which has reviewed more than 40,000 cases and have revealed a transfusion rates of 2.6% and a 30-day emergency room visits of 22.5%, out of which approximately half of them are admitted for either clot-related or bleeding problems. So the need for blood transfusion is generally considered as a surrogate for major surgical bleeding following TURP. All of us, when we do a TURP, this is the kind of urine that we would expect. or want to achieve following good resection at the end of the procedure, both for ourselves to sleep well and for the patients to recover faster. TURP bleeding is still the most common complication of TURP besides the absorption syndromes, and persistent bleeding will have its own morbidity and associated despair by the surgeon and the patients. The transfusion rate, if you look at the data of TURP before 1970s, shows a transfusion rate of more than 20%. And that is when TURP started. It started somewhere in the 1950s, the modern day TURPs, and early days there was a lot of bleeding. The dreaded complication was bleeding. In 1989, there's a large series which was reviewed by the Veterans Corporation study, showed a transfusion rate of 2.5%. Recent data somewhere in the 2013 showed a transfusion rate of 4.5%. But the Canadian registry is the largest data which is available, which shows a transfusion rate of 2.6%. We, because of this paper that I was going to talk, we reviewed our own data for the last 5 years. We found that our transfusion rates were less than 1%. And I'm sure most of the urologists practicing here will have a transfusion rate of around 0.5 to 1%. This is the index case of a medium-sized prostate, about 50 grams, trilobar prostate, which shows that the method of avoiding bleeding is to do a stepwise prostatectomy, go till the capsule and try to finish one area at a time. Do not resect multiple areas. People get into problem if you start resecting in multiple areas and you get bleeding from all around the fossa. So the systematic resection of the prostate, step by step, reach the capsule, get your bleeding early. You don't worry about the rest of incompletion of the prostate gland. The bottom line is be ahead of the bleeding. So this is just a quick video of a index case which shows that this is how the fossa should look clean, complete at the end of resection. Stop the irrigation at the end of resection and see that you're doing good. And this is what most of us would generally be following. And outcome for the patient and for ourselves to sleep well is quite good. The bleeding could be primary during the surgery. It could be reactionary post-op after the spinal anesthesia. All of us do these cases under spinal anesthesia. Post-spinal anesthesia, the PP might go up, or in the next 24-48 hours, there might be patient might strain at stools and he can have a bleed. That's a reactionary bleed. Patients, if they come back with a bleed 1 week to 1 month after the TURP, it's called a secondary bleed. And that is usually because of an incomplete resection. The residual tissue sloughs off because of ischemia and it opens up a bleeder, and that's a secondary bleed. The bleeding could be either arterial or venous. Arterial bleeders are usually very easily apparent during surgery. If you're doing your resection in a stepwise manner, arterial bleedings are easily seen. It's the venous bleeding suggests that you have gone deep, you have perforated the capsule and opened up the sinus. I'll show you a clipping of that down the line. And these venous bleedings are not apparent when you're irrigating because of the irrigation pressure. The venous bleedings are not very apparent. When you move your stream of fluid away, it starts bleeding and the whole vision gets clouded. What are the risk factors for bleeding during TURP? The larger the gland, the more the chance of bleeding. The longer the resection time, directly proportional to the size of the gland. And patients who are on antiplatelets and anticoagulation. These are high-risk patients for bleeding. I think enough discussion has gone on regarding patients, what to do on patients who are on antiplatelets, anticoagulants. My practice is, if patient is on antiplatelets, either ecosprin or clopidogrel, nearly 60 to 70% of our patients today are on polypharmacy. I stop them at least 5 days before the TUR. I am not a laser man. I do bipolar TURP, but I still prefer to stop the patients on antiplatelets 5 days before surgery. Patients who are anticoagulants, we bridge them. We convert them into heparin and then do the procedure under heparin and then take off the heparin and switch them back to their oral anticoagulants once they start passing urine and the urine is clear. What about patients who have got stents in place? There are clear-cut guidelines both by the AUA and other guidelines that patients who have got a drug-eluting stent, if possible, don't operate on them for a year because they will not stop them on antiplatelets. Patients who are taking warfarin, you can bridge them using heparin. The conventional warfarin is all right, but the newer oral anticoagulants are something which we are not very familiar with. It's always good to get the cardiologist on board, see how you want to do the bridging and proceed with the procedure. There are some people who do lasers. They are comfortable doing the ecosprin. I don't like to do them even with ecosprin. Method suggested to reduce bleeding is improving the operative skill. So during training, you should get adequate exposure to TURP and your surgical technique should be appropriate so that you do in a stepwise manner. There are novel resection devices which bipolar. There's always a controversy whether monopolar or bipolar is good. I would stick my neck out and say training centers should stop training residents with monopolar diathermy. You should stick only to bipolar. It is a safer method of learning TURP. You don't have absorption syndromes. You have lesser bleeding. There is data which shows that the amount of transfusions with bipolar and monopolar are almost the same. What is reduced with bipolar, the incidence of clot retention. That's why, otherwise the difference in bleeding is almost the same. The other non-surgical methods are, you could start these patients on 5-alpha reductase inhibitors, either finasteride or dutasteride. It reduces the VGF and reduces the vascularity if you start them 2 weeks ahead. I'll just run through 30 seconds of 2 videos with the permission of chair. This is a patient, we were finished the resection. You can see on using diathermy for coagulation, the capsular contraction. That's about time that suggests that you're near the capsule, you have to be very wary. In spite of that contraction, there was some apical tissue and we went ahead and resection. And as we resected, we see a gush of blood and there's a perforation there. That's a venous sinus that's opened up. So be very wary when you go near the capsule and you want to resect a little more near the apex, you will tend to go deeper very fast. This is another video. You can see this dark venous blood. This is a perforation in the left side of the patient, deep, and that's venous bleeding. That's a venous sinus. So we try to coagulate them. When the irrigation is directed to the venous channel, it apparently looks as if it stopped. But when you move your fluid direction away from that, it rebleeds. When you're reaching the venous sinus and you've finished the resection, one should not waste time trying to coagulate these venous channels. Go ahead and put a Foley catheter, increase the Foley balloon to about 40 cc's, put a tamponade. Invariably, you'll succeed in getting a hemostasis. When we look away, this venous sinus again opens up. So it's very difficult to get. So some tips is, you can start the patient on 5-alpha reductase, stick in one area of resection. If there's tissue there, you need to go deeper to the capsule to stop the bleeding. I'll run these. These are standard things which all of us have learned during our residency days. Is there a need for open surgery when there's bleeding due to TURP? It's hardly ever occurred. In my own experience of 30 years plus, twice we had need to explore the patient, and in both times I had to ligate the internal iliac. Even in packing, we couldn't control the bleeding. I had to ligate the internal iliac artery twice. I hope nobody gets that kind of a situation anymore. So number of times we need to open up for a patient with a TUR bleeding is very, very unusual, and it's very rare. I would be happy to answer some questions if there are any.
I do agree that bipolar is better because the incidence of TUR syndrome is also very minimal or negligible.
Yes.
The other thing is, when you said the venous bleeding,
yes,
it is more dangerous than arterial bleeding in case of TURP. Of course, the vision is lost and there will be a lot of irrigation fluid will go and will go off for TUR syndrome. So that is any.
Sir.
Yeah. Usually, this is slightly off the track, but related to bleeding during TURP.
Sir.
Have you ever seen adductor jerk happening during
Yes,
the
Yes,
TURP?
Yes. When we have
Can
a
it
large
happen?
endovesical prostate, when there's intravesical protrusion in the lateral lobes, if you try to resect deeper, you do get an adductor spasm. People say that you don't get adductor spasm with the bipolar. Even with bipolar, you do get an adductor spasm. We do see it occasionally.
Because if that happens, that again causes bleeding.
Yes.
Which is sometimes very difficult to.
Absolutely. I agree with you. What I found when I was preparing these slides is the textbooks of urology there's only a paragraph mentioned about bleeding in TUR. So there's hardly any write-up too much about in current day textbooks about TUR bleeding. So I'm glad that it's not too common and none of the urologists practicing encounter it too often.
Yeah,
No, the most
nowadays-
important slides probably you did say much because they are the most important message carrying slides.
Yes, sir.
Though you say it is all known to them, but they are the slides which
I had
carry.
to rush it because the buzzer went twice.
Sir, what is the role of preoperative embolization
especially in more than 100 grams,
Yes,
where there's
sir.
no availability of laser.
Yeah, even if you go by the guidelines, arterial embolization is still experimental. It is not coming to the guidelines. But if anybody wants to do it for a very large prostate, I think with caution and with enough consents, you should take it. It's not in the guidelines.
In that case, Ramesh, there
Sir.
are two options.
Sir.
You can do a staged resection, number one.
Yeah.
Number two, otherwise straight away you go for an open.
Absolutely. Sure.
Right. We'll move on. If there is no questions, we'll move on to the next one. TURBT, bleeding by Nirmal John.
Respected seniors and dear colleagues, good afternoon. After that excellent talk by Dr. Ramesh, I think my talk is irrelevant because he's covered most of the points, and my talk is quite parallel to his. TURBT continues to remain the gold standard to diagnose and stage bladder cancer, but vital to a good TURBT is removal of all visible lesions and the presence of detrusor muscle in the specimen. And the clinical need to achieve this actually exposes the patient to the risk of perioperative complications. Now, interestingly, the risk of bleeding appears to be rising over time, and this may be due to the increased use of antiplatelets for the prevention of cardiovascular events. So in this study comparing clopidogrel with low-dose aspirin, continued use of clopidogrel perioperatively was associated with significantly higher transfusion rates and postoperative hemostatic operations. So low-dose aspirin can actually be continued in most cases. All the other antiplatelet agents, anticoagulants are most always held perioperatively. Now, the risk factors associated with TURBT bleeding and complications are well known. So it is important to strategize prior to the procedure. And the strategy or approach to a TURBT to a large extent depends on the site of the tumor and the location of the tumor, the location and the size of the tumor, sorry. Now, it determines not only the choice of anesthesia, but even the choice of the surgeon, the type of power you'd like to use, and also the resection technique. So obturator jerk is, like Sir mentioned, is always a concern while resecting tumors on the lateral wall. It can be quite reliably eliminated using an obturator block, and reserve GA for cases where the obturator block fails or you're dealing with large tumors which may, consume time. Results with bipolar resection here are controversial, just like Dr. Ramesh mentioned. Now, before embarking on a TURBT, we must make sure that your instrumentation is adequate. A continuous flow resectoscope is essential. It provides good tumor visualization and also control over bladder filling. And it is key for prevention of and control of bleeding. The straight bladder loop is helpful while resecting or dealing with tumors on the posterior wall or dome. Needle electrodes help in an en-bloc resection, and large surface area electrodes like the roller ball or bipolar button are crucial to achieve good hemostasis. Now, transurethral resection of the bladder should be performed systematically and in individual steps. This is more pertinent when you're dealing with large tumors because severe bleeding tends to be associated with large tumors. Give a good bladder wash to remove all the clots. And if the clots are large and organized, you may actually have to resect the clots. Systematic resection, I would emphasize, is key, and you must avoid opening multiple fronts. Always remove all the superficial tumors first before going deep, and then use large surface area electrodes like the roller ball or bipolar button to control the bleeding. Leave the patient on a 3-way catheter with irrigation. Very often, when it comes to large tumors, a staged resection is actually prudent. Another cause for severe bleeding is bladder perforation. Early recognition is key. If extraperitoneal, saucerize the defect and patiently look for bleeders that may have retracted. In case the perforation is intraperitoneal, repair will be needed, which can be done either open or laparoscopically. So does bipolar resection reduce the risk of complications? A case series from AIMS showed that operator jerks can actually be avoided by using bipolar resection at lower power settings. But a randomized controlled trial from our institute actually showed higher incidence of jerks with default settings. It also has been reported that bipolar current has a better hemostatic capacity compared with monopolar current because it allows for deeper coagulation and has a cut and seal effect. However, in a large population study, by Sugihara involving close to 16,000 patients, the incidence of post-operative hemostasis procedures and transfusion episodes was similar in both the groups. Now, en-bloc resection with varied power sources has gained widespread traction, but almost a third of all these tumors might not be suitable for en-bloc resection, especially if the tumor size is greater than 3 centimeters or the location is in the anterior wall, posterior wall, or the dome. So both holmium and thulium lasers are good tools for EBRT and they offer excellent hemostasis. However, thulium YAG laser, due to the pattern of continuous wave, produces a smoother cutting line and thus is more accurate while making an incision and is preferred by urologists nowadays. The thulium laser is usually delivered by a 550 micron fiber with a power setting of around 30 watts. Now, this is a meta-analysis of close to 2,500 patients that showed that laser en-bloc resection was associated with significantly less operator nerve reflex, fewer bladder perforation, and lower rates of bladder irrigation. Now, coming to the rare scenario of intractable arterial bleed during TRBT, selective or superselective angioembolization of the anterior trunk of the internal iliac artery and its branches has shown a success rate of more than 90%. Anecdotal reports have also mentioned off-label use of fibrin sealant, which when injected transurethically into the TRBT defect can achieve hemostasis, but this is highly unlikely to get control of a brisk arterial bleed. Tackling intractable bleed in advanced bladder cancer where resection is incomplete or not feasible is where options like radiotherapy and diversion come into play, but I'll skip this for want of time. And finally, a note to all surgeons who are involved in teaching residents and fellows. This study by Neither et al. Showed that TRBT complications can be significantly reduced with vigilant mentoring of an experienced surgeon. And hence, this emphasizes the importance of setting up a well-structured teaching program. To conclude, bleeding complications post-TRBT, though rare, can be further reduced by systematic approach to resection and a judicious use of newer technologies like laser, when appropriate, can further reduce complications. Surgeon experience and mentoring of trainees does make a difference. Thank you.
Right. Any questions from the floor?
Coagulate the surrounding one before you reach the tumor. Second, you start from the periphery and go towards the center.
Yes, sir.
So the ways which you can reduce the amount
Yes.
of bleeding, even
I accept your point, sir. Also, if the tumors are large, start medially and then go laterally. Start with tumors on the floor and then go to the roof. And when there are large tumors on the dome, it's better that the senior tackles it rather than allowing a resident to operate. Yes.
For lateral wall tumors, do you give operator nerve block routinely?
Yes. Most of the times we give an operator nerve block. If the tumor is large and we are anticipating more time to resect, then we give a general anesthesia.
We routinely give that
Usually
will prevent
operator
the
blocks.
operator jerk and then avoid unnecessary jerky movements and can reduce.
Almost always successful.
If you give general, not, but routinely we do under regional, complemented by the operator nerve block.
The operator nerve block, is it mandatory for all cases?
Yeah, if you have a tumor
All
on the
depends
lateral wall.
upon the site of the tumor.
It depends on the site of the tumor. When it's in the lateral wall.
Nowadays, the anesthetists, they give ultrasonogram. With the use of ultrasonogram, they give the block.
Yes, sir.
It gives a very good result.
Yes, sir.
Gives a
True, sir.
And
Quite
this is a very
Added to that bipolar.
Correct.
So the chance of perforation is very minimal.
But if you,
Point
if you
well
do,
taken.
again another.
How will you manage the perforation? If it is small, if it is large?
So extraperitoneal or intraperitoneal? First we decide that it's
While
extraperitoneal.
dissecting, you make a perforation in the bladder dome. How will you manage?
So most often we convert, we either close the repair it open or laparoscopically. Very anecdotal case reports where the perforation is very small and it closes with adequate drainage over a prolonged period of time. But we haven't tried that. Most often we convert.
I have tried about 3-4 patients, small perforation, just to keep the catheter for 1 week or 10 days. They become all right. You need not intervene. So perforation is very small. You can keep the catheter for 7 to 10
For
days.
17, yeah.
It will heal automatically. No need to intervene or open or by laparoscopy. You do not do repair.
There's another situation here. A hypothetical situation. I don't say I happened to work with the general surgeon trained in urology elsewhere. This happened long back 10 years ago. I'm just asking the biopsy going to be high grade. You would have missed it. Second opinion came as high grade. And there is two scenarios, bleeding as well as perforation. What will be your decision?
In what scenario, sir? There's a
Bleeding as well as biopsy proved to be later high grade. High grade tumor, they should not have attempted. But they attempted, they should clear it off.
so high grade tumor which has perforated while doing a biopsy.
Yeah,
So there
exactly.
is- Yeah, if there is intraperitoneal perforation, there is no choice but to go in and repair it, either open or laparoscopic. There's always a chance of tumor spillage, but there is something which is unavoidable.
You won't venture out for any kind of radical cystectomy in the same table.
Yeah, I mean, if there is intractable hemorrhage,
I had a
sometimes,
nightmare.
and the
We had
patient
it.
is
We had it.
Yeah.
That's why I'm just sharing this.
And yeah, and if the patient is fit enough, and
Terrible time that we had.
for a radical cystectomy, that is also an
I
option,
don't
very
know if
ready
it's a good option or not.
Yes. No, we have done it. We have gone for radical cystectomy in patients with intractable hematuria, wherever it's feasible.
To be very honest, these are all practically difficult. It's all far-fetched. This can be practiced only in institution, not in a private.
Individual practice,
Yeah,
absolutely.
absolutely.
If it
Because you
happens
need to
on
have a
table,
blood bank support, you need to
as
have
you
ICU
rightly
support.
said, you have to open and repair it.
Correct.
There's no other go. Right. Thank you.
Thank you, sir.
You can pass it on to.
Yeah. So classically, when I was trained, I was asked to remove all visible tumor. But now with imaging and MRI, you know whether it's invasive, non-invasive. So very often we just sample, take a representative biopsy and then plan for a cystectomy. We don't really go and remove all the tumor. So that has been a change in strategy which has taken place of late.
Sir, in partial nephrectomy,
Audible, sir, please.
Partial nephrectomy. We are dealing with bladder.
in partial nephrectomy, we are getting consent for radical nephrectomy also.
Yes.
Like that, in this scenario, will you get consent for radical cystectomy also?
No, sir. Never taken a consent for radical cystectomy in this scenario.
Yes, yes. What he is trying to say, in that case, you can't try all these.
No, sir. I don't do the radical cystectomy in the same sitting. We usually stabilize the patient and then take consent, bring them back later.
Sure, sure. Final question, Dr. Srinivasan.
Please. Let me hear your question, please.
He wants to give the point.
Hi, I'm Dr. Srinivasan. So this slide is about the large and extensive tumor that itself is an alarm.
Yes.
So it is not like a regular TURBT.
Absolutely.
In TURP, at least you have a control of the catheter. So you put a catheter and keep it for 5 minutes traction. That point we don't have in TURBT. So that is
Absolutely
lost.
not.
One point
Yes.
is lost. The bleeding is difficult to control. Number two, large and extensive tumors, if it starts to build, people say do a biopsy and come out. The biopsy, the site doesn't stop bleeding. So you keep resecting. The defect becomes large. The bleeding becomes more. You don't know where you are. The clots gets formed. It's very difficult. 2-hour resection at times, sometimes you can't finish the tumor. So what happens is the irrigation at times you have to continue for 4 days and 5 days. And that the moment you think of angioembolization, fortunately it stopped. So that is another point. And the consent regarding the procedure, usually it's better to take a consent, something called any procedure, TURP and associated procedures, because this was a legal point mentioned by one of the lawyers in one of the meetings. When you say TURP, you place associated procedures, it means a myotomy also. It includes dilatation also. When
Any
TURP
procedure with a likelihood of at least 10% of happening, we'll take a consent. But a cystectomy is...
cystectomy you can't take, no.
Yeah.
The associated procedure takes care of the multiple small things you do
definitely.
during
Yes,
surgery,
yes.
like a myotomy, for example.
Point well taken, yes.
Thank you.
Thank you, Srinivas.
Thank you, sir.
We'll move on to the last topic. VAU bleeding by Chari.
Good evening to all of you. First, I was asked to present on the topic of bleeding after VAU. I was wondering what to talk about that, because all these years we have been practicing VAU for more than 40 years. And we never came across, I never came across a massive bleed after VU that as you get in the other scenarios that have been shown. But I was surprised to review the literature. I was in US during that time. Whole 1 month I was reviewing the literature. I came across 10 papers on this particular issue. Most of them are anecdotal reports, case reports. I will put before you the consolidated knowledge about them. Next slide. The anatomy of the blood supply of the urethral arteries is known all of you. There are 2 to 3 urethral arteries in the urethra, which are the branches of the either bulbar or bulbourethral or dorsal arteries. And they are, all the time we are known that they are between 3 and 9 o'clock. But the evidence that came from the literature long ago is that they are no longer at 3 and 9. They are globally distributed all around the clock. One from our own country and one from Chow from the other outside India. And therefore, we no longer have a predictable anatomy of the urethral arteries, and more so in the patients with stricture urethra, the urethral artery is about 1 centimeter closer to the lumen when compared to healthy urethra. That should be borne in mind, especially when we deal with the multiple times we do urethrotomies in a stricture urethra. Now, one look at the etiological factors of the bleeding, maybe a missed bleeding disorders, antiplatelet agents which have been discussed in the morning and anticoagulants, abnormal distribution of the urethral arteries, too deep an incision at one place, and infection, of course, can lead to a bleeding. The pathological points that have been detected, found in the literature are 1 bleeding urethral artery, 2 bleeding from the corpus spongiosum, 3 pseudoaneurysmal bleed, 4 AV fistula bleed, and 5 entrapped vessel that bleeds during the after the open surgery. Now, there are a number of complications of VIU. Bleeding, of course, is rare, but the point of concern today. It occurs in about 5 to 20% of the cases. Mostly it is minimal, trivial, and rarely and very rarely it is serious. Now, the diagnosis of post-VIU bleeding is obvious when you look at the catheter or the pericatheter bleed. There are some very rarely signs of hypovolemic shock. Panendoscopy will diagnose the site of the bleeding and the type of the bleeding, whether it's arterial or venous or spongiosal in origin. Color Doppler imaging of the urethra has been quoted in the literature to diagnose rarely the onset of the pseudoaneurysm, but we don't, it is an inverted commas. But the one that gives us the diagnosis mentioned in the literature is CT angio, digital subtraction angiography, selective pudendal angiography. Maybe the latter is the definite method to deal with in a severe situations with hypovolemic shock, so that at the same time you can tackle the problem by embolizing the bleeding artery. Now, hematologist opinion and assessment of the bleeding disorders should be simultaneously undertaken so that we don't lose time in treating with the serious patients. Now, the methods that control the bleeding, fresh blood and the FFP should be kept in hand. Stop antiplatelets and anticoagulants. Tranexamic acid is known to stop bleeding in minimal patients by preventing the fibrinolysis, and endoscopic transurethral instillation of fibrin glue we have discussed in the morning, a combination of fibrinogen and thrombin in the form of T-cell or flow seal, known to help in some patients with mild to moderate bleeding. The other methods that have been mentioned are one, blind perineal compression, which you all have been doing for the 40 years. But there is a point here, is ultrasound guided perineal compression, which is said to give better results when compared to blind perineal compression. The other methods are transurethral fulguration, transcatheter embolization, and exploration and suture ligation of the urethral bleeder. This one point I came across which I hitherto did not know till now. Now, the Atri et al. Have told us that they claim that the focused compression for 25 minutes on the place of the pseudoaneurysm has controlled bleeding in a couple of cases. And they claim that it is better than the blind compression of the urethra. Now, this particular video I have taken the courtesy from ANU Hyderabad, has a young patient with a 1.5 centimeter stricture at the bulbomembranous junction was subjected to optical erythrotomy at the standard method at a 12 o'clock position. They gave incision at the same place 3 times to get an adequate lumen. And he went home on the 3rd post-op day, came back on the 7th post-op day with severe bleeding. They tried all the conservative methods, perineal compression, tranexamic acid and so on, and ultimately it did not stop. The panendoscopy revealed a bleeding artery from 1 o'clock or 12 o'clock position, the site of the previous VIU. Then at the same time, they have proceeded with the bipolar fulguration of the bleeder using a bipolar button electrode. It effectively controlled the bleeding, but there are concerns of the coagulation of the bleeder, like a ischemic stricture that might develop, but in this emergency situation where you need blood transfusion, this is probably the lesser evil to take. The other, even by now, you are not able to control the bleeding. There are methods that are described in the literature, is doing a pudendal angiography, identify the site of the pseudoaneurysm and do a transcatheter embolization. One group has used PVA particles, the other one used the coils to control the bleeding effectively, and both the reports that have been mentioned, they had good results. However, the complications mentioned in this group are the erectile dysfunction and ischemic stricture. Now, this particular aspect of open suture ligation has been quoted in the literature in 5 case reports. One of them were following the stage 1 erythroplasty for a traumatic urethral stricture where there is a bleeding which could not be controlled. There were no facilities for embolization. They made a ureterotomy, controlled the suture leg at the bleeder, converted them to stage 1 erythroplasty. Similar situation occurred following end-to-end anastomosis for a short stricture in the bulb. He bled on the 7th postoperative day. They had to open the ventral wall of the anastomosis, suture leg at the bleeder, and complete the anastomosis. Now, I had only one patient of severe bleeding which needed transfusion about 40 years ago, which I could control with a monopolar ball. But now I would say that the bipolar energy has a better coagulative ability, so it should be used with a button electrode as we have shown in the video. So how do you prevent it? Careful history of a bleeding disorder, preoperative Doppler to identify the urethral vessels so that you can plan your incision. The technique of ureterotomy, whether you use laser or a cold knife, is divided in the literature. It is our preference, but the cost and the availability are the bottom lines. But the point is that you must avoid cutting deep at only one place for many number of times to expose the corpora cavernosa or the spongiosa. That is the cause of the bleeding. In this time of good erythroplasty results, we should not go for repeated or deep erythrotomies at one place. We must select erythroplasty instead of doing a job like that. Intraoperative fulguration of the bleeder, if found like an arterial spurter, may be useful. Coming to the algorithm, that is severe pericatheter bleed, perineal compression either blind or ultrasound guided, evaluate the bleeding disorders, endoscopic installation of hemostatic agent. They are costly, they may not be available always, but it should be injected into the site of the bleeding through a catheter through a cystoscope. And if it fails, one must go for a selective angiography and embolize the bleeder. And if all these things fail, or the embolization facilities are not available, we can even select the open ligation and conversion to stage 1 erythroplasty. Thank you for your patient hearing.
Absolutely, I agree with Dr. Chari. The last line, open erythroplasty, that is suture ligation, it has happened nearly about 3 decades ago when I was a resident in urology. I had the experience of assisting my senior resident surgeon who was able to control the bleeding by doing this. But this can happen, it leads to priapism.
Yeah, that's what I want.
When there is a communication between the fistulous communication between both the corpora and the spongiosum, it can result in priapism. All your techniques will fail. There's no other go. You have to open and you have to suture it. Just imagine a young patient comes with a stricture urethra for a simple internal urethrotomy, goes with the bivalve penis with the urethroplasty and with the stroma there. It is really pathetic. This can happen. So, any questions from
And
the
this
floor?
type of priapism, as Professor Mayappan was pointing out, belongs to high flow priapism. High flow priapism. I rightly pointed out the embolization. The same embolization technique is going to help you later on.
Yes,
The
Kanan.
microcatheters. Yeah.
Sir, this continuous bleeding following the VAU, when we are going to coagulate it with the, when you are going to fulgurate it with any type, that again can cause stricture and hazard. Should we advise the patient or tell the patient in advance in case if it happens, he will require an open surgery, or we can just leave, we'll control the bleed?
I think whichever patient we are doing VIU, we are going to say that the results are only, long-term results are only 40% or 20 to 40%. So it would cover the same in that. One interesting, yeah, yes.
I had a case 2 weeks before. IU done multiple times. Bleeding, transfusion, patient went for hemodynamic instability. And we did a CT angio. There was a pseudo aneurysm. And it was managed by injecting thrombin into the.
Good.
I think so.
Very good.
So for the information.
Yes.
So in VIU with cold knife,
No, not
most
selective
of
angio. Ultrasound guided. Like the radiologist has presented a case.
as you rightly mentioned, too deep a cut, most of the time it lands into the corpora.
Yes.
That's the maximum bleed comes from the corpora. So probably in that case, you just have to put in a catheter and give a compression. That's why Kulkarni and team have adopted a technique where they cut below on the at 6 o'clock position instead of cutting at the 12 o'clock.
Yeah, Dr. Ramesh is just.
Ramesh. Yes, sir. I have gone through a number of papers which have compared the laser against the cold cut at a large number of patients. The summary is that no severe bleeding occurred in the laser group and all the bleeding occurred with the cold cut group. And it is for us to decide if it is available, we can use it. But there are problems with the laser erythrotomy also. Yes.
The cold line, how the urethra expands, the urethra does not expand. Second thing is the setting of the lacing is proper. Three, because you have got laser, you can still use that as fulgurator point. When the ANU came, it showed using a bipolar. Instead of bipolar, they could have used because
They have a laser also.
And anecdotal case of artery.
That's good.
Was talking about, and you also shared on the.
Yes, sir.
Recently, there was some telephonic conversation with Dr. Ganesh, and he suggested them to do angio, and they did a coil.
The one point extra I noted that when you do an end-to-end anastomosis, that group says that if you suture ligate them on the table, you will not get a secondary bleed. In that particular case, they only coagulated and left it up, and then it occurred on the 7th post-op day. Angulation of the laser to 12 o'clock is difficult. That one of the technical difficulties that I've quoted.
So,
Ventral, 6 o'clock.
I don't think we should not follow somebody just saying that. We must stick to the age-old traditions like this fellow.
That doesn't look correct.
suppose possibility, suppose if you cut it in 6 o'clock, instead of bleeding, you may develop a fistula.
6 o'clock is not correct. Thank you very much, sir.
With this, we'll close the session. Thank you so much. Thanks for the opportunity.
I thank the chairpersons for chairing this session. Now I request President Avudiyappan sir to give certificates to the speakers of this session. Dr. D. Ramesh, sir, certificate. Dr. Nirmal John. Dr. Nirmal John. Chari sir. Okay, now we move on to the next session of lower tract bleeding. I invite for this session Dr. Siddhalingeshwar Neeli, Dr. Keshavamurthy and Dr. Chengalvarayan to chair the session. So. Thank you, sir.
We'll call the first speaker, Dr. Renu Thomas from Trivandrum, who will talk on hemorrhagic cystitis, causes and management. Dr. Renu Thomas.
Good afternoon all. At the outset, let me thank ASU for giving me this opportunity. It is indeed a proud privilege for me to talk to you on hemorrhagic cystitis. This is something I think every practicing urologist would have come across at some point in their practicing life. And when this happens, it is sometimes a messy job to manage hemorrhagic cystitis. So in my talk, I'll be going through how this is caused, the pathophysiology, as well as the management. Now, to define hemorrhagic cystitis, it is a symptom complex that refers to bleeding caused by irritation to the bladder mucosa. The onset of bleed can be rapid or it can be insidious. And the spectrum of bleed can vary from a mild bleed to gross hematuria causing clot retention, needing clot evacuation, when a hemodynamic unstable state, patient presenting in shock, all those kind of things. Now, the categories of hemorrhagic cystitis based on the etiology, it can be either infectious or non-infectious. If it is infectious, it can be because of bacteria, virus, fungal or parasitic. Non-infectious can be chemical induced, radiation induced or because of interstitial cystitis. And many of these causes may cause mild hematuria, but when there are severe manifestations, this can lead to hemorrhagic cystitis. Now, the grading of hemorrhagic cystitis is based on the clinical severity of symptoms. Grade 1 will be LUTS without gross hematuria. Grade 2 will be LUTS plus gross hematuria. Grade 3 will be LUTS with gross hematuria and clots. And grade 4 is LUTS with gross hematuria with clots causing urinary retention. Whatever be the cause, the basic underlying mechanism of hemorrhagic cystitis is that the inciting cause causes urothelial cell irritation causing mucosal edema. Eventually, this leads to cell death of the mucosal cells, exposing the muscle and vessels to the urine. Urine contains urokinase, and this acts upon the exposed muscular layer and blood vessels, causing bleeding. Now, taking upon each cause, I will rush through the infectious causes because this is something which we less commonly encounter, and this mostly occurs in the viral causes of hemorrhagic cystitis, mostly occurs in immunosuppressed patients, especially transplant patients. The viruses involved will be either polyoma viruses like BK virus and JC virus or adenovirus. The highest group of transplant patients which are at risk to this is the allogenic hemopoietic cell transplant recipient patients. Among these, children are also prone to develop this. In children, this can develop as early as 30 days, whereas in adults it may be delayed up to 90 days. And talking about viral infections, CMV virus can cause hemorrhagic cystitis even in immunocompetent patients. Now, the viral mediated causes, to confirm a diagnosis, urine cytology or PCR testing will help. Imaging will usually give non-specific findings like thickened bladder wall. The management when it occurs is basically reduction of immunosuppression. Antivirals like cidofovir is effective especially in polyomavirus infection. Other agents that can be used are leflunomide, fluoroquinolones. This can be used as prophylaxis as well as treatment of BK virus hemorrhagic cystitis. And there are no recommended antivirals as such for adenovirus, but some agents which are used with partial success are ganciclovir, valganciclovir, vidarabine, and ribavirin and cidofovir. The non-viral infectious hemorrhagic cystitis can be caused by bacteria, fungi, or parasites. We routinely treat bacterial cystitis. This is usually benign, only mild bleeding occurs usually, but sometimes this can cause gross bleeding leading to hemorrhagic cystitis. Sometimes it can be fatal as well with accompaniment of bladder perforation. The usual implicated bacteria are, there are several groups of bacteria including tuberculosis. The basic treatment is treatment with antibiotics based on culture as well as the symptom control. Fungal is even more rare. The implicated fungi can be Candida, Cryptococcus, Aspergillus, Torulopsis. Again, in the line of treatment of bacterial cystitis, antifungals and symptomatic management is usual treatment. Parasites, the usual parasite involved is schistosomiasis and occasionally hydatid cyst. But the usual sequelae of schistosomiasis is a contracted bladder, but rarely HC can be the consequence. Now, radiation cystitis is much more common. I think most of us would have dealt with it at some point of our time. This develops after radiation for pelvic malignancy or whole body radiation, especially in children in preparation for bone marrow transplantation. The onset can be either acute when it occurs within 3 months or late can be up to 20 years after the exposure to radiation. The incidence is 5 to 10% and it is the development as well as the severity is usually dose dependent. The pathophysiology of radiation cystitis is slightly different. What radiation cystitis does to the bladder is that it causes endothelial cell damage and perivascular fibrosis, causing vascular occlusion, leading to bladder ischemia. And eventually the mucosa sloughs off, the smooth muscle is replaced by fibrosis, bladder contraction and decreased compliance occurs. There is progressive obliterative end arteritis and mucosal ischemia, and ultimately tissue breakdown and sloughing of the necrotic bladder mucosa results. There also occurs telangiectasia, which again accentuates the bleeding. Now coming on to the chemically induced cystitis, the most common agent implicated is cyclophosphamide as well as ifosfamide, which are used to treat several malignancies as well as non-malignant conditions. The HC has got a high percentage of incidence in these patients, up to 40%. What happens in cyclophosphamide administration is that there is a toxic metabolite of cyclophosphamide called acrolein, which is an unsaturated aldehyde which is excreted in urine. This interacts with the bladder mucosa to produce the toxic effects. Now, always prevention is better than cure in case of chemically induced hemorrhagic cystitis. And what is used for prevention is MESNA, that is sodium 2-mercaptone sulfonate. And along with this, other measures that can be adopted are hyperhydration and forced diuresis, continuous bladder irrigation. What MESNA does is that it combines with acrolein to form a non-toxic compound which is excreted through the urine. Other prophylactic agents that are used are amifostine, anakinra, glutathione, pentoxifillin, and some plant derivatives. Other offenders causing hemorrhagic cystitis, there are several kinds of chemicals which can cause hemorrhagic cystitis, and some peculiar things are nonoxynol, which is a vaginal contraceptive. If there is accidental insertion into the urethra and if it enters the bladder, this can cause hemorrhagic cystitis. Now coming to the management, the usual general measures to resuscitate the patient depends upon the clinical status of the patient. For milder causes, for milder grades of hematuria, maintaining a good hydration status, and as I told earlier, prevention is always better than cure in this condition. For radiation cystitis, limit the dose of radiation. For chemical cystitis, use MESNA when indicated. And when you anticipate hemorrhagic cystitis, adequate fluid therapy and alkalization of urine is going to help. Initial bedside management when it occurs would be bladder irrigation and clot evacuation when indicated. Antibiotic therapy because this predisposes to sepsis and urinary infection. Continuous bladder irrigation, and when indicated, cystoscopy and fulguration if the bleeding continues, and intravesical instillation of several agents. Most common used agent will be alum, that is aluminum ammonium sulfate. This causes precipitation of proteins which actually protects the bladder mucosa. It is usually infused at a rate of 250 to 300 ml per hour. 1% of solution of alum is prepared. This has got a good percentage of efficacy, but beware of the complications of aluminum toxicity, and this has to be used in caution with especially in the case of renal failure. Other agents can be epsilon aminocaproic acid, prostaglandin F2 alpha, sodium hyaluronate, silver nitrate. In refractory cases, when all other measures fail, one can use formalin. This is very much effective, but the complications are prohibitive and severe complications. So extra care and extra protection has to be used when formalin is used. The other intervention, as I told earlier, cystoscopy and fulguration when other conservative measures failed. For fulguration, one can use lasers, which can be either Nd:YAG, argon beam, or green light lasers. Systemic therapies like hyperbaric oxygen is especially useful, especially in case of cyclophosphamide treatment. This is a costly thing and not widely available, but when available, if it is used, it is found to be highly effective. The basic mechanism is it causes saturation of hemoglobin, which promotes angiogenesis and wound healing and decreases tissue edema. Other things like angioembolization when other measures fail, and in refractory cases as a final measure, one can adopt cystectomy or urinary diversion. But cystectomy is not an easy job, especially after radiation cystitis, where when everything is fibrosed, sometimes you may have to do an incomplete removal of the bladder. So other experimental newer therapies which has not gained much acceptance is still in experimental stage. The glycosaminoglycan layer replenishment of bladder, stem cell therapy, viral specific T cells, platelet rich plasma, and fibrin glue. We have been talking about fibrin glue several times today. And in summary, I would conclude that hemorrhagic cystitis have got different etiologies. The pathology almost similar in majority of the cases. The basic management is resuscitation SOS and remove the offending agent and adopt a stepwise treatment depending upon the severity of bleeding. And the treatment adopted would progress from bedside measures to more invasive treatment depending upon the clinical situation. But the basic aim of therapy is to stop bleeding and to restore urinary function. Thank you all for your patient listening.
Thank you, Dr. Venu Thomas, for a comprehensive coverage of that. Are there any questions from the floor?
If there are no questions from the floor, shall I take the opportunity to ask the question to him, sir? So, Venu Thomas, sir, excellent presentation as usual. Have you tried Premarin in these cases? Any role of conjugated estrogens when you have hemorrhagic cystitis and bleeding?
I have not come across the use of estrogen in literature. And recently I had a chance to manage a severe case of hemorrhagic cystitis, radiation cystitis actually. Even then I had actually searched through the literature. I didn't find reference to using estrogens.
Dr. Kannan sir has got something to offer on that.
In radiation-induced cystitis, hemorrhagic cystitis, our radiation oncologist is insisting on instilling steroids into the bladder. What is your experience about it?
I have not used it, and when I prepared for this talk, I went through the literature. I didn't find any reference of using steroids.
He insists that we should instill hydrocortisone 200 milligrams dissolved in 50 ml of water and allow it to stay. Is there any scientific basis for that? But he insists that in some cases it has worked.
Maybe he may be presuming based on the fact that...
I don't think there's a scientific basis to that because I have never gone through any literature which suggests steroids to be instilled before radiation.
Okay. My next question is, there is a method of treatment called styptic radiotherapy. Is there any role for styptic radiotherapy in hemorrhagic cystitis? Radiation itself is given as a method of stopping the bleeding.
Yes, low dose radiation is used as a treatment for refractory bleeding in hemorrhagic cystitis.
I didn't come across literature when I was going through literature for this talk.
It is there.
Okay, thank you, sir.
The bigger problem in this issue comes, I think, sir, when we have diagnosed hemorrhagic cystitis is different. But when you have a patient with hematuria and go for a scopy and find an hemorrhagic cystitis, you distend the bladder and then you release the bladder distension, automatically it starts bleeding. There where the problem starts. Where to brand the diagnosis? Is it simply due to infection that is the reason for this or something else which we'll have to find out? Anyway, if there are no further discussions on this topic from the floor, I think we can move to the next one, sir.
Thank you. Next paper, thank you, Dr. N. Thomas. Next paper is Bleeding in Radical Prostatectomy by Dr. Anand Shivaraman.
respected chairpersons, organizers, colleagues, seniors, colleagues, friends. So my topic today is bleeding in radical prostatectomy. I've been given 8 minutes. We usually pride ourselves in saying that blood loss is very minimal in radical prostatectomy. But there are always outliers. There are always patients who will need some sort of help with when they bleed. So, though it's very uncommon, I've also included some radical cystectomy and simple prostatectomy in this. I've got a few points to offer. So the scope of the talk is going to be problems in access, right? Because it's been 10 years since I've done an open radical prostatectomy. I'm not qualified enough to talk about it right now, but I'm going to stick to robotic prostatectomy and then or minimally invasive prostatectomy, the problems in access, problems during surgery, problems in the postoperative period, and patient factors. So what are the problems during access? If you ask me in radical prostatectomy, this is one of the chances of major bleeding. Patients can have huge bleeding if the access goes wrong, right? And this is one thing that's easily avoidable. You can very well go to open Hassan's technique if you are comfortable with that. I personally use what I call a safe Viris technique, which basically means I put an incision just above the umbilicus, use 2 vicral sutures, lift up the rectus, the anterior rectus sheath, then put a Viris. So it's like a roof of the house, and then you put the Viris needle in between the 2 points of the roof of the house. So that's one of the safest ways of looking at it. And obviously you will check if the air goes in and then put some fluid and then goes in and then withdraw it and see if there's bleeding also. Then one more point of technique is you pull the 2 vicral sutures up, then the pressure inside the abdomen goes down. I think this is also something that will help us know that we are inside the abdomen. Right? The other thing that I found is when you're putting the trocar inside, a lot of people are using undue pressure. The rotation is more important than the pressure that we use when the trocar goes inside. If it goes with pressure of the sudden jerk when the trocar goes inside, that is the time when you'll have major trouble. So I would also suggest to consider incising a small point, less than a millimeter, couple of millimeters, and the tip of the trocar touches the area where you've incised, and then you go inside. This pressure is completely avoided, right? So first case, bleeding after trocar has been inserted, right? And it can happen to anybody. Impossible not to, once in a lifetime we will get all these things. And we managed it with this. All of you have seen this. We call it the Carter-Thomason needle and driver. So what it does is it's basically a port closure suture. So if you've got bleeding, all you need to do is take wide stitches with the port closure needle and then pull it up, right? So again, this is something we never want to see when we do access. This is what happens when a sudden pressure goes inside, and this is an injury to the lower part of the aorta, right? So this patient, probably I think the team that did this surgery was able to manage this without trouble. But if you ask me if there's a lot of bleeding from a major vessel, I wouldn't hesitate to convert. So conversion should not be something that, it should not be something that affects your ego or something. All that matters is the patient should go home safely, whether it is open, whether it is purely done robotically or minimally invasively, should not be your concern, right? So this team was able to manage it. But if you ask me with this sort of bleeding, there's nothing wrong in opening or converting this patient and then sorting it out at that point in time, right? So what are the problems in surgery? During radical prostatectomy, the only one thing that matters is the dorsal vein complex. It has a chance of rapid sustained blood loss. Raising pressure is not always a solution, right? We always see this. Pressure, that's not good because carbon dioxide embolism can happen. The pressure in the IVC is 8 and in the right atrium is even lower than that. So if you raise it to 15, 20, sometimes you can have massive carbon dioxide embolisms. I'm going to quickly skip this because of lack of time. So this is what happens when you have a DVC bleed, a lot of bleed. Suddenly the patient can lose about 500 ml of blood within a span of very 3-4 minutes, it'll rapidly bleed. So one of the best ways of doing it is don't cut it partially if you cut it. Cut it completely and then you suture it thoroughly. That's something that can potentially save you from trouble. I previously used to suture and then cut, but some of the apical tumors you'll have difficulty if you do that. So nowadays we are also thinking of cutting and suturing if it's an apical tumor, right? So this is what happens in a massive DVC bleed, but this is always a problem area in radical prostatectomy, and we need to get through it, but cutting fastly, quicker, and then stitching that area quickly as well, right? Vascular injury. So this is something that we need to be always cognizant of. In laparoscopy, when you hit something, you will know. In robotics, there is no tactile feedback. You will never know if you hit something. So this team has injured the external iliac vein here, and the fourth arm has injured the external iliac vein. The arms are so powerful that it can make bone bleed. What will happen to vessels? They will automatically bleed. And the best thing to do in such a situation would be to hold the opening with an instrument, either the fourth arm or your assistant, and then quickly start suturing this, right? And usually when this is the point, you would not say raise the pressure too much, raise the pressure too much, and this can sometimes cause a lot of trouble. If somebody has a carbon dioxide embolism or a large air embolism, what do? We put them on a Trendelenburg position. Most of the prostate patients are in Trendelenburg position. They also need to be in the left lateral decubitus position. It's called the Durant's maneuver. And the reason is to push the air into the right atrium rather than the right ventricular outflow tract or the pulmonary artery. So in simple prostatectomy, we usually get bleeding because we are in the wrong plane. Robotic simple prostatectomy is one of the commonest, nowadays Mayappan sir was saying, just open it. We do a lot of simple prostatectomy as well. If the patient has multiple abscesses, if you are not in the right plane, invariably it will bleed like stink. So some of the techniques is access, right? And I've always seen this, if there's a lot of blood, if we don't suck it out properly, or if we don't put a gauze piece or something, there will be, hemoglobin absorbs blood, the light. So what happens is the field becomes more and more dark. If you put a gauze piece there, and it reflects light as well. And also, if you keep a gauze piece there for too long a time, it will also become starting to absorb the light. So change the gauze piece as much as possible, and then you would increase your access by taking stitches and pulling the entities out, the lobes out. So bleeding in radical cystectomy, most common because when the tumor, if suppose most of the times we now do neoadjuvant chemotherapy before we do radical cystectomies, but some cases you will not be able to do that. Either patient factors, either the creatinine is high or something. And if these tumors are stuck to the lateral wall or something like that, and post TURBT, then it always makes your life miserable. Again, the only thing that I would like to add here is access and vision. It should be absolutely fine. I'll just finish in a couple of or 1 minute, sir. Right? So this patient had multiple parasitic vessels or something going into the tumor, and a lot of bleeding. Again, there is no case in robotics that we do without reserving blood. Even it could be, though we've not transfused in a long time, it doesn't mean the next patient won't be our first time. So always take adequate precautions before we go ahead and do any major surgery for patients. Right? Now we come to the post-operative period. Sometimes we see huge hematomas like this. And my technique here would be to do serial hemoglobins. Most of the time these ones settle down, but sometimes you may need to go in and see what's happening. So these are entities that generally settle down. I think it happens where the port's been put and there's some slight ooze that tracks into the retroperitoneum and so on. So it's been fashionable nowadays for people to say, I don't put drains at all. Right? In the nephrectomy, if it is clean, I don't put drains, or cystectomy, I don't put drains, or prostatectomy doesn't need, but I always put drains. I'm at the school that says drains are essential. This is the drain that I use. It's a Jackson-Pratt drain. The suction is not too much, and the holes there are multiple in number, so usually it doesn't get clogged. Patient factors. So all of us ask patients whether they had some bleeding, extra bleeding when they brush their teeth or something like that. But there's so many unknown bleeding diatheses that are there that we only come to realize when they evaluate them completely after they have a massive bleed. And recently we've had a couple of patients with this. USL we used to see a lot of Jehovah's Witnesses. This is a sect in Christianity that doesn't believe in blood transfusion. So recently we had to send a patient away because they had a lesion on top of the IVC on top of the aorta with a hemoglobin of 8. So, and they told us only on the morning of surgery, right? So we had already admitted the patient, but still I said it's not a thing that I would go ahead and do, and I discharged the patient and said, come back to me when your hemoglobin goes up or something like that. So these are things that we need to keep in mind. Just a small practical talk on entities of bleeding that we see in radical prostatectomy. Happy to answer any questions. Thank you.
Thank you, Dr. Anand. Any questions?
One quick question. Yeah. That was an excellent presentation. Regarding the safe venous technique, if you put a stitch and lift the rectus sheath, won't the distance between the rectus sheath and the peritoneum increases and it will keep your venous above the peritoneum?
So, good question, but our main goal is here not to hit the vessels, right? So that is the safest point of doing it. Otherwise, bowel you can never avoid if it is stuck to this. And the varus needle is long enough to go through that distance. You cannot obviously pull it too much. So it all stuck together, so it won't have I have never had that problem.
Proceed with the desired procedure, you just salvage the emergency and get out.
Again, depending upon how severe the bleeding is and so on. So more than comfortable doing an open prostatectomy, sir. So it's not a problem. We can do it, but we've never last 10 years, we've not had a reason to do that. But
Okay. This is something, since you showed number of vascular injuries and one slide showed patient factors. This is a practical question I'm asking. Many a time I was told by the cardiothoracic surgeon, in a chronic smoker, the vessels are having aortoarthritis or an arthritis sort of a problem where you are trying to suture the bleeding vessel by routine suture will not hold. Especially this happens in the chronic smokers. Your routine way of suturing the vessel, bleeding artery will not hold. So you have to have that buttress suturing and all that. How true is that? Because he is talking from experience, you have an international exposure. Kindly enlighten me on that.
so, couple of things regarding arterial sutures. It's never good only to take a figure of 8. Ideal would be to take a purse string suture if it's a major arterial vessel and you're trying to close one single opening. Other thing is you would use a pledget. Most of the time, pledgets are essential when you do an arterial suturing because you don't want the suture to cut through. So these are a couple of points, but specifically smokers, I don't think we've altered our technique for smokers.
Because use of pledgets is highly recommended because these vessels will be like wet blotting papers. So your sutures will not stay unless you use pledgets.
So reasonable thing to do would be you would keep a pressure at 12, go up to 15, 18 at the most. But beyond that, when you keep a consistent high pressure and there is a big opening in a vessel, it's not a good thing for the patient. But luckily in a prostate, the patient is head down. But most of the air, even if it goes, it has to travel up. Air usually ascends up, but the flow of blood can sometimes take in a lot of air, carbon dioxide down as well. So, and also minimum of 60 to 80 ml of air has to get inside to cause RVOT, which is right ventricular outflow obstruction. So again, if you're safe enough and you do the thing quickly and stop with that, I don't think it's a major problem. Is that something that's more theoretical than...
Anand, thank you very much for the wonderful presentation, but not just for the presentation. It's just taking us back to the days you, we, and Dr. John were together. Now, two things which we noticed here. I think people should acknowledge this. It is not easy to come and present complications as a presentation. You should be bold enough to present complications as a presentation. The second thing, I was a little worried whether Anand is going to talk about open prostatectomy. He stuck to his track and said that I will talk only on things which I do and I am experienced. I think we all should appreciate Anand for this. If there is a chance to clap, you can clap also. There's nothing wrong in it. And thank you very much, Dr. Ananthakrishnan, for this presentation. And the person who is going to follow you is known to everybody and no inferior than anyone. Maybe have Dr. Jinil Kumar to kindly come on stage, please.
Thank you.
Retroperitoneoscopic bleeding.
Thanks for the introduction. So, how many of us, as actually in the auditorium, has attempted or done a retroperitoneoscopy? I'm sure that majority wouldn't have, sir. Yeah. Good. So, is actually a great privilege for me because is a difficult surgery and a lot of people doesn't do because of inhibitions or initial inertia. I'm thankful to ASU because I could present this one. This is one technique that was taught to me by Sanjay Bhat, none other than HS Bhatt's son. So it's a great privilege for me. So coming to retroperitoneoscopic surgery, why we are not doing is because the anatomy is quite different from our usual approach. There are difficulty in managing the instruments. There are a lot of clashes. There is difficulty in maneuvering some of the times like bleeding. It would be difficult to manage. There can be sudden loss of pneumoperitoneum can be lost due to suction or if there is a peritoneal injury. And if there is a bleeding, there can be issues. And bleeding, of course, is a concern in retroperitoneal surgery because we may be stuck and forced to convert. So I'm presenting a few cases just to show that whatever we can do in truth transperitoneum can be done with retroperitoneoscopy also. One is a retroperitoneoscopic partial in a difficult tumor. Second is a RPLND bleeding, what we managed in retroperitoneoscopic surgery. So this is a how to, yeah. So this is a small tumor in the posterior lip behind the vessel, difficult area to access. So in the partial, you usually do the double clamping like this just to avoid any chance of bleeding. We confirm that it is completely vessels are completely clamped with indocyanine blue. So few of the issues is the limited space, but we can manage just like a regular surgery. And the issue that has happened is there is a bleeding. So this case, it is very difficult to manage from, I just did the initial layer, inner layer, then unclamped. After unclamping, you can see that it is started to bleed. The issue is there is limited space to manage, and sometimes it will be difficult to see the space. So in this case, we could manage with 30 up camera position without clamping. So all the maneuvers what we are doing in transperitoneal surgery is possible with retroperitoneal surgery. There is one point I want to highlight here. So this is actually, I am tilting the camera up and managing the bleeding at the hilum in the retroperitoneoscopy. So it is arrested. So I'm showing a few slides of retroperitoneoscopic extraperitoneal approach we described, that is raise RPLND. So this I am managing the lumbar vessels behind the IVC, in between the tumor and the IVC from behind. Actually this is the tumor. Yeah, I am clamping the lumbar vessels. So suddenly I found that there is a bleeding from the IVC. This is a gesture of this thing. So I'm using the rescue suture which described the Nagaraj sir. This is the rescue suture. I'm compressing the bleeding with the rescue suture. Then I am taking the further sutures and then ligating that. So that is one way of tackling. We usually do it, this is behind the IVC. This area is very difficult to access from anterior aspect. So we could access from behind well. Oh, there is a gonadal vein is dividing. And actually you can see that this IVC is stripped over. I am lifting the IVC from the tumor. This behind is this is the actually lumbar vessels I'm dividing, and this is again another lumbar vessel that is there in then in it is bleeding at the distal end. Just this is how it is managed. But after what has happened is suddenly the the clip got slipped and it started bleeding. So lumbar vessel I am plicating on the muscle, the distal end. So it's a misconception that retroperitoneum doesn't have space. The only catch is you have to adequately strip the peritoneum to get the access and have space for maneuvering the instruments. So this is the lumbar vessel that is bleeding in the right side. So I am accessing from the right side, stripping all the peritoneum, getting adequate space to all the maneuvers. So this one lumbar artery, after lifting aorta, lumbar artery is bleeding. So behind the aorta, I am clipping the lumbar artery. Even if you want, you can put sutures there. There is no limitation for all these maneuvers. So you can see the space I am getting in the extraperitoneal approach. So this is another bleeding managed, and small bleeders we can just coagulate behind. I am lifting the aorta from behind to access behind between the spine and the aorta. So you get adequate space like this. If you want to have access, you can do whatever you want. I am dissecting the opposite side from this side, the right side. I am going across the aorta, lifting the aorta to the opposite side to dissect behind aorta. This is the lumbar artery that is stretching. This is over the spine. So the vessels can be tackled properly from this side. Next one is actually from so I'm going from the right side. I'm managing a bleeding at the left lumbar vein across the aorta. This is a bleeding from the left lumbar vein, and I'm taking tissues beyond the aorta in the left side. There is a gonadal that is left gonadal that is going there, and this is the tissue between the left gonadal and the aorta, and this is the renal artery in the left side. This one. So the aim of my presentation was just to show that retroperitoneum has got adequate space to manage everything what we can do transperitoneally. The bleeding can be managed. We get adequate space to do all the maneuverabilities which we require. This is the renal vein that is exposed in the left side. I'm dissecting the renal vein and getting the vessels exposed. So basically, this is our inertia that mental inertia that retroperitoneum doesn't have any space. If you start doing, we will find that we can do a lot of things through retroperitoneum, and this is a contained space. Whatever bleeding happens, it is contained to that cavity. There is no issue with the bowel. A lot of advantages are there. We have to start doing. How I started is by doing adrenals and ureterolithotomies in the initial career. These are the two things with which we can start. Thank you very much.
Thank you, Ginel, for your wonderful presentation. But in preparation, in cases where it's complicated like RPL, do you mobilize completely to get ready for the eventualities?
So that is a good question because everything we should be preparing because RPLND, this is the post-chemo RPLND. We have to have, but what I found is I have done transperitoneal and retroperitoneal. I find that retroperitoneal is easy to tackle the vessels. Retroperitoneoscopic approach is better compared to because there is nothing coming there. Even if there is a bleeding, only vessels are there in front of us. If your adequate dissection is there, then none of the other issues is a big issue, a big problem. So we prepare all the things what is required like a transperitoneal, but approach, I find that if you are doing regularly, this is easier.
Any other questions? Thank you, Ginil, for your wonderful presentation. With this, I think we close this particular session. Thanks to ASU for giving us the opportunity on behalf of my co-chairpersons.
I thank the chairpersons for doing an excellent job for this session. I request our President Avidyapan sir to give certificates to the speakers of this session. Dr. Renu Thomas. Dr. Anant Sivaraman. Yeah. Dr. Ginil. The case discussion session, I think we didn't give the certificates. Now I request Dr. Hemana is here to come and collect the certificate. Dr. Gopi Chand. Dr. Muttu, he also left. Huh? Ganesh Kamath sir, also left. Huh? Then we'll move to the next session, last session. Or shall we take a break? We'll continue. Three will be serving. Okay. So then we come to the last session for today. That is a case discussion for the lower tract bleeding. So for the Dr. Ramalingam sir will moderate this session. The panelists for this session are Dr. Chandramohan, Dr. Alagappan, and myself.
Bleeding control பண்ணுவாங்க. Cancel. Good evening, friends. Thank the South Zone Council for asking me to do this moderation. My panelists will be Dr. Surya Prakash, Chandramohan Reddy, and Dr. Agappan. So, I have some 6-7 clinical scenarios to pose to the panelists. So, this is the first scenario. Chandramohan, can you just... this is a young lady, primary, who had a forceps delivery. Okay? So I was called in as there was a massive laceration of the vagina, urethra, everything. This is all they could see. There was so much bleeding, and two units of blood were given, and BP was slowly falling. 100/70. This was about 20-25 years ago. So that's why the clarity is like this. So you don't see the urethra, and you were called in to help out. So what do you think has happened, and how would you like to proceed?
Sir, forceps injury of the vagina and probably the posterior urethra wall along with the anterior vaginal wall might have happened. So careful inspection after coagulating if any bleeder is there. Better to take time before we do anything on this. That is the first.
Okay, they tried mopping up, they packed the vagina, and then they kept on doing for nearly 2 hours. And then only they called me when the BP was falling. And they wanted to put a catheter, they could not see the urethra.
So can I add, sir? It could be postpartum uterine bleeding also, postpartum from the uterus.
No, it was not a postpartum bleeding. The forces was, the PG was doing it. They said it went through the vaginal wall and so much force was used, and that's what I was informed. So the point they wanted me to do was to put a catheter so that they can suture the rest of the area.
Yes.
They could not see the urethra. I also searched for a while.
So
Honestly, lot of places it was peeling off and so lacerated. I tried to go from one end, right side, to keep on looking for and then picked up the posterior flap of the vaginal wall and then tried to approximate somehow, but everything is coming like a thin flake. So how do you assess the urethra?
Suprapubic we can try. Suprapubic, we can inject some betadine or methylene blue and then.
Right. Suprapubic methylene blue was injected. With great difficulty, we could find out the wall. I thought that was the original urethral opening, but that was also not there. But ultimately, the methylene blue injection helped. Anyway, you could make out, see, even after injection of methylene blue, I could sense some trickling here on the left lateral aspect of the inferior ramus. Somewhere there, some trickle was there. I tried infant feeding tube, it went in. So the urethra is so much distorted now. It's all the raw area. So what would you like to do? I put two patch in the vagina. Still everywhere it is bleeding.
Sir, one should have an access through the for the urine drainage. So generally, I am correlating with this with the last tract during OIU. Last tract during OIU where I don't have anything from below. So I have put a 7.5 by 12 nephroscope, pass a guide wire through the bladder neck. Invariably it will come out through some opening, and then take back and put something like 12 French, 14 French catheter and just come out. Don't do anything. Delayed reconstruction is the only possibility.
Okay. The infant feeding tube is already there.
If it is there,
Put a guide wire, try to put a Foley catheter.
Try to put
that
Foley.
will tell the urethral continuity is maintained or urethra is
this feeding tube drained urine with contact.
Yes. This is draining
Then,
urine. You could identify the urethra now with this.
Then a little bigger Foley's is a safer way of.
So there is avulsion of urethra also. We could not get a good length urethra to suture. Tried to suture. That was not holding anything. And is there a possibility you can do something to do primary closure? Any other way, or just put a catheter, leave it, and pack it, and then wait and watch, and then.
Yes. Delayed primary or delayed suturing better?
Okay, anybody have a different opinion? Okay. I was young, nearly 30 years ago. So thinking we could do something, reconstruction, something like that. So I tried to pack the vagina and then did a Marsh's flap, taking both the labial aspect of the aspect and superiorly based Marsh's flap, and then tried to patch up one wall of the urethra and then complete the anastomosis. But it was still distorted. We could get a thick labial fat that could bridge the raw area and get a picture like that. So it was looking ghastly only. Can never think that it can be normal, but I thought that that can be the one of the methods we can manage. So the problem is urethral loss. We could get this picture at the end of it. Large pack was left in, and the hemostasis was fairly okay, stabilized. The question is, what about the continence? Will it happen, or will you have to leave with a catheter?
Usually in such a way that if urine is not leaking, bladder neck is not injured, somehow continence will maintain.
Fortunately, her continence was okay. This is nearly 8 years after the repair. You can see the urethra on the left extreme end of it. She is able to avoid with the stream hitting on the left lateral aspect, and she is continent. The forceps which was applied in such a way, lot of tear, yes, out. Thing is, you try any area to put a suture, it gives way. Okay. This is a second case scenario. And this is a robot-assisted radical prostatectomy. And Surya Prakash, can you take this one? Yeah. Okay. Lymph node dissection was started. Thambi, it's not playing. Video.
It's playing now.
Yeah. Right side lymph node dissection started. Trying to remove as much lymph node as radically as possible. You can see the operator now. Everything looked going very smooth. All are gentle movements apparently. Suddenly you see some bleeding. So every movement looked very gentle and very meticulous by a very experienced robotic surgeon. You suddenly see some bleeding like that.
First of all,
I'm going to play it again to see. I just want you to tell me where exactly is the bleeding happening. Because only when you are sure where exactly is bleeding, then you can.
Press first.
பண்ணேன் வீட்டில் தான் பண்ணிட்டு இருந்தேன் நெட்வொர்க் டேக்கிங் டைம். Can I guess what is the possible site of bleeding?
It looks like iliac in posterior wall.
Yeah.
Maybe the scissors is
பென் ட்ரைவ் போடுறியா? பென் ட்ரைவ் கொடுத்தேன்ல? பென் ட்ரைவ் கொடுத்தேன்ல? அங்க லோட் பண்ணிருக்கியா? அங்க லோட் பண்ணு.
It's not playing, sir.
It was playing there. I gave the pen drive. Just a second. சரி பரவாயில்ல, பென்ட்ரைவ்லேருந்து பே பண்ணணும்ல. சரி. பதினெட்டு இல்லை, 18. ஓகே, இல்லை கர்சர் கர்சர் நான் பண்ண
And we'll go to next place, sir. There is no time.
தம்பி பிளேயிங்கா?
Oh, it's playing.
ஓகே. இரு. நடுவில் சென்ட்ரல் இருந்து ப்ளே பண்ணலாம்.
Central.
இன்னும் கொஞ்சம் இல்லை, கொஞ்சம் பின்னாடி போகணும். பின்னாடி. So he is holding some tissue. It has stopped. The question I have to you is, where is it bleeding? Is he doing the right thing or not?
No, unless we see it clearly, we cannot blindly suture it.
Huh?
We have to identify the site from where it's bleeding.
Exactly. So it's a blind suturing.
It's not advisable.
So what is happening is the bleeding is increasing. You will see in a minute.
Oh, they'll use a
Is it a safe method of doing the...
No, I don't think so. Because it's a venous bleed. There's no hurry. Just put a gauze piece for some time. Then we can see about the bleeding.
What is the tissue is holding?
He's holding the artery. Artery.
So usually next to the
bleeding is
obturator
increasing.
vein- sorry.
Bleeding is increasing.
Next to that obturator vessel nerve, there will always be a vessel there and a vein there, and that snaps usually when you try to go very proximally. That is probably what has happened. This is not the lower border of the.
Is it external iliac vein or
No,
something else?
It is obturator vein.
Exactly. He is trying to suture the external iliac vein. It is truly not external iliac vein. It continues to bleed.
Yes, yes.
Continues to bleed. What probably I would have done is probably keep a gauze piece, wait for a while,
Yes.
take it and see what exactly is bleeding.
See, usually in venous bleed, you advise that raise the pressure, that will reduce the bleeding. You can identify the site of bleed and then you can proceed. That's what you
In
usually tell us.
laparoscopy, generally, you can raise the pressure to a little extent. For a big rent, if you keep raising the pneumo, it will absorb and then you will end up with a CO2 embolus. That's really not advisable. Keep a gauze piece, wait for a while, slowly move the gauze piece. See one end. You can remove from proximal to distal or distal to proximal, and then see where it is bleeding. It's not advisable to increase the pressure. Somehow with a bulk suture, it has stopped. It's actually the avulsion of interiliac vein from the junction. Okay, somehow the bleeding has stopped. So what are you worried at the end?
Nothing will happen. The lumen is maintained and nothing will happen. Bleeding will stop.
Yeah, we need to see the flow.
Yes.
We need to see the flow in the axoniliac vein proximally. This is actually only vehicle suture. What is the ideal suture?
Prolene.
Prolene can slide easily.
Yes.
Vehicle will not slide.
Vehicle is not.
Will not slide.
Braided
Prolene is better. Somehow that was managed. Patient was all right. Post-operative. Alagappan, you have a question now. This is an elderly male who had a muscle invasive bladder tumor, had radical cystectomy and orthotopic neobladder. He was doing okay for 6 days. On day 7, he pulled out the Foley catheter. And you can see a lot of bloodstream fluid in the drainage tube. I generally retain the drain tube till the drain becomes 25 ml. On day 7, you see a situation like this. Abdomen distended, and I thought the drain is draining blood-stained urine, and we'll keep a drain, corrugated rubber drain in the abdomen wall also. That will also decompress, because he was having discomfort. The HB is falling steadily to 9 grams. It was 11 grams pre-op. Creatinine is slightly going up. So what is your guess?
Probably this looks like an exception. It's the pre-vesical space, the retro space of Redzius. So if the urine is draining well.
No, he pulled out the catheter.
No, the SPC, the yellow one.
No, SPC is draining little clear urine.
Clear.
But lot of bloodstream urine through the drain tube.
So the anastomosis, the neourethral anastomosis, there might be a bleeding from that. So of course, an imaging, an angio, if the creatinine is normal, a CT angio would be the next best investigation.
Will you do any imaging, or will you quickly explore? Anyone has a different opinion?
The patient is hemodynamically stable and will do a CT.
CT. That's a good idea. So I did the other way. I explored. I thought anyway it is disrupted. He pulled out, definitely urethra would have been avulsed. So I thought no point in doing any imaging, you have to see and do something. Because SPC was draining a little bit of urine. So I thought the neobladder is intact, urethra has been avulsed. That was what I thought. But do you think anyway neobladder would have given way? So there was a pool of blood, sucked everything.
Maybe because of the clot retention, this could have happened in the secondary.
There was no clot.
So then
it is
should
only
be
blood-stained urine. You can see the thin fluid only. There was no clot.
The drain was draining blood.
Yeah, this particular fluid was drained by the drain tube. And this is what you found. That's the neobladder. You can see in close, this was the neobladder. Foley was coming through that. And then on the distal end, there was some oozing coming from the retropubic area.
Space of Redzius.
I tried to feel, it was 7th day, we were not able to really feel the neobladder so very well. But this was apparently the neobladder, and I could see the suture line. The neourethra to the neobladder, suture line was there. But further tracing of the urethra was not possible. You have a bleeding from the retropubic area. So you ultimately, you are not able to see the continuity of the urethra. So what will you do? He has lost nearly 1 liter of blood and blood transfused, fairly stabilized. You have opened.
So the bleeding is controlled or still it is bleeding?
Now from the retropubic area, it is still bleeding. It's all after sucking, you can still see the clot there. Everywhere else it was blood stained urine, but in the distal moat area, retropubic area, there was clot.
You couldn't reach the anastomotic area, sir?
I could not taste the urethra. About 1 centimeter of urethra from the suture line was seen. After that, there is no continuity.
Then you can very anticate, make a small opening
So,
in the neobladder.
I could not see the urethra at all.
Through the neobladder.
No, in fact, from the urethra, why don't you try gently Foley's where it comes out, you see. That's a easy
Scopy.
Scopy or Foley's catheter.
It was like this, you could not really see the retract the
Yeah,
prepuce also.
From beginning only it is.
Prepuce also, everything is ecchymosed.
Flexible cystoscopy.
Okay.
This is where the CT angio would have helped before, sir.
Now find the urethra, how will it help? I did a pubectomy thinking that I'll be able to see the urethra. Still the urethra was not seen. That's the pubectomy. Still the urethra was not seen. So what next?
Go further below.
No, sir, we can, through the urethra, you can,
Through the urethra,
No.
try to pass a catheter from
below.
Maybe you can do a Dawson slit and then try to pass a Foley catheter and then identify. That's the idea. I did a perineal incision and then isolated the proximal bulbar urethra and then rerouted it through the, because the pubic bone was laid open. Now I could find the urethra there.
It is a cut, huh?
You make a bulbar urethra open.
Yeah,
Urethra is cut.
totally avulsed. I mean, not totally pulled out, it was disconnected at the bulbar urethra. I don't know the mechanism. Could have tried, but ultimately you have to identify the urethra to could have done. But this was about 7-8 years ago. So that's all I had in the mind. Quickly we had to explore. Otherwise he is going to bleed lot and then we are going to lose him. So somehow isolated the urethra and then we could, now with the pubectomy you can see the urethra. We did the crural incision like in urethroplasty, brought in the urethra into the abdomen. So mechanically we are able to bring in the urethra and then do anastomosis. But what about the continence?
Continents will not be there, no, sir.
Yes. So we have avoided urinary extravasation, somehow made a continuity. And this is how it looked. At the end it looked nice anatomically, but there is absolutely no membranous urethra, no sphincter at all. So this patient was counseled for neobladder. He would not accept a conduit. I didn't get a consent for conduit. I was worried whether it can be litigation. Maybe like a heterotopic, you could have put an appendix or something and could have been done. But I thought we have somehow got continuity. He will not become continence totally. He is on catheter for, he was on catheter for 4 years. I suggested, since you wanted only neobladder, the only way out is sphincter in the bulbar urethra. So he said, I have lost all money. I will not spend any more. I said, you have to live with the catheter. Every 3 months he was changing the catheter. Yes. But this, I done nearly 300 cases. I never had somebody pulling out the Foley catheter. And then avulsion. This was the only case. So he was not willing for conduit. That's for sure. At any cost, I will commit suicide. So, as Keshav said, I could have done a heterotopic and made him continent. That could have been a better idea. But I thought I'll be able to convince for a sphincter, and that about 8 years ago it was costing somewhere around 4 lakhs, so which he could not afford. So he was on Foley catheter every 3 months. He used to come for a silastic catheter exchange, but that time I tried to contact him, thinking that I can get one sphincter free from Kundan Singh. He was willing to give, but this patient said, I am comfortable with Foley catheter. I don't want to undergo another major surgery. Leave me alone. And Chandru,
Sir.
you have another one. BXO, 54 years male, had BMGU. Same evening he gets severe pain.
So something, collection leading to distension of the scrotum, either hematoma or urine leak.
So what will you do? The catheter is there. You just put incision and drain, or what?
Incision and drainage.
I'll do an ultrasound. Scrotal ultrasound.
Ultrasound, lot of clots there.
So we have to incise and evacuate that.
Done. So much of clots.
You have to
See
identify the bleeder.
the anastomotic
Usually-
area not very well seen. There is.
So you have to identify the bleeder if possible, because on the post-op day 1, there is a chance that you can identify bleeder and take a stitch.
What is the commonest area of bleeding?
Bulbar.
This is very rare. We do so many urethroplasties, so many thousands, but bulbourethral artery, if it is missed, because it can sometimes be wavered. We expect it to be behind dorsal, but it can be here and there. So in that case, bulbourethral artery can cause so much bleeding. We have to
So
find
many
where it
times
is
we
and-
try to use bipolar, then leave it, thinking that it's a very minor problem. But sometimes you come across such a ghastly situation, you have to take him to theatre back and then ligate the transfix the bulbourethral artery. So the other things we have to be aware of is, was he on antiplatelets? Many times people say, I am not on any medicine, and then the attendant will come and show some medicine. This is what I was taking. And Surya Prakash, this patient, unmarried male, had a contusion injury, blunt injury in the industry.
Okay.
He comes with acute agonizing pain and swelling in the scrotum. And we try to explore, it is a burst type of tear in the testis.
Yeah.
I tried to put a bipolar here and there, and then kept on doing it. It no way it stops.
So we can
Unmarried.
so we can save the testis, excise all that devitalized tissue, and then we can.
I tried to trim. Actually, it was very ragged edges. I tried to trim, and then the bleeding becomes more.
If you take the bites with the tunica albuginea, it will stop.
I tried to approximate, it cuts through, and then so I am trimming little by little, thinking that it will come back, will be able to suture. Edematous, it is not able to do. That is okay. But I have not got consent for archectomy. I tried, it is cutting through. It is tense. It is not coming up easily. Do we compromise excising part of the testicular tissue?
Yes, partly you can do exercise that.
Partial archectomy is an option. Maybe partial we could do. Excellent.
But before that, bleeding should be stopped, because bleeders will be small in the. Yeah, you have to ensure, otherwise it will form again hematoma.
We had the conventional bipolar. which we use for circumcision and all. Same thing. Try to coagulate it. There's so much tension. So I did tunica. Well said, Prabhagar. So keep the tunica vaginalis and then suture, and then kept a tight bandage, got away. Because we didn't get a consent for archectomy. So we had to get a consent for archectomy. Pardon? Is it? You are the right person to say.
You do not require consent for orchiectomy, but when the litigation will be there, onus will be on you to prove that it was orchiectomy was essential to preserve his health and his life. That will be the headache.
In this case, it is not that much severe that you can prove.
No, the very way it looked like some hematoma in the scrotum, we'll get away keeping a drain and all. But
Sir, this is not a completely shattered testis. This is something like a bypass in the testis, like a micro dissection. You can close it.
Kanan?
Yeah, it's just a lateral thinking. Can you try this V-lock suture in this? Can you try these bolsters which are using in the partial nephrectomy in this? See, all you need is control.
If you say...
No, I'm just thinking. It's
no,
lateral thinking, that's all.
Yeah, finer, say 3O, 4O PDS may be better, it will not cut through. But a V-lock generally cuts through. Even in partial nephrectomy, the concept is changing. Instead of a V-lock, we are trying to use quill. The fin in the quill is much friendly than the V-lock. V-lock cuts through much easily.
Okay, can you use that in this situation? Because see, these problems come once in a week, and these are lessons we are going to use in our practice maybe once in a week.
This happened more than 10 years ago.
No, it may come
Those
to me tomorrow.
days I didn't have all this. I did. My passion is for upper tract bleeding, but to Surya Prakash said you have to talk only on lower tract bleeding. I say. Then I had to dig out everything from the last 35 years for 2 months because Surya Prakash said no way.
No.
That is why I am asking everything.
No, Ramalingam, what I'm asking is, what is the take-home message if I'm going to face such a situation in practice?
If you
later?
can have a tunica vaginalis and then you get away, it's fine. Otherwise, Keshav's idea of partial excision of the parenchyma and then approximate.
Okay.
Still you have some testicular tissue, don't totally remove it unless it is so warranted.
Okay, that is the take-home message in this.
Yeah, because the vessels are intact, you don't have a reason to remove the testis.
So if we go for any partial orchiectomy or total ablation, can we preserve some seminal tissue in cryopreservation? Because it's an unmarried fellow.
Yeah, partial you can.
But still.
Normal, other test is normal.
Exactly.
I thought we will escape away from saying that I removed your testis. I wanted to, that situation, without a consent, I thought it will. Definitely.
Again, one more.
Yeah, that's an option.
Again, one more lateral thinking. Will you fix the other testis so that it doesn't go for a...
It is only injury. It is only injury.
This one is injured. The other testis, what is the guarantee that it may not go for a torsion later? So, having opened this, will you fix it?
I don't think that is warranted because this is injury, so I won't, I didn't think of it. Okay, Alagappan, your turn. Keshav, can we go for the next one? Alagappan is going to discuss on this one. It's a huge prostate. PSA is 2.1 only, void inlets, and it's more than 100 grams prostate. Someone is doing a HOLEP. So will you go for
someone is doing, sir. I don't do HOLEP, so someone is doing. Yes, please.
Okay. Will you will go for open?
No, sir. I would approach this with a staged TURP.
Okay.
Anything more than
anyway,
100 grams.
Someone has started the HOLEP. It's all bleeding everywhere, and the vision was so poor. unable to proceed beyond this one. Kept a catheter, applied traction, waited for half an hour, and then go in again. Again the same bleeding. Procedure incomplete.
Did you use monopolar coagulation with the button, anything, just to come out for that stage? Instead of using laser. Laser coagulation is really difficult if it is multiple areas.
Its whole area is dark and then unable to see where exactly it's bleeding.
Bipolar or monopolar, whatever button. High current, high frequency current. Next option is open.
So put a catheter, give traction, see for some time. If
Yeah,
it doesn't
he-
control, then go for open.
Applied traction with a Foley catheter and waited for a while. Okay. So how many will open? Okay, that fades to open. Okay, that's what.
All the seniors are quickly telling open. We have to take the opinion from the juniors because they might have not opened once also. All seniors are quickly telling open.
So ultimately,
yes, sir.
no, you are always little ego, no? You say that I will do it with the whole up and then try to coagulate. No, he didn't continuously try to coagulate. He put a Foley, gave traction.
So
And then,
prostatic artery embolization can be tried because for elective cases they
The
do.
obstruction may not be a factor,
prostates, it won't
but
succeed. Multiple arteries
temporary
will be there.
traction for a while, whether it can stop bleeding, then go in again and see. So you see, ultimately came back to bipolar coagulation. Yeah, the video is not playing. Thambi, video play agma. He got away with hemostasis with little struggle and could get away. So the last one to Chandra again.
Sir.
Thambi. அடுத்த ஸ்லைடு ஹேங் ஆகுது. Does it say wind up? Santosh, is it saying wind up? The last one. Yeah, I think, this is the last. I just wanted to thank people who have given the thing. This video is not playing. The moment you put the trocar, it is trickling, continuously trickling. And the video play pannappa. That's one more to last one. Continuously it's trickling. So will you do this or will it be useless one?
Sir, if it is very thin abdomen like children,
It's a child.
precisely you can take this. But any adult abdomen, this needle will not go inside and come out again. Sutures on both sides can be put and then pull out.
So the other technique is you temporarily, if you want to take time, put a Foley catheter through this one, inflate the balloon, pull out the trocar, keep it for a while, and then put another trocar from different area, and then you can suture from inside.
Inside suture.
Actually, you have to look at the inferior epigastric vessels, and you can take a reversed bite and then suture. The last video, Thambi? Yeah, it's playing. Another situation. If you put a port at along the course of inferior epigastric, you have to be very careful. Nice one.
Almost like urination.
Yeah. Inferior gastric. So what do you do first?
All the ports should be quite opposite from the epigastrium.
Exactly, diagonally go to the opposite side
side, so
and
that's
then
from
put a port and then you try to do what
surgery, sir?
Anant has shown the Thomson cotton needle. That is the temporary solution. But I had seen one situation in one of the workshops in Cochin. Dinil, do you remember? Once when Alavat was doing a partial nephrectomy, he finished in 1.5 hours. But the the superior epigastric was bleeding very badly. He had to open and then find out where exactly it was bleeding. That took 1 hour. So when you try to put an additional trocar, rotate the camera 30° up, see where exactly is it coming. Sometimes you may get clue, sometimes you may not get clue. But try to avoid that area. So thank you, Surya Prakash.
Thank you, sir.
And the
Thank you very
council for making this happen. I'd like to acknowledge the people who have given their videos. Thank you, and all.
Thank you, sir. Nice video, sir.
இது என்னதா? ஓ, என்னது?
Thank you very much, Ramalingam sir, for nice case discussion. So, sir, please accept a certificate from President sir, Ramalingam sir. And other panelists, Dr. Chandramohan. Photo. Great, sir. Wonderful. Dr. Alagappa. With this, we come to the end of our scientific program. I thank you very much for staying back till the end and participating actively in the discussion. Now we come to the valedictory function. Where is sir? Yes, Sir Kannan sir. Yeah. Sir.
I would like to request the organizing chairman to take the stage, the ASU secretary, the ASU president, and myself, being the joint secretary. I would like to, Devanathan said to have few words.
I think all of you are already tired, and I think the program from morning till now must have been very useful to you. All the speakers have done the job very well. I'm fairly certain the take-home message will be quite a lot. And to recollect, you should start recollecting from today night itself, otherwise you'll start forgetting. There are so many things and so many doubts we might have had before. And after attending this particular workshop, I am fairly certain that many of your doubts would have been cleared. We have also given the feedback form to all of you. I am sure many of you would have filled up the form, and you would have also given the feedback about this workshop. The purpose of this feedback form is to go through it, study it, and to find out the areas where we can improve for the next conference. To tell you in short, the persons, without mentioning overall all the colleagues of the Trichy chapter of Urological Society of India have contributed to this success of this conference. We were fully guided by Dr. Krishnaswamy Kannan, who acquired the experience of being associated with the association for a longer period. With his experience put into practice, we were put into correct track and got everything done without any problem. And it was his ambition for a long time. And to support him, he has our President, Trichy Chapter, Rajesh Rajendran, and Secretary Alagappan. And all the members have contributed to the extent possible from their end. I am sure many of you would have enjoyed the breakfast and lunch and a small tea in between. And the Dean was very kind enough to give this particular hall a unique one in a government setup, wherein we had a lot of space available and could accommodate easily about 96 delegates, and the lunch could be served in the right opposite. With all the facilities, I think we have had this conference very successful. I once again thank all the delegates who have participated and made this a conference, a workshop, a successful one. I request all of them to make another visit to Trichy. If you have missed anything in this, and we will have some more conferences in future in Trichy, and whatever mistakes you have found in our organization, can bring it to our knowledge, we will correct it and then make it all right. Wishing you all the best and a very happy stay in Trichy. Thank you.
I'd like to say the ASU Secretary to say a few words.
Thank you, Dr. Alagappan. It has been a fantastic day right from the morning, and I was a little worried in the middle that we were going very late, and finally we could make it in time. I would like to thank the organizing team. You have done a fantastic job. I always was in two minds, Trichy Medical College, how will the facilities will be, whether we will be able to do it properly or not, but it went beyond the expectations. Sir was, every minute he was monitoring. He said, I'll be a volunteer. That's I think my mind was blown off when he said that I'll be a volunteer for this program. So he was meticulously monitoring everything, right from food to the who is coming program and all. And Dr. Rajesh and Dr. Alagappan, under his guidance, they've done a fantastic work, sir. Entire your team needs a big appreciation, sir. Regarding the scientific program, Dr. Ginil and Chandramohan really helped me. We sat 3-4 times in deciding the topics and the faculty, and I thank all the faculty for accepting our invitation and coming all the way. Initially, they were asking for whether it would be hybrid meeting and all, but still they came all the way to Trichy and delivered very excellent talks. It was very informative. And even the audience, the delegates, I thank everybody for their active participation. Though we overshoot in some talks beyond the time, the interaction was good. Every talk was followed by some good discussion. So that's how the meeting has to be. And I thank my president, Avudiyappan sir. He's always been very supportive. And any decision I said, okay, go ahead, Surya, he says. So thank you, sir, for all your support. And thank you very much for everything. Thank you, sir. Thank you.
Oh, last but not the least, this is the vote of thanks. Please, before leaving, please leave the feedback on. Oh, floor with feedback. Yeah, please volunteer, please.
I think what I say will probably reflect what everybody is going to say. At the outset, it's very pleasing to see the team in red. The wholehearted involvement of the whole city chapter in the whole thing, right from the way communications was sent by Dr. Rajendran. Almost every day he was virtually, for the last 1 month, he's been sending about communication about the program, the accommodation, and the way the whole day structure of the program is gone on. It's wonderful. And the scientific content that Surya has created is also very nice. And the peak for me and a few of us 25 of us who went in the bus today was thanks to Mrs. Deva and Vinod. It was a wonderful morning session we had before the session started at the temple. And sir, convey our gratitude to madam. And it was a CME for us on Hinduism by Vinod. I was really surprised at the depth of his knowledge on the various aspects, and it was very entertaining for all of us. And Dr. Kannan, all of us who have worked with him in different councils, knows how meticulous he is in dotting the I's and dashing the T's. Dr. Kannan sir, hats off to you. Wonderful job. And the whole team, it's gratifying to see the whole team together. And it's always said that it's not the machine, it's the man behind the machine that matters. Avudiyappan sir, congratulations on the first program under your leadership. It's a great affair, and it's promising that the ASU is going to go leaps and bounds. Thank you so much, sir.
I would like to invite the ASU president to give the closing remarks.
So it's my privilege to honor this seat and honor the midterm workshop in the name of Professor H.S. Bhat. It's really very, what shall I say? I don't have words to express the feelings I do have. It's really very promising one. And thanks to Dr. Rajesh and Dr. Kannan, who are in constant contact, as Dr. Ramesh has told. They were going on sending messages after messages every day. You see one message, followed that, few messages are waiting for you to see. So, and the perfection, I'll say. Kannan is a perfectionist, everybody know that. And Avan Indri Anu Masaya, no. Without him, I think this program we don't know what is the procedure next to be done. And everything is in paper, black and white, printed out in good formats. And thanks to all the faculty members who have taken all the stress and strain of coming down here and then preparing and spending their weekend holiday in Trichy. And we never felt it is a holiday for us. It looks like a working day for all of us. And it's my duty to announce the next ASU 11th H.S. Bhat workshop. It will be by Dr. Balagopalan and his team at Rajagiri Hospital, Cochin. So I invite you all for the next H.S. Bhat workshop at Cochin. to be organized by Balagopal. It's a topic yet to be decided. So topic will be decided. Which one? Oh, pediatric. Okay. And even this program of bleeding, bleeding in urology was Kannan's brainchild. He was telling to me for the past year because I had been a council member earlier. From that time onwards, he was going to tell, and they wanted to conduct a Trichy. So I said, you skip this year being a virtual platform, we'll give you the next year. So this year has been allotted for them, and they've done a wonderful job. Thank you all. Thank you all.
So the program concludes with a small speech. I will not take more time. Just to say a word of thanks. Sometimes thank you is not enough. Thanks to the opportunity to the ASU to give this opportunity for Trichy to conduct this midterm conference. Of course, the overwhelming response from the audience, that is the most important thing, the largest number of registrations, which made this probably a success. And of course, content is the king. Without this scientific committee, orchestrating a beautiful scientific program, which is very useful in the day-to-day practice for urology. So bleeding in urology was a very nice topic chosen, as well as executed by the scientific committee. And next, I would very significantly, macroscopically thank Dr. Rajesh for his major contribution in this bleeding control. And the microscopically, I would thank for Kannan sir, because he didn't leave in RBC level. So, so the next is, of course, the support, the technical support. A special thanks to the Aishwarya Hospital team, the hospital staffs who did an excellent support in all the services. Of course, food is the most important thing, because even whatever we say, however we treat the patients, at the end of the day, they are satisfied only with a good diet chart. So the same way, I hope the food was better. Thanks to Dr. Vijay Kumar, who had taken meticulous efforts in designing the menu and all these things. It was a homely menu, probably. And of course, I would like to thank the college, the dean, the VP, the vice principal for this conference. It's not a luxurious conference hall as we suppose. It was, I think, probably it was a basic enough, which was sufficient to provide all. Thank you, sir. And of course, audiovisual aids. It was the first important, it was economic, it was effective, and it was very elegant. Thanks for the audiovisual team. And of course, the best thing about memories is to make them, of course, thanks to Dr. KNS sir, Srinivasan, Dr. Uma madam, Uma Devanathan sir, and Vijayalakshmi Krishnasamy Kannan sir, and coordinated with Dr. Vinod for the Srirangam visit, which definitely will carry over the memories for a longer time. So, of course, at the end of the day, we would have, doing a surgery, satisfied surgery is most important than a successful surgery. So, to err is human. We have attempted to do something, and sorry if we had left you in certain areas, or if you had left few names, if you have felt bad in certain areas, definitely maybe the next time we'll come up with a better way. So, of course, this is not the end, it is just the beginning. Thank you. I would thank the whole Trichy team to making this program a successful thing. Thank you.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
நீங்க